Assalamu alaikum. We shall begin the session in another 10 minutes. We are waiting on a few people. So 10 more minutes, sorry. Assalamu alaikum, and a very good morning to all of you. I am Dr. Faryal Sharif, an FCPS consultant dermatologist, currently practicing at Institute of Skin Disease in Karachi, and I shall be moderating this very interesting session today. On behalf of the whole team, I welcome you on the second day of PADCON, the 41st PADCON, and without further ado, we shall begin our session with recitation from the Holy Quran.
बिस्मिल्लाहिर्रहमानिर्रहीम। शुरू अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम वाला है। इन्ना अअतैनाकल कौसर। ऐ मोहम्मद सल्लल्लाहु अलैहि वसल्लम, हमने तुमको कौसर अता फरमाई है। फसल्लि लिरब्बिक वन्हर। तो अपने परवरदिगार के लिए नमाज पढ़ा करो और कुर्बानी किया करो। कुछ शक नहीं कि तुम्हारा दुश्मन ही बे औलाद रहेगा। सदक़ल्लाहुल अज़ीम।
So ladies and gentlemen, today's session comprises of some very interesting talks of both international and national speakers. So I really hope you pay attention and have quite enlightening sessions today. So let's proceed towards opening our session, and I would like to invite a respectable chairperson and panelists on stage. So today's session shall be chaired by Professor Ijaz Hussain, who has joined us from Lahore today. He is heading the Department of Dermatology at Mayo Hospital and is also serving as a Pro-Vice Chancellor at King Edward Medical University since 2018 till date. Sir has also been the president of South Asian Regional Association of Dermatologists in 2018 and 2019. He has also been an editor at Journal of Pakistan Association of Dermatologists and has over 108 publications to his name. He has trained as many as 49 postgraduate students of FCPS, MCPS, MD, and Diploma. Sir, we are so honored to have you here today. Can you please come on stage? Thank you so much, sir. So moving on towards a respectable panel of panelists, I would like to invite Professor Khawa Khurshid today on stage, who has joined us from Lahore. He's heading the Department of Dermatology at Rashid Latif Medical College, and he's also an esteemed supervisor and examiner of College and Physician and Surgeon in Pakistan, and he's also been my examiner in my FCPS exam. So we are very pleased to have you here today. Thank you for joining us. Please come on stage. Thank you, sir. Our next honorable panelist is Professor Faria Asad, who is heading the Department of Dermatology at Services Institute of Medical Sciences, Lahore. She has also served as an editor in Journal of Pakistan Association of Dermatologists and also as a vice president of Punjab Division of Pakistan Association of Dermatologists. Ma'am, can you please join us on stage? Thank you very much. Our next panelist is highly esteemed Professor Jameel Shaheen. He is the Professor of Dermatology at Quaid-e-Azam Medical College, Bahawalpur. He is also the Regional Director of College of Physician and Surgeon, Pakistan, Bahawalpur. Sir, can you please join us on stage? So a fourth panelist is Dr. Rahim Bangash. He is an associate professor at Hayatabad Medical Complex, Peshawar. He is also an esteemed supervisor and examiner of College of Physician and Surgeon, Pakistan. Sir, we welcome you here today. Please join us on stage. Thank you. That is a lovely panel of most esteemed dermatologists in the entire Pakistan. So now, proceeding towards our session today, I would like to introduce our first international speaker of the day, Professor Babar Rao. He is an acting chair and a clinical professor of dermatology and dermatopathology at Department of Dermatology, Rutgers Robert Wood Johnson Medical School. He is also an associate clinical professor of dermatology at Weill Cornell Medical College, along with being the president and founder of non-invasive diagnostics in skin, and particularly his interest is reflectance confocal microscopy. Today, he shall be talking about something which has given us a lot of problems, even though the disease is very simple. So it's new and true in melasma and vitiligo. Sir, can you please join us on stage and begin your talk? Thank you, sir.
Thank you. Assalamu alaikum, everybody. And Friyal, thank you for bringing me here. And Baki jo organizing team hai, Sari Sadia and everybody else, thank you. I seriously believe that I don't know more than the panelists here in vitiligo and melasma. But I'll share what I know over the years about pigmentation, hyper. And also, many of my friends are here from my dermatology childhood time, like Ibrar, Azhar, Kadus, but many Azim is here. So I'm really happy that basically it's not a lecture. I'll share what I know, and then we'll just make it interactive. So I do many things, as you know. My passion is skin pathology, dermoscopy, that area. But like all of us, to make some revenue, I do everything else. वो control करेंगे मैं करूँगा slide. Can I have the control, please? अच्छा, ठीक है, laser की जरूरत नहीं. So this talk is not sponsored, but I must declare that I'm a speaker for Insight, जो के cream बनाते हैं absolura vitiligo के लिए. But the talk is not sponsored by them. This is sponsored by you guys and me. So obviously this is Ibrar, I was checking the #1 prescription in the world are written for pigmentation. if you calculate India, Pakistan, Sri Lanka, and all those countries, so #1 prescriptions are for this. Now, what happens via melasma or hyperpigmentation? Last time I was giving a lecture in somewhere in Middle East, and I was calling it melasma, 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 and somebody started yelling, this is not melasma, this is hyperpigmentation. So I'm lumping it together, hyperpigmentation on the face. Obviously, there are fellow residents here. They must know what happened physiologically. But we knew that sunlight has something to do with melasma or hyperpigmentation. And we also know that there are other factors like injury and trauma which can do that. But more recently, we are also convinced scientifically that visible light can also make melasma worse. And how it happens, I'm not here to teach you, but for residents and students, if they want to know the mechanism, this is the pathway. As you start treating melasma or hyperpigmentation of the face, the number one thing you all know is to determine if the pigmentation is just in the epidermis, dermis, or both. Otherwise, you will be wasting your time if you start treating without knowing that or without thinking that. So if it's in the epidermis, so obviously you can blow it off with many, many things, from chemical peel to lasers to hydroquinone and all that. If it's in the dermis, then it is difficult how to treat it, so keep that in mind. There'll be different things. And how do you tell that? You all know, you can clinically just look at it. If it's bluish, it is little grayish, then it's dermal. If it's brown, or that, it's epidermal. But there are tools like Wood's light and other tools to basically see where the pigment is. Now, anything you want to do, especially if you want to write a paper about it, then you have to go objective. So how do you tell how much pigmentation is there? There are various ways to calculate that. You all know that there is this thing called melanin index score and also the Massey score. So basically, if you are going to treat it objectively, especially writing paper or teaching students, it's good to calculate this area. How to do that, you all know that, but basically I wanted to put it out. Melanin index score and melanin area severity index. As we go into studies a little bit later, some studies, especially there is one of the studies we'll quote later on, they will just talk about Massey and non-melanin index. Others will talk about melanin index and not Massey. Whatever suits a study, they use it, but it's good to look at both things. You all know these, what are the treatments, like from hydroquinone to triple combination to tranexamic acid to cysteamine, and then, newer things like azelaic acid, kojic acid, all of those. So these are various things we'll be discussing slowly, but nothing new to teach you here. Then also there are now drugs, like you can use oral tranexamic acid, and some of them are summarizing here from various studies. So tranexamic acid obviously gets used a lot more in Asia than our part of the world, and it has, like all other treatments of pigmentation, high rate of relapse after discontinuation, as high as 72%. Some people use oral isotretinoin and have some success with it, especially in the dermal part or epidermal combined melasma. This polypodium has a lot of chatter in previous year, but some people use that adjunct with other therapies. And then vitamin C and E. So there is a lot of buzz. There is, like, we were looking at it, how much vitamin C products are sold in the world in a year, so billions of dollars. But if you really go into it and seriously look at objectively, the evidence is very small. They do anything. In combination, they help, but if you just keep using vitamin C and E, they may have some improvement on their own. Evidence is not that great that they do something magical. Continuing further a little bit on procedural type of melasma, so chemical peels, glycolic acid, salicylic acid, TCA. There are some studies which have obviously good outcome, but most of them would result or can result in post-inflammatory hyperpigmentation. And many years ago, I was giving this talk, and somebody asked me, so any of these medication will work. The trouble is the moment you treat pigmentation, it's going to come back. And so what we're looking into it here in discussion, like, okay, what can we do so that it doesn't come back, or if it comes back, it's not that bad. So people have started merging other things like microneedling with it. Other than these, you can do microneedling. And then also there are studies now using intradermal tranexamic acid at this dose. And then lasers people try in these pigmentation story, but most lasers can work, but again, high rate of relapse, and especially in darker skin type, and that's where the pigmentation is. And in Asia especially, they tried IPL for just epidermal pigmentation with some success. So what is then, is there anything new? These are all things you know. I'm not teaching you anything new, but so what are any updates, if so, in reference to that? So photo protection, obviously we thought if we do block UVB and we block, then we can stop some pigmentation, but now we know that visible light also have a role. We now there are studies which we'll quote in a little bit, like if you just protect from sun with a blocking cream or otherwise, that can itself prevent pigmentation. I think it's good to add in a maintenance regimen as you treat them with hydroquinone or anything like a laser in between, and for the long duration when they are at home, it's good to use some cosmeceutical, and there are many of them. And then lasers, obviously we've been talking, can they help or not? So going into this study is this is the group which in America we have a society called Skin of Color Society. This is all skin of color, but we have a society there. And these are the leaders of Skin of Andrew, Susan, all of them. They are specialized in pigmentation. So if you're talking about hypo or hyperpigmentation, usually these people pop up in many of the papers. And here have the misconception of skin of color about the photo protection. So, sorry, my pointer thoda sa ruk jata hai, I'm trying to, okay. So then based on the study, these are the recommendations for the use of sunscreen. Daily sunscreen protection is beneficial for all skin types. The type of sunscreen should be adapted both to skin phototype and to extent of the daily sun exposure. Protection against UVA wavelength is also important, as I've been mentioning. For skin type 4 and 5, broad spectrum sunscreen with SPF 30 or above should be recommended. Tinted sunscreen which contain iron oxide, they also protect against visible light, so should be considered. Huh? Is taraf karenge? Acha. Oh, okay, sorry. Okay. So then again another study by Henry Lim, who is the guru of photo physiology in the United States. Impact of visible light on skin, the role of antioxidant and the free radicals quenchers in skin protection. Now I know. So basically, other than, this is from his study from the paper, like other than visible light, so when visible light or ultraviolet light hits a molecule, it gets excited and there are free radical and there is then damage to the skin. If you then also add antioxidant here at this to the injury will be less. So this is a study from that paper where they did here is like there are like 4 groups here: untreated patients in the first line, and then with SPF 50, SPF 20, and titanium dioxide, and then SPF 50 and antioxidant. So what study shows is basically if you add antioxidant and titanium dioxide, the pigmentation here after 7 days is much less than starting here and here. So other than sunscreen then, adding antioxidants and taking care of visible light by blocking UVA, you will have better results. Then this is a very interesting study where basically they followed these Hispanic female with their skin color is exactly like us or a long period of time, and they observed just by giving photo protection by block sunscreens, their pigmentation got better just by photo protection. So here we are showing here in this group like with or without sun protection, and you can tell clearly that if they were using sunscreen only, no other treatment, the pigmentation in histology and clinically got better just over a long period of time just by using sunscreens. So then there is a lot of buzz about this new cream, Histamine. You probably all know. When it came, it was like, wow, it'll probably solve the world problems, but actually it's okay. So there is this comparative study where they combined hydroquinone with ascorbic acid versus the Histamine 5% cream in the treatment of epidermal melasma. So this is the hydroquinone group on the left and Histamine group on the right. And important thing is, in the study, both groups have a significant difference in the pigmentation. Let me go back. But the difference between Histamine and hydroquinone group was not significant at all. So both groups worked. So if there is no convincing reason that Histamine is better than hydroquinone alone, so you can use both of them depending on which patient. Then the lasers. So in cases where your hydroquinone, tranexamic acid, Histamine, or whatever else you are using, it's not working, or it's working a little bit, in those recalcitrant or difficult cases, you can definitely add laser, especially a fractional type of laser. They do less damage. And there are, but remember, you're not going to do laser for ordinary melasma because it will relapse, it will get worse, and so keep that in mind. So if your other therapies are not working, then yes, add laser to the therapy. So here is the study where basically patients who had a laser and without laser, you can say in these difficult cases there was definite improvement. So in summary then, just talking about hyperpigmentation, I did not discover anything new like what you guys know. But there is an approach to it. We can summarize that way. You can use hydroquinone triple combination, usually the best cream for now in the world, triple combination. Obviously, you don't want to use hydroquinone maybe more than 6 months. Then if it goes beyond that, then consider ordering non-hydroquinone such as azelaic acid, topical retinoids, or cosmeceutical. Definitely consider protecting them from both UV, ultraviolet, and visible light. And then in difficult cases, consider adding chemical peel, lasers, microneedling, or oral agents. One thing for sure, whatever you do, you will improve it, but you will have to treat it like diabetes or hypertension. When patients ask you, okay, so it's coming back, do I have to use creams all my life? Yes, they have to. There is no solution. Like I say in diabetes, hypertension, you use medication for the rest of your life. So yes, we'll fix your pigmentation, but you have to use sunblocks and maybe some other cosmeceuticals, vitamin C, whatever you use to maintain it. sorry, it's going back. So this was the study I was quoting. If you just use sunscreen or sunblocks, you can improve the pigmentation. So going to my next slide, so that was new, like what were the studies I was quoting. But what really is true is, I think the best method so far is just cover the face and there will be no pigmentation. So that is the best message I can give. Obviously, if you have a sensitive skin, you keep getting melasma or pigmentation. Whenever you're outside, I hate sunscreen. They are like messy, oily, greasy. So if you can, and you are in an environment where you can, just cover the face if you have pigmentation and you'll be fine. So I think I'm going to go to the next part, which is vitiligo. But in the meanwhile, I'll take some questions from the audience if they have any. Any questions on pigmentation, hyperpigmentation? Then we'll go to hypo or G. Azim, yes.
In those countries where there is 100% cover faces.
Yeah, so I think this is a good study to do. There are like small anecdotal reports from Middle East here and there, but there is no long-term study, जो कि 1 साल या 2 साल की गई हो. I think it will be an amazing study, and if any of the residents can do it, Ibrar and Azim, and we can guide you guys. Yes. Ji, Ibrar from. Ji, नहीं आप पहले बात करें जी.
Dr. Tahir, some female patients, particularly housewives, they have noted that their pigmentation increases during cooking. And if they avoid cooking, their pigmentation or melasma, it tends to decrease. Is it true? Has it been observed? Or if it's true, then what's the explanation for that?
मुझे सही से आपका सवाल समझ नहीं आया, sorry.
कुछ ख़वातीन कहती हैं कि वो जब कुकिंग करती हैं,
जी जी,
जिन दिनों कुकिंग कर रही होती हैं तो पिगमेंटेशन बढ़ जाती है.
जी जी.
तो क्या ऐसा पॉसिबल है हीट से?
I think it's very possible. Other than visible light, I think heat itself does something, like a physical trauma, and it is true in cooking. Housewife or house husbands, they have more pigmentation. Yeah.
Thank you.
Ji.
Assalamu alaikum, Dr. Mariam. I want to ask about pigmentation demarcation line. Pigmented demarcation line. What is the treatment of it?
Well, that's like, they are more like stable situation. So I think in those cases, probably you have to consider some kind of laser, if you have. But it's very hard to treat usually. So you can try a laser, you can try a chemical peel, but they're hard to treat. Journal Saab had a question. Ji.
Do you have any experience using face washes with glycolic acid and other things?
Yes, so as I was saying, when you treat them hydroquinone or whatever else, but for the home remedy, I like glycolic acid, adding in their daily cream jo laga rahi hain. Ji.
I'm sorry, I just came late and I saw the slide of
That's okay.
carbon dioxide laser showing for the treatment of melasma.
Ji.
Do you think that, especially in the Asian skin of color, does this fractional CO2 laser helps in alleviating the problem?
Ji.
Because my experience is rather getting more of a post-inflammatory hyperpigmentation after doing
Ji.
So what's your experience? I didn't listen to the part.
Yeah, so the experience really is, I was saying, so initially, any pigmentation, the #1 choice, scientifically proved, is hydroquinone in a triple combination, jo hydroquinone ki hoti hai. If that doesn't work, or if it works, then we go to second choice, is jo ke transamic acid and other things, histamine and the newer things. But either way, you will fix it initially with hydroquinone or some other cream, or maybe with a little bit of a laser. In between, it's a maintenance therapy for rest of the time, for many years, the rest of their lives. Usme then, you'll use lighter agents like glycolic, abhi kisi ne mention kiya, or vitamin C, or creams with a C, jo ke uski daily maintenance zaruri hai. Otherwise, so we tell patient, okay, I'll improve it, but you have to use visible light, sun protection for rest of your life, and some cream to make it better every day. Jaise diabetes ki karte hain. Ji, Azim. question, maybe I misunderstood. Ji. Please, please. Everybody knows Azim. He's in Lahore, a good friend. He knows as much as anybody else knows in the world. Ji.
My humble observation is that if you do CO2, which is notoriously known to produce heat,
Ji.
that can cause hyperpigmentation.
Yes, yes.
If you space out the thermal zones, which means that if you decrease the density
Ji.
and decrease the intensity, means joules,
Ji, ji.
then it may be reasonable. But the better reasonable choice will be to have erbium glass laser, which is 1550 nanometer, so which is classic Fraxel rather than Fraxel Restore.
Yeah,
so if you use Fraxel, which is erbium glass laser, which is 1550 nanometer rather than doing 10,600 nanometer, the CO2 one, that is better. And probably the most data that we have on lasers come from Far East, especially the Korean population. There they use very, very low intensity ND-YAG laser, and in my humble observation, they have the largest series. And if you lump them together, I think they have the largest data on the low intensity, very, very low intensity, like 4 or 5 joules of Q-switched ND-YAG laser. So that's where I think the status of affairs is today.
Well, thank you. Anybody has a comment? Or Faryal, how many minutes do we have for the next session? Where is Faryal? We are okay? Okay. Ji, please, please.
Assalamu alaikum. My name is Dr. Abdul Majid Baledai. I belong to rural Sindh and flood affected. Sir, my question is very interesting for hyperpigmentation. That, sir, mostly we are practicing in rural areas. The people or women, they always say that why hyperpigmentation has selected the facial area? Why not other parts? Although exposed areas are so many anatomically, even hands, chest, scalp is also available. Likewise, that why it is not going to affect? Only it has selected and victimized the mostly the female bechari. Baki jo hai males, they are deprived of that.
Okay, let me understand. The question is, why do they have more on the face? I think if you see some skin cancer in an area, the most sun damage is on the nose and the face. So just squamous cell, basal cell, actinic damage, sara face pe hi hota hai because it's most exposed. Although you can get it on your hand, but this is the most exposed area. That's where you'll get it. Ji, Ibrar wanted to comment. Ji.
No, great talk, Professor Rao. Just a quick question, a reminder for the residents in the room. If you talk about photoprotection and trying to protect against sun exposure, it'd be a responsible thing to do to also check for vitamin D levels and supplement D, because especially the females who are very, very prone to being very careful in the sun, as they become postmenopausal, risk of osteoporosis goes up. So any comments about that? Maybe you can start off a new study here, a project, to test vitamin D and supplement vitamin D.
Yeah, so there are small studies for vitamin E and those things, but evidence-based. So what do I mean by evidence-based? मैं कौन होता हूँ कि मैं evidence decide करूँ? So there is, in JAMA and Archives of Dermatology, and other countries have it too, there is a way to tell that a study is not ethical, is authentic or not. So basically you have to be double-blinded. It has to be enough cases. It has to be non-sponsored. And then the conclusion you're making has to be relevant to what your study was. So when I say evidence-based, there is a way to tell grade 1 study, grade 2 study, grade 3, in reference to E, D, C, none of them qualifies for grade 1 study, but it's in a given case obviously be useful. Ji, aap bataएं.
Sir, I have two small questions. Dr. Munazza here. So first is regarding hydroquinone. In my experience, most patients develop allergic reaction. How to deal with these reactions? Because due to hydroquinone, they ultimately stop using this medicine.
So they develop redness, you mean?
Yeah, sir. Erythema, redness.
So that some people do more than others, but I usually, in my practice, which is not now evidence-based, if they're having redness, I usually tell them to use it less. Don't use it every day. Go with 3 times a week and then slowly increase. But in some people, it's so bad that they have to stop it. They have a lot of redness.
Number two question is regarding the use of laptops and mobile phones.
A
lot of patients, they are using regular sunscreens, but due to this technology use, their melasma is very refractant to treatment. So what's your opinion, whether it's a basic etiology of these mobile phones as well?
I think they're individual based, but when you are now advising sunscreen, make sure if you can, it should be broad spectrum, jo main baat kar raha tha, and then if you can add other things to it, like antioxidant vagara, definitely the effect is much better.
And they should be using sunscreens while indoors, while using the gadgets as well.
जी.
Thank you, sir.
जी. So, जी कोई पीछे, जी बताएं, जी. मुझे समझ नहीं आ रही
जी डॉक्टर ताहिराओ मैं पूछना चाह रही थी कि व्हाइटनिंग इंजेक्शंस के बारे में थोड़ा सा बताइए क्योंकि ग्लूटाथायोन इंजेक्शंस का बहुत इफेक्टिव रहा है मेलाज्मा में बट हाउ सेफ इफेक्टिव एंड एथिकली करेक्ट इज दैट
सो इट इज इफेक्टिव but I think if you read the studies it can still come back, but the trouble is glutathione जो melanocytes हैं जो ये और body के they are in the brain, they are in the air, they are in the heart, they are everywhere else. So we don't know what is happening to those sites. In the long run, it is not at this point known that it is safe internally other than the whitening part, but I think it works. It's not approved in our part of the world. हम नहीं कर सकते वहाँ पे injections, neither do I promote, but I think it definitely works. And if you are a good doctor जो कि उनके CBC वगैरह check कर रहे हैं तो I think it'll be okay. But the data wise in the long run क्या होना है we don't know कि क्या होना है. But we don't know about many things के क्या होना है. जी. जी.
कैंसर के मरीजों में इंटरेस्टिंगली अमेरिका में
they can do anything.
us knowing वो आईवी ड्रिप्स जो हैं वो बहुत सारी चल रही होती हैं. खासतौर पे आपके न्यू जर्सी में एक पूरा सेंटर है जो कि अल्टरनेटिव मेडिसिन का सेंटर है. तो बिकॉज आई वाज लुकिंग फॉर माय मदर व्हेन शी वाज सिक, तो वो सुना था कि वहाँ पे वो आम देते हैं.
There are no clinics. They only do IV or IM injection. This vitamin E everything. Even in most of them are not run by dermatologists. जो other internists and primary care doctors are there running like an infusion center, but there are many of them. But it works. Definitely it works. Ji. So I think I should maybe go to the next part, which is vitiligo. So most of you know what is vitiligo. And most of you know it has types, like it could be segmental or non-segmental. And it could be also this acromion type, small dots. And it is a common condition, 0.5 to 2% worldwide, and very common in India. And there are like lots of cases in the world. So me and my fellow Samavia here, and my other fellow too, that we basically spent some time try to simplify the mechanism of what happens, how melanocyte may get destroyed. So we took pictures from here and then put this together for resident and student. Ultimately, there could be an intrinsic problem with melanocyte. They are weak, they are genetically weak or abnormal or something. Or then there could be then immune response either way, coming from this side or coming from this side. Eventually, melanocyte get destroyed, and then there is no pigmentation. We'll go into further detail. Important stuff to know is CD8 positive cell or the destroyers, interferon gamma, and this gene CXL9 and 10, which comes from keratinocytes. So having said that, iski residents extra, you can take photo or take a copy from Faryal. So then going a little bit further into it, there are newer medications nowadays, which are, I will go through that in a minute, they work at this point. So initially, immune cell activation due to chemical, UV radiation, visible light, or anything like that. The immune cell get activated, and then we have CD8 cells production, and in turn then through interferon gamma we have production of the CX9 and 10. Then CD8 lymphocyte, this way they can go into the melanocyte and destroy them and produce vitiligo. So the brand new medication called Absolura that works at this point, blocks this chain. We will talking about this in a minute. So clinical course, most of you know, it could be a non-segmental vitiligo, and it could be the way you tell is if the disease is progressive or not. So what is the definition? Let's go to the stable vitiligo first. The definition of stable vitiligo is no change detected by serial photography or clinically in a 12-month period. So एक patch vitiligo का अगर वो change नहीं हो रहा, in a year we'll call it stable. What is a progressive disease? Usually this is non-segmental type. It has a longer duration. There is carbonar phenomena, and usually there is a mucosal involvement. So if the disease is progressing, because you want to establish that part to give treatment, if it's a stable vitiligo, maybe you'll consider doing some surgical treatments. If it's progressing, maybe you'll do medical to stop the process. So another thing, when you start repigmenting a patient, so most of the pigment will come from this stem cell sitting in hair follicle or hair bulge here and will migrate this way if it's a hair-bearing area. If it is not a hair-bearing area, rarely you can also get pigment from the epidermis, which is slower than coming from the hair. But melanocyte stem cell preserved in hair follicle I showed here, and that so the areas where they have higher hairs will repigment easily. Only contra statement to that is, although in genital area we do have a lot of hair, but pigmentation is not as fast as face for some reason. So once again, the mechanism of why, like you're treating vitiligo and why it will relapse or why it will start, once again to summarize that, basically these memory T cells. So these I thought I had other. So memory T cells, these are the destroyers. वो आते हैं melanocyte को destroy करके, then they sit there, 2 or 3 or 4 or 500 of them. And then as anything new in cell start, they get activated and destroy the melanocytes again. So one thing new in the treatment is, पहले ये होता था कि अगर एक patient आया है और उसको एक patch है, तो we used to say कि it's okay now, you have only patch, one patch. Yeah, that's what I wanted. मुझे खड़े होने की आदत ही नहीं है. Okay. Can you guys hear me? Yes. So जो इसका vitiligo का अगर एक छोटा सा macule है thigh पे, face पे, anywhere, so we used to say कि अब ठीक है, अभी थोड़ा सा spot है, जाओ, there is nothing to worry. But the new science is that one little patch actually should be treated actively, because there are those memory T cells sitting there जिनके पास information है कि they can go anywhere and destroy rest of the pigmentation. So you start treating as soon as you see a patch or a macule of vitiligo. And what is the treatment? Obviously, there is an objective way of following this. You all know this, but I'm just putting it together for you. So as I said, it could be non-segmental vitiligo or segmental vitiligo. Segmental जो है usually obviously difficult to treat. Early active ho, so non-surgical treatments such as topical treatments and oral UVB. If it's a stable disease, usually it's only surgical. This side doesn't work. But mostly we treat this side. If it is you will start with non-surgical treatments, which we will go through. If there is no response, you can consider surgical treatment. But most important is, अगर disease तेजी से बढ़ रही है, कि इधर भी patch आ रहा है, इधर भी patch आ रहा है, then you don't want to even go this time. You have to first stop the disease. And to stop the disease, mostly you can use systemic oral steroids. in mini pulses, but different people have different way of do it. But agar active disease hai, mini pulses you can use of steroids, and what dose you all know. But you stop the disease, then you start treating this side. If it is a segmental one, this is the this is like I'm shooting backward. Acha. So to stabilize the disease, oral steroid, narrowband UVB, minocycline, methotrexate, and vitamin supplementation. Here comes in the pigmentation. And for repigmentation, so first you have to stop, and for repigmentation, whole slew of things. Topical steroids, protopic, those things, vitamin D, narrowband UV, psoralen, and then there are some newer experimental medication. We'll go through them. Melatonin, and then JAK inhibitors. आज किसी ने JAK inhibitors पे talk देनी थी, वो हो गई है कि अभी होनी है? Okay, I am okay. So other than those few, so one of these is already approved, Ruxo. We call it Opzelura in America. This is the only first FDA approved treatment just for vitiligo. Cream hai, subah sham lagani hai. But there are many others in production, like there are JAKs, 1, 2, 3, 4 of them. And then there are IL-15s and others. And then there are these melatinoids, jahan pe we'll talk about that in a minute. So these are in production so far. Only one approved with that Ruxo or Opzelura. It's a cream morning and evening. Sorry for my pointer keep going back and forth. So you all know this. We have all done this. If the pigmentation is gone, most of the part of the body, and there are few patches left, then obviously you can depigment them with these methods. Going into a little bit surgical methods, you probably do this in some centers. But anyway, there are two different types, the cellular graft and the non-cellular graft. This you all know, there is a mini punch graft you can do. You can create a suction blister and then transfer that. You can do a split thickness thin graft. You can do hair follicle graft. This graft, one of these things we'll talk in more detail, is very interesting, called epidermal curettage. Very easy to do. We're going to show a diagram. Me and my fellow, we did some experiments. Some of them didn't work, but we're working. Really, really easy, cheap way to do at home. We'll talk about that in a minute. And then there are like cellular graft, in which we have cultured melanocyte, cultured epidermal graft, non-cultured epidermal melanocyte suspension, and then there is this thing called non-cultured follicular root sheath. So these are a little more difficult to prepare in your own अपनी clinic में ये सारे culture करना ज़रा मुश्किल है, but here some of these you can do it easily. We'll talk about some of them in a minute. Again, this is a paper. Actually, ये paper, if all of you, I think we have a reference here. This is really, really a good paper, जो कि सारी surgical treatment को compare कर रहे हैं बड़े अच्छी तरह से. These tables are from that. This is our guy, one of our Muslim derm guy in France. Really, really good guy. उसका paper है ये बड़ा अच्छा surgery का, if you want to look at it. But in this, I just want to highlight one of this technique called epidermal curettage. So these are just we have pros and cons we are discussing in tissue versus other graft, and most of them they work, but obviously some of them are more cumbersome to do it. Let's see if we get there. So this new treatment where you have a melatinoid, a stimulant for melanocytes, के उनको rather than trying to stop the immunity, जो कि हम उनसे कर रहे हैं JAK से or other treatments, you can also induce maybe melanocyte produce more pigment. So in this is the paper discussing melatinoid implants and narrowband UVB therapy for the treatment of vitiligo. And the gist of the studies, yes, it worked. And how do you do it? We will discuss a little bit. Basically, you will do a monthly injection of melatinoid, which is like a patch, जैसे diabetes के दूसरे patches होते हैं. And then you add UVB to it, and the results are pretty good. इसमें pooled analysis of the, if you see combination therapy was superior, so basically they did UVB and melatonin and UVB alone. And when you combine UVB with melatonin, UVB on one side is stopping the inflammation or autoimmune part of the disease. And then melatonin is stimulating the melanocytes, so in combination, it's not surprising that it worked better. Then there is this, actually, I was visiting Azim's department, Jinnah Hospital, mein. There was another guy, another dermatologist there. I was talking to him. And I don't know, 10, 12 years ago, he told me about this needling story. आमतौर पे जब मीजोथेरेपी या माइक्रो नीडलिंग कर रहे हैं तो वो स्ट्रेट वर्टिकली कर रहे होते हैं. So he said, नहीं, अगर if you take the patch and you basically, if this is the vitiligo patch, you are injecting this way, meaning possibly pushing some melanocyte or something from normal to G. Jahangir, yeah, G, ठीक है. Jahangir tha, yes. Other Jahangir, not Azim Jahangir. Say, so anyway, so he was, but it was the same department as him. So he basically, he was injecting this way. Then I went back to America and we did a study, we did a study. So we were treating vitiligo with these transfer injections. In that we also have a little bit of cortisone, like we inject 2.5 milligram. So the group where we had cortisone and transfer needling, they did better. No surprise, because double action. But then actually slowly it's getting popular. What people are doing it now, or in some surgical treatments, Devinder, jo Jalandhar mein, he's the word guru of vitiligo. So you'll do mini punch graft, and areas where it's not pigment, you do transfer needling. So you combine, then the results actually look good. This is that study, they're showing they did mini punch graft and then they did transfer needling with it in the various groups. And I think they summarize it in next here. So the group, jisme ke ye mini punch graft only versus a transfer needling only, but then they combined both and the results were, much better in this case. So let me say what is transverse needling. Okay, if this is vitiligo macule, इसकी side से needle से injection ऐसे करना है. You drop little bit of pigmented skin into white skin, जो कि vitiligo किया. So that's really easy to do at home. उसमें simple, anybody can do it. I think it works. These are some of the results. And then I'm not going to bore with studies. So then going into the next one. So the new cream, Ruxo or Absolura we call it. What the evidence for that in randomized controlled trials for vitiligo. This is not that my speaking deck, this is from the paper. So okay, how did it do? And basically different groups of patients from all skin types. This is too much to read there. These are the results. So in vitiligo, like in melasma, we do MASI and melanin index. In vitiligo, we talk about VASI on the face, which is F is for facial VASI. And usually if it's total, it's T VASI. But in this case, also if the VASI score is 1.5, if the score is high, it's bad. And 12 weeks, the VASI came down to 0.25. And then 24 weeks, this is one of the photos from the trial, it's 0.3%. So big change from there to there, just with that cream twice a day. 12 weeks and 24 weeks. Again, in the same trial, there will be basically if, then the question was, ke aksar log jo ke who are doing medical treatment for vitiligo, we are also treating them with UVB most of the time. Would that change the cream या कुछ होगा या treatment खराब हो जाएगी? But actually no. This is a recent paper where they combined UVB with Ruxo or Absolura, and overall I think they did much better than doing it alone. So actually it's good to combine. Here improved VASI and total VASI if you combine both treatment, basically effective. So then I was talking about this efficacy of non-culture evidence and this result in the surgery paper. So I don't anybody in Pakistan कोई कर रहे हैं ये suspension या कोई जो treatment vitiligo के anybody Azim you doing it? Okay, okay. So what I want to actually go to next step there, which I really believe all of you should do it, publish it. If you want to publish it with me or my group will do it, I think it's really easy to do. So abhi me and Samavi here, my fellow, we did some experiments, very easy. So what you do is ke ek jo donor site hai, you take your curette or blade, so you scrape it off and you also scrape the recipient side. So scrape karke jo thodi si skin ka ek messa banega, few drops of saline, you make it to paste with a forceps, throw it on the recipient side and put a bandage jo ke hafte tak lagi rahe. I think the studies are showing results are pretty good, but even if it's not good, it's easy to do. Every clinic, everybody can do it. और वो suspension बनाने की ज़रूरत नहीं है. I think it will work. I'm looking into कि इसको और कैसे improve किया जाए, जो कि every practitioner can do it, and we are thinking of micro needles, etc., etc. But so let me repeat it. So clean the skin, उसको scrape करें curette से, dull curette होगी या dull blade होगा. Then where you want to transfer, scrape that area, put this paste, जो कि saline में 2 drop जाके बन जाएगी, put it there, put a bandage, and keep doing your medical treatment, जो भी आप कर रहे हैं, उसमें pro-topic steroid, जो भी लगा रहे हैं, keep doing. I think many of you students, fellows can publish this paper soon, but in this study they're showing this worked. Basically, at the end of the study, 50% repigmentation was in 95% of the 19 out of 20, so very heavy number. But the study abhi choti hai, sirf 20 patient hai. I want one of you guys to do 100 patients, jo ke aasan hai. You can do 20 lesions on the same patient for the study. So, in summary, on vitiligo, so drugs like Ruxo or one of the JAKs. And the new one is melatonin, IL-15 inhibitors, and this is coming. And then new surgical techniques like mini punch graft and then curettage I was mentioning will work and are working. Thank you. Anybody have a question? Shoot me an email. No, I'll talk, but ये मेरी email लिखी हुई है. Shoot me an email. Research का question है कि पढ़ाई का या whatever. But let's open the forum. How many minutes do you have for questions? I can stop.
Thank you very much, Dr. Rao, for a very elaborative and a very illuminative talk on both disorders of pigmentation as well as depigmentation. I just have a question. It was very heartening to know that the technique which you quoted us, our departmental study.
Jahangir Saab karte
yes, Muhammad Jahangir Saab. And before that, Professor Tahir Jameel Saab had initially written this paper. I think he'll be able to tell about it himself because it was his pilot study, his study that we followed and then we went on to do with it.
तो आप लोगों ने publish नहीं किया वो किसी और ने कर दिया?
नहीं, publish तो हुआ हुआ है, sir can answer this
अच्छा हुआ हुआ है?
मेरा सर एक सिर्फ इससे एक और सवाल, ये जो अभी आपने क्यूरेटाज टेक्निक बताई, मेरा सिर्फ ये सवाल था कि क्या डोनर साइड पे कोबराइजेशन of vitiligo होने की chances?
I apologize, I forgot to mention, जितनी भी surgical treatments है vitiligo, they can cause cobnophrama, so that's a risk जो हो सकती है. But that's the risk we have to take. But ये हो सकती है.
Sir, over to
जी ताहिर साहब, if you like to comment. So the credit goes to Tahir, ये जो मैंने needling की जो बातें की, and I published the paper also after जी.
Thank you very much. I give all my credit to Professor Tahir Saeed Haroon, a legend in Pakistan, who actually gave all the confidence on me because any surgical procedure was not known in Pakistan. So he was the one behind me when Satish Sawant visited from India, and he gave a demonstration about all these small procedures. And we started autologous skin punch grafting in the beginning. But now we are even doing that process called regenera. We make the mesh from the small punch, and then similarly we abrade the area and we apply on it with the weekly dressing. And alhamdulillah, you are doing a great job, but we are also following in the same steps.
No, thank you. I'm actually very interested to develop something very simple. So jisko shauq hai, talk to me, we'll work together. Thank you. Thank you for your, thank you. Thank you.
That was a very interesting and an interactive session where we visited the basics and the advancements in both hyper and hyperpigmented disorders. Thank you, Dr. Baba Rao, for the wonderful, wonderful talk. So our second international speaker of this session is Professor Abrar Aleem Qureshi. He's an MD and MPH, a Warren Alpert Professor of Dermatology and Chair, Department of Dermatology at Brown University. He's also the Director of Hospital-Based Ambulatory Specialities at Lifespan Teaching Hospital and Chief of Dermatology at Veterans Administrative Hospital in Rhode Island. And his topic of today is also very, very interesting, especially for our clinical dermatologists. It's new drug for old problems, medical dermatology revisited. So can you please join us on the stage, sir? Thank you.
Dr. Faryal, thank you so much. Assalamu alaikum, everyone. Great to be here. MashaAllah, Dr. Syed Tabassum, congratulations on an incredible conference. I'm really proud to be here and happy to share our experience last few years working in Boston. I'll just make a quick comment, though. Someone mentioned Professor Tahir Syed Haroon. I remember as a child, I used to go visit PAD meetings. There was no PAD at the time. It was brand new, just came about. My father, Dr. Aleem Qureshi, Professor Tahir Syed Haroon, and Professor Ghulam Shabir were there. I remember they designed the group and the association, and this is one of the few associations in the world which is an association for dermatologists, not for dermatology. So you are the people who this is about, and they made a very big deal. I remember Professor Ghulam Shabir making a big deal. The society is about the people, not about the specialty. So I just want to make that comment. So I thought I'd just talk about, let's see, right clicker, right? You can go to the next slide. Aap kar de. All right, so I'm a consultant for OM1, which is a real-world data company, no pharmaceutical companies at all, and we develop a lot of research tools that we license out for clinical trials. I'm not going to talk about that today. Next slide. So I just want to mention, this is our team in Boston. So we have basically rheumatologists and dermatologists working together. And it's a great experience because as we work together with rheumatology, we learn a lot back and forth and vice versa. So that's Dr. Reginado. He's lying on the ground. You can see we have a great working relationship. And we also, on the far left of the screen, is actually a pharmacist. So we have a pharmacist, we have a rheumatologist, and a dermatologist in clinic all working together. So it's really a great experience. And if you get a chance, you can check out I'm doing a new teaching modality using Instagram, Derm Tracker, for the youngsters. I'll be sharing some of that later this afternoon. Next slide. So what I do is just jump into, there's a lot of new molecules in the marketplace in the US. I thought I'd share some of them with you. MashaAllah, it's great to see a lot of new molecules arriving in Pakistan as well. So these are the new biologics that the US FDA approved in 2022. And I'll show you the next slide is 2021. But can you imagine how important JAK inhibitors are? We had a great talk yesterday. Professor Rao spoke this morning about JAK inhibitors. They're almost everywhere. So out of 8 drugs approved by the US FDA 2021 into 2022, half of them for skin diseases are JAK inhibitors. So it's really interesting how these are going to take over. So there's abrocitinib, the oral molecule, which is approved for atopic dermatitis. And then I mentioned these other molecules. At the bottom, you see Olumiant, baricitinib, that's now also approved for the treatment of alopecia areata. It's the first biologic approved for alopecia areata, and we're using it in clinic. Next slide. Next. And again, at the top, you see of these 4 on this slide as well, you can see deucravacitinib. It's also an oral TYK2 inhibitor for plaque psoriasis, approved. And you saw Opzelura, Professor Rao mentioned, ruxolitinib topical for the use of vitiligo. So it's incredible how JAK inhibitors are coming in. I'll just mention a couple of other molecules. For those of you who treat itch, this is a brand new molecule. It's actually a kappa opioid receptor agonist called Korsuva. It's given intravenously for severe pruritus related to renal disease and hemodialysis, given actually at the time of hemodialysis. I haven't used it yet. It's brand new in the marketplace, but it's a fascinating drug to use. And just want to mention an acne medication. I won't be talking about that today. This is a new combination of tretinoin and benzoyl peroxide for acne vulgaris. Next slide. All right, so let's take a deep dive into JAK inhibitors. You've heard about them yesterday. You heard some this morning. They're a fascinating group of molecules. You can see my pointer's not working, but you can see, so all the way from the left of your screen to the right, at the top are the names of the disorders that you can treat. Then you see all the molecules. So there are basically two chains, JAK1, JAK2, then there's JAK3, and there's tyrosine kinase, TYK2. So in these different combinations of receptors, you can basically target different cytokines and different molecules. So at the top you see the conditions. Oh, thank you. At the top you see the conditions, right up here. Well, I have a question, especially for the professors in the room, the senior physicians. When was the last time you had a group of molecules or one molecule that can treat alopecia areata, psoriasis, atopic dermatitis with the same molecule? Very rare, right? It's very difficult to imagine. Maybe cyclosporin did that, which is profoundly immune suppressive. Well, it turns out the JAK inhibitors are the new molecule, the new kid on the block, and they do that. So in some ways, as an epidemiologist, as a physician, it does worry me that these drugs work for almost everything, and I'll show you some pictures in a second. So word of caution, as we use them, we should really be careful and watch the patients carefully. So here you have basically a selective, well, let me say this. At the bottom of the slide here are the non-selective JAK inhibitors. These ones target almost all JAK1, JAK2, JAK3, and TYK2 molecules. So the one that's available in Pakistan now, tofacitinib, I know 2 companies have it here. We're certainly using a lot of tofacitinib in the US. Baricitinib is certainly available. And then, of course, ruxolitinib. So those are your non-selectives. Then your selective JAK1 inhibitors, abrocitinib, I just mentioned to you, is approved now in the US for psoriasis. The TYK2 inhibitors, deucravacitinib is available now, and the selective JAK3, they're not on the market yet, but they're coming. So it's a whole field developing with time. Next slide. What's really interesting is, during COVID, the pulmonary, the ICU doctors, pulmonologists were coming to us asking us how to use baricitinib in the ICU patients, because it's now approved for the use of basically pulmonary complications in COVID. And so we're using it, in the ICU. So at some point, they actually held our baricitinib access for patients with rheumatoid arthritis and psoriasis, because they were using it actually in the ICU. Next slide. All right, so word of caution. JAK inhibitors, these are the 4 things you have to watch for. It's really important. There are 4 black box warnings on all these molecules from the US FDA. So first one is, there definitely is a higher risk of cancer. Certainly in people who are past smokers, it really is there. There's increased risk of major cardiovascular events. You have to watch these patients carefully. Risk of stroke, as well as heart attack, myocardial infarction. So massive risk there. There's also a risk of deep venous thrombosis and blood clots. So you have to watch these patients carefully. If they have a history, family history, again, they have to be watched carefully. In patients we do use the molecules, we'll certainly check with our hematologists to make sure we can use the medication. And they do drop your lymphocyte count, so you have to watch your CBC very carefully. You can get leukopenias. You can get anemia in some patients. We haven't seen any thrombocytopenias yet. So again, 4 box warnings for these drugs. Next slide. Next. Yeah, all right, so let's jump into some case examples. So tofacitinib. It's been around, at least in our part of the world, for about 6-7 years. So we've used it a fair amount. It was initially approved for the use of rheumatoid arthritis. So we saw a lot of patients coming in with that. Now, of course, it's approved for psoriasis as well. But because we have access to the drug, we use it off-label. So not for the indication, but off-label quite often. It comes in 2 preparations. Well, it's 5 milligrams or 10 milligrams twice a day. And now we have a long-release 11 milligrams once a day. So remember, it's a JAK inhibitor, non-selective, targets all JAK1, JAK2, JAK3, and TYK2. And certainly there's a risk of infection as well as TB, et cetera, that we follow on these people. Next slide. So this is the first patient I treated for, ever with a combination of rheumatoid arthritis and alopecia areata. She has alopecia universalis. You can see she's got brass tacking of her nails. Next slide. And she has rheumatoid arthritis. A lot of swelling on her MCPs there. You can see, swelling of the PIPs as well in RA, quite symmetric. So she was able to get tofacitinib, and she didn't get a great response. She wouldn't let us take pictures of her hair at the time. The response was not great with tofacitinib because she had very long-standing universalis, but her RA did get better. Next slide. And since then, you can see the fingers up close. Next slide. But you can see, since then we've used it quite often in our patients with alopecia areata, and they do quite well. So you can see on the left side, pre, and this is literally 4 months into the use of oral tofacitinib, 5 milligrams twice a day. I'm sure you're seeing these responses well in your patients here if you're able to use it. What's interesting is, in alopecia areata, unlike psoriasis, you have to wait. You have to be very patient. It takes about 3 months to see the response at all. And then if you stop the drug, it takes about 3 months for the hair to fall out. So you have to be very careful. If you stop the molecule, you have to be careful, watch the patients carefully. They can actually lose hair too. Next slide. But you can see a really robust response. If they do well, next. If they do well, what you can do is drop the dose from 5 milligrams twice a day to 5 milligrams once a day. It saved them some money, reduced the risk of infections. And can I get the next slide? Again, you see a nice response. Next. And again, pretty nice response. So he was actually on 5 milligrams twice a day. At month 6 or 7, he noticed he was getting a little more in the way of URIs, respiratory tract infections. So we dropped him to 5 milligrams once a day, and he's maintained that response in the last 4 years. Next slide. So a young man actually, Pakistani parents, born in the U.S., had pretty severe disease, was 19 years old, going to college, really wanted to, solve the problem. Started tofacitinib. Within 6 months, got a great response, and he's maintained his hair quite well. Next slide. You can see, pretty reasonable response. There was still some ophiasis pattern change remaining. Next. But you can see, overall, a much more robust response compared to what he had before. So, again, if you're patient, they'll do pretty well. Next. Next slide. Now, vitiligo. We've certainly had patients with vitiligo. Let's say they had psoriasis and vitiligo. They got the tofacitinib for the psoriasis, and the vitiligo cleared as well. So here, classic example, this is pre, and then the next slide is post. Literally within 6 months of getting, next slide. You can see a pretty nice response. Psoriasis cleared as well, but the vitiligo cleared beautifully on tofacitinib as well. Next slide. It's interesting. Sometimes you see patients with, next. So this is a patient actually who has 3 conditions. He's got alopecia areata, he's got psoriasis, and he's got vitiligo, right? So same genetic basis for all 3. Next slide. So we published this a few years ago. Next slide. So here he is before, right? You can see the alopecia areata, you can see the vitiligo, and you can see, he's got inverse psoriasis. Literally within 4 months to 5 months of starting tofacitinib, 5 milligrams twice a day. Next slide. You can see a pretty robust response. Hair, vitiligo is almost beginning to clear. Psoriasis cleared within about 4 to 6 weeks. So, a nice response. You're getting a 3-disorder treatment with 1 molecule. But again, you got to watch out for all the side effects I mentioned earlier. Next slide. Now, we're using the molecules when we can in various disorders. This is a woman with severe cutaneous lupus, right? Just classic lupus of the skin. And I got a picture of, next slide, picture of her on tofacitinib pre and post. Next. And you see, although she's not totally clear, within 4 weeks she feels much better, less itch, and eventually she cleared. Next slide. There's another woman with cutaneous lupus. She also has lupus nephritis. Was getting admitted to the hospital with lupus nephritis flares all the time. We put her on tofacitinib. Next slide. Shows you also how bad her disease. You can see quite a bit of disease there. Quite severe disease on her face. Next slide. And she cleared quite well. Actually her hair's now grown back completely. I took the slide early on. She'd shaved her hair because the psoriasis, the lupus was bothering her, and now she's completely clear, and she stayed clear. And it's interestingly enough, there's no data on this yet. We're actually looking into it. Her lupus nephritis is quiet. Her proteinuria settled down, but she's now on 5 milligrams twice a day of tofacitinib. So again, we don't know all the mechanisms of action, but it seems as if the JAK inhibitors are quite efficacious for cutaneous lupus. Next slide. So let's talk about baricitinib. This is a JAK1, 2, and TYK2 inhibitor, non-selective also. The dose is a little different. It's 2 to 4 milligrams a day. In the US, it's approved for 2 milligrams a day for rheumatoid arthritis, but the dose for alopecia areata is 4 milligrams a day. That's typically how we use it. Again, same adverse effects. Next slide. And then we'll talk about upadacitinib a little bit. This molecule we're using quite a bit for atopic eczema, atopic dermatitis, severe atopic dermatitis, patients do really well, especially patients who failed Dupixent. This is a selective JAK1 inhibitor. The dose is a little higher, 15 milligrams a day. Next. And then Dupixent, are you using dupilumab in Pakistan yet or not? Okay, it's not available? Okay. But you know, this drug is the only molecule we had for atopic dermatitis, you know, in the last few years. It's become a very, very important molecule for the management of atopic dermatitis in the US. Do we have much atopic dermatitis here? Hair? Okay. Anyway, so when we use it, you know, we like the 300 milligrams every other week dosing, and they do very well long term. Also, remember, it works for asthma as well as for atopic dermatitis. Next slide. I just want to mention one more molecule. Next. So benralizumab, worth noting, we're using it for our patients with itch and with atopic dermatitis. This is an anti-IL-5. So Dupixent's anti-IL-4. This is an anti-IL-5. All right, let's show you some cases, some pictures. Next slide. So this is a gentleman with severe atopic eczema. You know, he was drinking alcohol, trying to, you know, keep himself from itching, to put himself to sleep at night, was getting LFT abnormalities, etc. Quite severe disease. Next slide. Was very depressed, was itching all the time, half asleep. You can see his mood. You know, this picture's taken when he's not feeling so good. You know, the itch is keeping him up at night, poor sleep. He's failed pretty much every therapy out there. Next slide. So we gave him Dupixent. You can see he's a happy man. He came in literally cleared completely. And he actually remained clear 5 years later. He injects it every other week. And when he comes in, he says, Dr. Qureshi, you know, this drug has changed my life. My first patient I saw ever who came in on Dupixent, dupilumab, actually did so well, she was crying. And I thought something had happened to her. She was crying because she'd never not itched. Like the itch was gone, right? It was amazing. Next. So this is a young woman who failed Dupixent. So Dupixent does not work for everybody. She has severe atopic dermatitis. You can see classic distribution. You know, a lot of lichenification, sort of classic clinical picture of atopic dermatitis. Well, so we use upadacitinib, Rinvoq, that I mentioned earlier. Rinvoq is, you know, 15 milligrams a day in patients who failed Dupixent. And next slide. So, you know, this is literally within 4 weeks. The next picture was taken. Next slide. You can see her itching is much better. She's beginning to clear already, and the rest of her arms are getting better as well. And her itch has gone from, you know, being very severe to being very, very tolerable. So again, you know, the new molecules are working. We now have a backup to Dupixent, which is Rinvoq. Next slide. But again, you know, in patients who have severe lichenification, it takes a long time for them to respond. So you have to be very patient with them. This patient actually failed Dupixent also, the anti-IL-4, because she had severe lichenification, but she responded to the JAK inhibitor. Next one. Now this is, maybe I can ask some of the residents, what do you think is going on here? This patient has atopic dermatitis, and she has a tracheostomy. What's your diagnosis? Anybody? The attendings are not allowed to answer this. Any residents? What if I gave you a hint? The patient has atopic dermatitis, has frequent skin infections with Staph aureus, hyper IgE syndrome. कहाँ से आप लोग? Jinnah? JPMC wins. Okay, I'm joking. Anyway, so Job syndrome is atopic dermatitis, frequent skin infections, and they get a lot of pulmonary infections as well, which is why she has a tracheostomy in place. Horrible quality of life, was not responding. We started her on Dupixent for her atopic dermatitis. The advantage of Dupixent is it's an anti-IL-4, so it does not increase your risk of bacterial infections. So guess what's happened? Her asthma settled down, her atopic dermatitis is quiet, and her skin infection frequency has gone down, and her pulmonary infections actually have not happened in the last 2 years she's been on the medication. So, you know, it's interesting to follow these patients with Job syndrome. They respond quite well to dupilumab, Dupixent. Next slide. All right, I'm going to switch gears a little bit. So I'll talk about this molecule that we're using for scleroderma. So we're going to switch gears now into scleroderma. It's a new molecule. Again, the theme of the talk today is new molecules for old diseases. So this is an exciting molecule because in 2017, the US FDA gave it a breakthrough designation approval for scleroderma. So imagine, it was in trials for scleroderma. It's an anti-IL-6 receptor antibody. It's given intravenous subcutaneously. We like to give it IV, 4 mg per kg IV, typically every 4 weeks. Anyway, this molecule was in trials for scleroderma, and they stopped the trials early because it worked. So they gave it breakthrough designation therapy. And I'll show you some pictures in a second. But we're very excited to use it. Next slide. So interestingly enough, it's also approved in the US, and it's been used in Pakistan quite frequently during COVID for pulmonary disease. Now, patients who are about to get intubated with COVID, who got bad pulmonary disease, 1 infusion of tocilizumab, and usually you can, if you get them right on time, you can avoid intubation, and they actually do very well. So this is the 2 trials that were done, recovery trial and PACTA trial. Actemra is now approved for the use of COVID lung. Next slide. Anyway, we use it for purely scleroderma, and it's approved for rheumatoid arthritis as well. Actually, it failed trials for psoriasis, so it's not used for psoriasis at all, but we use it for scleroderma. I'd love to ask you, we're seeing a number of women, at least in the northeast of the US, who get this type of lichen sclerosis / morphia. They also have vulvar disease, vaginal disease. They do get this skin disease, and it's very extensive. So it's usually submammary. It's got on the abdominal fold, involves the umbilicus, and involves the groin area, and can involve the armpits as well. And it's extensive lichen sclerosis. Are you seeing that much in Pakistan at all or not? You see some. Okay. Next slide. And so, that's how it presents. So there's severe scarring. It can be ulcerated. Sometimes it can be quite painful. It occurs in a small area of the back, also in the upper back as well. And like I said, submammary and armpit area. So it's quite extensive lichen sclerosis. We always ask them about vulvar disease because they often have vaginal or vulvar disease along with the skin disease. And again, typically we'll start with hydroxychloroquine. Then we'll add methotrexate, typically sub-Q methotrexate. How many people here use subcutaneous methotrexate? Can I see a show of hands? Great, okay. So, sub-Q methotrexate is nice because each 0.1 ml is equal to the pill. It's 2.5 milligrams, so it's easy. If you're on 4 pills a week, you take 0.4 sub-Q. Anyway, so we'll add sub-Q methotrexate, so hydroxychloroquine plus methotrexate. If that doesn't work, we'll give them thalidomide. How many people here use thalidomide for lupus or for scleroderma? No thalidomide? We use a lot of thalidomide for our lupus patients and for patients with scleroderma. It works pretty well. It's antifibrotic. We use 50 milligrams 3 times a week. And the major risk with thalidomide, by the way, is clotting risk, deep venous thrombosis. But coming back to this patient, so you have someone with lichen sclerosis, pretty extensive disease. If they don't respond to the methotrexate and hydroxychloroquine combination, we'll give them Actemra IV. And they usually clear quite well. Next slide. So you can see a pretty reasonable response. The scarring gets better. They become a little less scarred down, and they're extremely happy. Next slide. Now, this woman actually, I don't have a follow-up picture, but she also has lichen sclerosis / morphia, very severe ulcerative disease that cleared completely on tocilizumab, on Actemra. Next slide. Scleroderma. So going back, leaving lichen sclerosis for a second, we're going to move on to systemic sclerosis. We're seeing a fair amount of systemic sclerosis in females, of course. It's usually a disease of females. When they present with the edema and the shiny hands, so sclerodactyly, right, that's when you want to catch them and treat them. Because if you can catch them here, you can preserve hand function. Next slide. So this young woman came in, she was having trouble opening her mouth. Her hands were getting, sclerotic already. She actually was having trouble. That's the most she can make in terms of a fist. So she really cannot make a full fist. She does have the opposable grip, so she can pick things up, but she's losing that fist function. So we gave her Actemra, and we caught her early. If you can catch them in the first 6 months of disease, you can actually reverse it. Next slide. So this is a video. We're actually now developing a new outcome measure to measure hand function before and after Actemra. Click करें एक दफा, एक दफा click करें. So you can see the patient's actually was not able to move her hands at all, is now able to move the hands. What's really interesting is we can rescue the function on the in the dorsal hand area, so where the MCPs are, but we're still having trouble rescuing the movement of the fingers. So if you look at the video carefully, you'll see you can get the opposable grip back, where the MCPs are becoming more relaxed, but the finger, the DIP, PIP movement is still restricted. एक बार play करना. So you'll see, this person couldn't hardly move her hands. Within 4 months of Actemra use, you can see a beautiful response. So doing pretty well. Next slide. There you go. And of course, not everybody responds with scleroderma, right? If you miss them, if you don't get them early in the disease progression, especially if they're very far away from that edema sclerodactyly phase when it began initially, you've lost them. At that point, they become scarred down. So this patient actually, you can see the classic face, the pointed nose, you can see some telangiectasia on the malar areas, very sort of advanced sclerodactyly, shiny fingers. That's the most she can move her hands. Now, she's still better than getting the mitten deformity, so we can halt the disease. We just cannot rescue back all that function, unfortunately. So next slide. So you can see, this person is much more advanced. We just can't save the hands beyond a certain level. Next slide. So let me just end with some comments about Raynaud's. Dr. Faryal, we're okay on time? I think we're okay on time. Yeah, okay, let's jump into Raynaud's. Do you see a lot of Raynaud's in Pakistan, especially in the north? Are you seeing Raynaud's? Yes? No? Okay. So listen, medical dermatologists also use Botox, and I'll show you in a second how. So Raynaud's, we have an extensive, actually a lot of work we're doing in Raynaud's now, which is very interesting. So this is our sort of standard treatment regimen for Raynaud's. We start off with obviously topical vasodilators. Nitroglycerin, yeah, it doesn't work very well because it's so rapid in onset. If they use a lot of topical nitroglycerin on their hands, they end up getting into trouble. They get headache, their blood pressure drops. So it works okay, but it's tricky to use. So we usually use nifedipine, and we use a lot of the calcium channel blockers. We're using a lot of sildenafil, Viagra. It works unbelievably well for Raynaud's. I'll tell you about that in a second. We are using Botox to save fingers if they have necrosis, gangrene, is risking the fingers. We use some Botox. And then Bosentan we're using as well. It's actually an endothelin inhibitor we're using as well. And then I'll talk a little bit about the other molecules. Next slide. So, classic patient Raynaud's. In the Boston area, it's getting cold. Once the snow arrives, it gets so cold. We see a lot of these patients coming in. They have a lot of pain, a lot of discomfort, and they also often have pulmonary disease with their scleroderma. Next slide. So, we want to prevent this tapering of the fingers, this scarring that they're getting. You can see scarring of the digital fingertip. Next slide. And when we start seeing these kind of changes, we know there's enough anoxia. We have to get more blood flow to the digits, and that's when we usually would go from just nifedipine or a calcium channel blocker. We'll add sildenafil. So sildenafil, we tend to use it 20 milligrams 3 times a day. Initially twice a day, up to 3 times a day. The key with sildenafil use is it takes 2 or 3 months for it to start working. So you have to warn the patient, listen, we're going to put you on this. You might get some change in your blood pressure, especially in women. If their pressure runs low, you have to be careful. And typically at 20 milligrams twice a day or 3 times a day, you start seeing their fingers become warmer, their pain goes down. Actually does respond. Next slide. One sign, so all the good clinicians out there, if you can pay attention to this sign. If you see at the tip of the digit hyperkeratosis, like this, that finger has anoxia. It is not getting blood supply. That is not a wart. It's not a squamous cell carcinoma. That is the body's reaction to basically hypoxia, right? And so if you see that finger needs help. We usually will adjust the sildenafil dose and try and get them to be warmer. It's very interesting. Which digit has the least risk of looking like this on the hand? Of the 5 fingers in the hand, which finger do you think has it? Say again? Ring finger actually does get involved. Thumb. Aap kahan se? Kis school? Nishtar. Wow, that's pretty good, Nishtar. So the thumb. Why the thumb? Why is the thumb so protected? आपको याद है early on जब हम nubs देखनी शुरू की थी, यार nubs thumb से कभी देखते हैं? क्यों नहीं देखते nubs? Thumb से क्यों नहीं देखते nubs? Because you'll feel your own pulse. The thumb has the biggest artery of all the fingers. So you very rare, if the Raynaud's is really bad, the thumb's involved, right? So the good clinicians are thinking, if the thumb's involved, it's bad Raynaud's. Thumb is almost never involved. Usually it's all the other fingers, and when you see this, this is becoming scary. Next slide. So again, we're trying to prevent this kind of damage. This is the kind of stuff, this is one of our patients who we've had on every therapy. Now he's also beyond nifedipine and sildenafil. He's on bosentan. I'll show you a picture in a second. Bosentan is an endothelin inhibitor. It works pretty well. It has a problem though. It can increase your LFT, so you have to watch the liver very carefully. But he's had to have multiple amputations of his toes because he's getting severe sclerodactyly and the Raynaud's is really eating away at his digits. Next slide. So nitroglycerin I mentioned, the biggest issue with it is headaches and drop in blood pressure, so it's short acting, not much use, limited use. Next. So sildenafil, phosphodiesterase type 5 inhibitor, really works beautifully in our hands. This is our go-to drug for Raynaud's. Again, some lightheadedness, but overall does pretty well. Next. And then for the residents in the room, all the trainees, house officers, bosentan's worth looking into. It's an endothelin 1 inhibitor. It's used, of course, as you know, for pulmonary hypertension, right? But we're using it for Raynaud's, and they do pretty well. Again, you've got to watch the transaminase. You've got to watch the transaminase very carefully. Next. So here's an example of a patient who's a smoker, right? Has almost like a Berger's disease type presentation. So Raynaud's and smoking. Comes in one day, it's wintertime in Boston, and you can see very dusky fingertips. So we warned her to be careful. The thumbs are not in the picture because the thumbs are normal. That finger looks pretty good, but the other fingers are purple. Next slide. She continues to smoke, shows in one day, comes in and says, I have a lot of pain in my finger. Look at that finger. She's getting gangrene in that finger. So that finger, the fingertip, is basically beginning to die. She's still smoking, right? So we do smoking counseling. What do you think the success rate of counseling a patient to stop smoking is in clinic? 1% or less. So we don't even try to counsel them. But anyway, we send them to our smoking cessation people. Anyway, so that's her finger. Next slide. Then you can see she's getting necrosis there, a lot of pain. So that's when we use Botox. Next slide. आप लोग इस्तेमाल कर रहे हैं Botox? Are you guys using it for your Raynaud's or not? Okay. So essentially, we use it for digit-threatening Raynaud's vasospasm, and it works within 12 to 24 hours. Patient will come back to you and say, my pain is gone. It's very quick. Next. So we use typically, next slide. So typically we'll inject it on the lateral aspect of the finger. So, you know, prep it and mark it and just inject 4 units here and 4 units on the other side of the same finger. So easy peasy. 4 units one side, 4 units the other. Next. So you can see that we just drop a little bit of Botox on either side. If you call the patient back at home, within 12 hours they'll say, you know, dard chala gaya, we're feeling much better. It just feels a lot better. And so, next slide. And you know, within 3 weeks she came back, we'd saved the fingertip. It revascularized, some eschar left, but her pain was gone, feeling much better. She's still smoking though, but you know, pain is better. Next slide. And this is a patient, I don't have pictures before, but she got admitted to the hospital. We had to have called hand surgery. She got all her fingers were amputated. Because she's a smoker, has severe Raynaud's, and everything failed. Bosentan failed, Botox failed. So in this case, you know, sometimes we fail to help them. She's doing a little better now, but she's still, you know, and she has quit smoking. She lost all her fingers. So again, we do see some severe cases here and there. Next slide. And finally, you know, we're always doing, you know, fun, crazy things in clinic. We see a lot of calcinosis cutis in our patients. Sodium thiosulfate is very hard to get. Also you need to monitor them on telemetry. So it's hard to give them telemetry and give them IV sodium thiosulfate. So we use topical sodium thiosulfate, especially on the fingertips, and it works pretty well. So we compounded 20% sodium thiosulfate. We published it a couple of years ago, and it works pretty well. What we do is you put the cream on the fingertip or on the calcium nodule, wherever it is in the fingers. I have them put a small amount of cream and just put a small piece of tape on it every night. So every night they concentrate the cream there, and within takes about 12 weeks, and it clears pretty well. It's better than giving them IV sodium thiosulfate. Next. I think that might be it. Next slide. And okay, Dr. Fayal, you want me to keep going or keep going? Can you? It's up to you. You're the boss. Keep going. Switch. Can you switch to the other presentation? Just the last couple of slides, and then we can end and take questions. All right. So finally, I just switch gears into another area where we're using some new molecules typically for hidradenitis suppurativa and for pyoderma gangrenosum. So the group of anti-IL-1 molecules, of course, you use a standard therapy, systemic steroids, right, IV or oral. We use, obviously methotrexates of the world, mycophenolate mofetil, Cellcept. All those molecules are great, but an anti-TNF therapy, so infliximab, IV works, Enbrel, etanercept works, but I'm just going to show you some experience with the anti-IL-1s. Just one word of advice, I've learned this from rheumatology. It's been an incredible experience. I'd love to ask some of the senior, maybe the panelists during the question and answer session if they've tried this. Prednisone does not work as well for pyoderma gangrenosum as does methylprednisolone. So oral prednisone versus methylprednisolone, it's basically a 4 to 5 ratio. So 4 milligrams of methylprednisolone is equal to 5 of prednisone. And we have a much better experience using methylpred. So if I see a patient with pyoderma gangrenosum, I'll put them on methylprednisolone. Typically, instead of putting them on 50 or 60 milligrams of, let's say, prednisone, I'll give them 48 milligrams of methylprednisolone. And they respond immediately. Because methylpred is already ready to work, does not need to be methylated in the liver, and it's much more bioavailable. So just try that. If you're ever stuck, actually, how do you know prednisone is not working for the clinicians? You put someone on prednisone, and the pyoderma gangrenosum is not responding. How do you know? Simple stuff. They're not hungry. They're not gaining weight. There's no mood changes, right? So if they come back and they're still pleasant, and they don't look like they're gaining weight, and the appetite hasn't changed, they're not absorbing the prednisone, that's why the pyoderma gangrenosum is not getting better. So you always go back to the basics. Anyway, so canakinumab. It's an anti-IL-1 blocker. It's actually very expensive in the US. Do you know why it's so expensive? It's approved for these rare syndromes, the cryopyrin syndromes, FMF, CAPS, etc. And so Muckle-Wells syndrome. So it's so rare, it's not used as often, so that the price is very high. But we can get it in some of our patients, and it works pretty well. 150 milligrams subcutaneously every 4 weeks. Next slide. Next. And anakinra is the older molecule. I use this a little bit. It's not as easy to use. It's an anti-IL-1. It's a receptor antagonist. So the problem is it's given every day subcutaneously, and patients get very tired of injecting a shot every day. But it's used for RA, and we use it for some of our patients. So next slide. So this is a patient with pyoderma gangrenosum. You can see before and after pictures. So before and after, did pretty well. This is, had failed. It was on prednisone, failed anti-TNF therapy, was still breaking through. We put her on anakinra, which is 100 milligrams subcutaneously every day, and did very well and cleared quite well. Next slide. The patient again with pyoderma gangrenosum, you can see old scars and now getting a new lesion while on infliximab, so she's breaking through. Infliximab is a mouse chimeric molecule. You get an antibody response against it, so it stops working. So we put her on again on canakinumab, did very well. It's, she really has almost a pustule development. It's more serous, but pustule developing at the site. This eventually broke down, but it healed quite well. But on the patella, it can be quite risky because the patella, the bone is right underneath that bursa there. But did quite well on canakinumab. Next slide. This is a patient with hidradenitis, but also has Crohn's disease. So when you see hidradenitis, it's a reminder, think cutaneous Crohn's also. So this patient really has hidradenitis. These lesions almost look like pyoderma gangrenosum. And again, did very, very well on canakinumab. Next slide. You can see an after picture. Very quiet, everything's healed, everything's sort of, shut down. And then long-term therapy, it's easier to maintain them and they stay quiet. Next slide. Infliximab, certainly we use a fair amount. Do you guys use infliximab available here, right? And you like using it? That's great. Excellent. So, we use basically 5 mg per kg most of the time. We don't use anything less than that because the risk of antibody formation is so high. So 5 mg per kg, 0 to in 6 weeks, and we maintain them every 4 to 6 weeks. We don't go down to every 8 weeks, and they do quite well. Up till we have Inflectra and Renflexis, the biosimilars, much cheaper. All the hospitals are using them, and it works pretty well. Next slide. So you can see we're using infliximab for, what's the diagnosis for the residents? Very good. आप कहाँ से? JPMC, this is amazing. Okay, got it. Okay. All right. So anyway, so PRP, infliximab works pretty well for PRP. Actually clears them very quickly, and you can maintain them long term. Our experience has been pretty good. Next slide. So let me end with, you got to go back. I trained 22 years ago, so we used to use a fair amount of old molecules, methotrexate, cyclosporin, cytoxan. So sometimes, the irony is, I told you today about all the new molecules for the old diseases. Sometimes the new molecules don't work. So you got to go back to the old molecules. So this is an example of a patient with severe pyoderma gangrenosum. I'll show you in a second. Severe pyoderma gangrenosum, complicated by surgery of the nose, etc. Well, we went back to cyclophosphamide, and it worked beautifully. So I like oral cyclophosphamide because you don't have to worry about the bladder, hemorrhagic cystitis, etc. But we started him originally on IV cytoxan, cleared his disease, and then transitioned him to oral cytoxan, and he did very, very well long term. So here, 1 to 2 milligrams per kilogram IV every 4 weeks. You've got to watch their leukopenia. We give them Melasma for the hemorrhagic cystitis in our infusion center. And now he's doing very well on 50 milligrams twice a day. Next slide. So this is him when he first presented. Okay, he got in the hands of ENT, and someone was doing surgery trying to clear a nasal abscess. It was all PG, misdiagnosed. So when he showed up, he had Pseudomonas infection into his sinuses. Nose is all gone, eaten up. You can see a large lesion right there. Next slide. This is him, 3 months, 3 infusions of cyclophosphamide. 3, right? You can see open frontal sinus. The nose is all scarred down. You can see that's what's left of the nose. That scar here is almost completely healed in 3 months on cytoxan, right? And next slide. This is him now. I saw him recently. He's on oral cytoxan, 50 milligrams twice a day. Completely, so we hadn't seen plastic surgery. They closed the frontal sinus because that was very dangerous, risk of infection. So they did surgery there, and he did not get PG with surgery. That's pretty good because he's on cytoxan, and he's going to get a nasal reconstruction job, but he's almost completely healed. So, sometimes you go back to the old molecules. Next slide. And this is an example. Look how beautifully the skin heals. This lesion was pre-cyclophosphamide IV. This is at 4 months. Almost looks like you sutured it together. It contracted and healed. PG, if you can get the right immune suppression on board, they heal beautifully. All right, I think that's pretty much it. Next slide. Oh, I got to ask you this one. This is my last slide. This is now for the senior residents. Where are the senior residents? Raise your hands. Who are the senior house officers? No one's accepting the senior. What is your diagnosis? What are the senior, not the first years, and not, who are the third year FCPS? What's your diagnosis? आवाज नहीं आ रही. अगर तस्वीर आ रही है, आवाज नहीं आ रही. Anybody? You know what this is? This is factitia. तो हम clinic में हमारा आते हैं लोग, right? They आ रहे हैं, we're seeing dermatology, rheumatology. They come with all sorts of diagnoses. This woman has a major psychiatric disorder. She has obsessive compulsive disorder, is severely depressed. And
no doubt it was a very, very useful talk, and we came to know about a very large number of new molecules. The case you showed in the last, that the one, it was not responding, the PG on the nose. Wasn't it giant cell arthritis?
Actually, great question. We actually asked that question. We did some biopsies off the local area. There was no GCA though. But that was one of our concerns because when he came in...
That's why I responded to cyclophosphamide.
Yeah, no. He had incredible headache, But that was because he had sinus infection as well. But luckily, the biopsy did not show a granulomatous dermatitis and change. But great question. So we tried to rule it out. But you're right. You know, for Wegener's and for GCA, cyclophosphamide works very well. Do you guys use oral cyclophosphamide here or not much? Oral? For pemphigus? Okay, Azim कह रहे हैं कि he uses for scleroderma, especially of the lungs. Side तो यार publish करें कुछ किया हुआ publish करें so we can learn from you. We have to learn because cyclophosphamide is such a great drug. Oral cyclophosphamide is so much easier to use, but in the US dermatologists are too scared to use it. We use it because we work with rheumatology. IV is a little harder, but oral is great. So you use it for scleroderma. What else? Pemphigus? You use cytoxan pemphigus or not?
Use those. अब तो हम सारे biologics use करते हैं. It is life changing for most of the people, and it is actually if we buy one 500 milligram injection, the company has been kind to give us the second injection free.
Great.
So it has become very affordable for most of the patients, and especially if you are going to give like 1 or 2 grams in a year, that's pretty reasonable.
That's great.
Yeah.
Rituximab,
yeah.
That's great. Great, thank you so much.
One more question.
Oh, sure.
You did not take name of mycophenolate mofetil, which is a very commonly used drug nowadays in many indications, especially in pemphigus. So what is your experience regarding
Yeah, you know, we love using mycophenolate. It does not work in our hands. I mean, it doesn't work for psoriasis at all. It does not work for all the lupus dermatomyositis type disorders, but it works beautifully for all the blistering diseases. Yeah, scleroderma works beautifully, but for lupus, dermatomyositis, for some reason, it does not. Now, in patients who have dermatomyositis-related lung disease, it works well. But we love using it. So we love using a combination of mycophenolate plus thalidomide. So thalidomide plus mycophenolate for severe scleroderma also. It works. Now, of course, we have Actemra, but I like the molecule. You know, it's interesting. Mycophenolate is quite immune suppressive. We see a lot of zoster, shingles with it. For the residents, what is the one drug that can cause agranulocytosis with mycophenolate? Valacyclovir. So if you get a patient with mycophenolate who gets shingles, please stop the mycophenolate when you're treating the shingles, because you can Google it right now. There's a rare, you can basically drop, you can make them neutropenic if you combine valacyclovir plus mycophenolate. So just be very careful. If they get shingles, stop the molecule. By the way, that reminds me, we could have talked about methotrexate. One thing to remember, because I saw this happen to me, to one of our fellows. Methotrexate is absolutely contraindicated in hemodialysis. You see a patient with renal, we worry about the liver, but if you see a patient with renal failure who has hemodialysis, please don't go near them with methotrexate, because methotrexate can kill them with one dose. 1 10 milligram dose, you're done, because it turns out hemodialysis does not get rid of the glutamated form of methotrexate. So methotrexate, the way it works is, when you get methotrexate, it gets glutamated in the liver. So it's a glutamation process. Glutamated methotrexate is the active moiety. Does not get hemodialyzed. Remember, methotrexate is metabolized in the liver, glutamated, but it's excreted by the kidneys. So we had a patient many years ago who essentially got 1 dose of methotrexate, 10 milligrams, because the renal fellow approved it without talking to their attending. The senior nephrologist didn't know, got 1 dose, got a mucositis. Went for hemodialysis. The nurse called me from hemodialysis and said, your patient, she's bleeding everywhere. Because, when you get hemodialysis, you get heparinized. They gave her heparin. She already was neutropenic. Platelets were 20,000. White count was 0.5. And she got a second dose of methotrexate. It took us 11 or 12 days of GCSF, GMCSF to bring her white count back up. So hemodialysis, no methotrexate. And mycophenolate, if they get shingles, herpes zoster, please stop the mycophenolate if you put them on valacyclovir. Thank you.
Excuse me.
So, Dr. Zim Boucher, he's asking for lichen plantar pilaris, any new molecules. So we love using, so our typical, for all lichenoid disorders, we start with hydroxychloroquine, we add methotrexate, If methotrexate doesn't work, we'll switch to thalidomide, and then we'll go to JAK inhibitors right away. And JAKs clear them. LPP, it's beautiful. It shuts down the inflammation. I mean, you can't rescue the old hair, but you can stop the disease from progressing.
Thank you very much. Yes, Dr. Qureshi, it was a beautiful presentation and a lovely, we had a very illuminative roundup of all the new drugs, of the old diseases being treated with new drugs. I just had one question about the JAK inhibitors, that you shared your experience. I just want to know how long can JAK inhibitors be continued? They are quite expensive, and can they be used as adjunct to other drugs?
So great question, Professor Mees. Thank you. So, JAK inhibitors, as you know, can be used with methotrexate because we use them all the time in rheumatoid arthritis. So methotrexate plus JAK inhibitor seems reasonably safe. The duration of therapy is a great question. In dermatology, when I trained 20 plus years ago, we were trained to start therapy when disease got worse and stop therapy when it got better. So we treated disease intermittently. Now the new trend is we're doing disease-modifying therapy. So you're modifying the disease course, so you leave them on therapy long-term. The problem is phase 3 clinical trials only tell you about short-term efficacy and short-term safety. The real data on long-term safety is from phase 4 studies. So you have to watch the data carefully because you have patients on long-term therapy. So the answer is we don't stop therapy anymore. We continue it long-term, but we're just very careful to watch our patients very carefully long-term.
I have a question.
Sure.
Thank you very much for a very enlightening talk as always. I have a question related to the Botox you mentioned for Raynaud's. So for how long the effect is maintained, number one, and if you don't see the response within 24 to 48 hours as you mentioned, can you repeat it again?
Yeah, so good question. So you can repeat it again within a week, but usually you get a response right away if you get 4 units on each side, so 8 units per digit. And it lasts for about 3 months for that finger. So that digit, they get immediate benefit, and if you see the patient back within 2 weeks, and you just touch the finger, it's warm. It's amazing how fast it works. So I was joking, but I wanted to show you that medical dermatologists also use Botox.
And I have another, just an observation.
Yeah.
Are these patients not using the thermoregulated gloves kind of things for such Raynaud's? Are they not helpful?
So the great question.
Because in our country, we have the limitation of the availability of those thermoregulated socks and the gloves.
Absolutely.
But I was wondering for your hospital, if the patients are coming that way, it's really,
No, so it's a great question. What we tell patients, at least in our neck of the woods, is when it's snowing, it's very cold, like in Pakistan's north. When you wear gloves, you don't want to wear gloves with 5 fingers. You want to wear mittens because the 4 fingers together are warmer than gloves. So that's the number one thing we tell them. Wear gloves. Second, you can now get these gloves that have battery packs. So you hit the button and it heats up your hand. So they need exogenous heat and etc. I was actually looking at, there's something called, you guys know more about it. Kangri ka naam suna hai? Kangri. Kya hoti hai wo? It's a heater. And Kashmir mein, they get something called Kangri cancer. Where does the Kangri cancer occur? On the belly and the legs, on the thighs. Because they typically keep the Kangri in somewhere like, in a sheet or around a robe. But anyway, so it's interesting. Exogenous heat is the key. And I always think about Kangri when I think about exogenous heat because that is a great form of heat, but you can imagine it causes cancer. All right, thank you.
Thank you so much, Dr. Abrar. From your lecture, we do realize we have hope for disorders that were previously notorious for being resistant to treatment, and that was a very enlightening talk. So our third speaker for the day is Professor Shahid Javed. Do we have you here, sir? Okay. Professor Shahid Javed served for more than 13 years as the head of Department of Dermatology at Faisalabad Medical University. He has special interest in lasers, dermatosurgery, and contemporary medical teaching, and is actively involved in a lot of researches and academic activities. His topic of today's presentation is high fluence, low density fractional CO2 lasers for acne scars. We welcome you here, sir. I think it's going to take 2-3 more minutes, and then he will be able to join us on stage. I would request you all to please remain seated. Thank you, sir. Thank you for joining us today.
My worthy panel of experts, honorable guests, dear colleagues, and the young dermatologist, Assalamu alaikum. In next 10 to 50 minutes, I would like to share with you our experience with treatment of deep scars with targeted CO2 laser. We usually use high fluence and low density fractional CO2 to treat the deep-seated scars. I'm grateful to the organizer of this conference for providing us this opportunity to share our clinical experiences, and especially to the scientific committee and Dr. Sadia for organizing an excellent scientific program. I owe a great depth of gratitude to our great teacher, late Professor, the father of national dermatology, Professor Tahir Said Haroon, and the living legend, Dr. Mazurul Hassan. More than 90% of the dermatologists which we see today in our faculty, they are either directly students of these two or indirectly the students of their students. Faisalabad, the Manchester of Pakistan, and my home city. And
This is the acne, the bread and butter of dermatologists. Although it's a self-remitting disorder in majority of individuals, more than after a span of 10 to 15 years, majority of the patients, they remit spontaneously, but many of these, they have this type of scars, and it's especially embarrassing when they have this type of breast scars like these ones. We can classify or grade scars either depending upon their color or the depth of the lesions, and today we will concern only with these type of depressed scars. These are the ice peaks, box, and rolling scars, and as a dermatologist, you are familiar that these types of scars, they are difficult to treat. You can treat these with topical therapies, and you can treat with these, it's usually spontaneously remitting, self-remitting, but you can treat the keloidal scars with the 5-fluorouracil and a combination of intralesional steroids. But these are the deep scars which are difficult to treat, the rolling scar, the ice peaks, and the box scars, and we will talk our experience with treatment of these scars. The management is slightly difficult since you have to take care of the epidermal and dermal problem, and you can either resort to subcutaneous incision surgery when the scars, they are tethered to the underlying tissue. Punch, excision, grafting, theoretically that seems very fascinating, but the color usually doesn't match on the face. And you can simply use the punch elevation that you excise these depressed scars and elevate the punch, but even then the surface, the epidermis texture, that cannot be treated with these type of procedures. The fillers, obviously either you can use the platelet or the synthetic ones, but again the abnormality of the epidermis, they cannot be treated with these, and if the lesions, they are tethering to the underlying tissue unless you do the subcutaneous incision surgery and combine it with the fillers. The results will not be a good one. Rather, you will end up with donut appearance of these scars. The dermabrasion, the classical dermabrasion in which you ablate the whole of the epidermis and the upper part of the dermis is now outdated. Similar is the conventional laser resurfacing, since the downtime is very prolonged one and it's very risky in our clinically pigmented skin. Nowadays we have the fractional one, and we have two types, the ablative one and the non-ablative. The downtime with non-ablative is minimum, but at the same time the efficacy of these non-ablative lasers, that is also minimum. So we are mainly treating with fractional CO2 lasers, and these lasers, they operate in the range of this wavelength, 10,600 nanometer, and the absorption, the chromophore is the water, and water is present in epidermis and dermis. That's why we can target both the epidermis and the dermis, especially the papillary and the reticular dermis, and you can ablate the column of the skin. The absorption is high, so although there is risk of post-inflammatory pigmentation, but you can ablate the whole columns in a fractional manner. This is the concept of fractional laser, that is you ablate fractional of the epidermis, remaining islands of the skin, they remain intact, and that's why there is rapid re-epithelialization from that remaining skin. And this is the histological picture, that is within 7 to 10 days you get complete re-epithelialization, that is very rapid as compared with the convention one, in which you get re-epithelialization after 2 or 3 weeks. This is animation showing you how these types of fractional lasers, they operate. That is, they remove part of epidermis and increasing the intensity of laser beam, you can go deep as far as you can. And by this way, you can ablate, practically ablate the damaged area, not only the epidermis, but the dermis one. This is a close-up with 19 millijoules, and you can see these white, these are the vaporized central area, but you can see the intervening skin also contracts, and that's the beauty of CO2 laser, that also leads to modification or new collagen formation in the skin, which is not directly targeted. The close-up again in slow motion, and you can see the contracture, the immediate contracture, since the collagen fibers, they are heated up, so the skin becomes tightened, and there is immediate remodeling of the skin. As I said earlier, we can go deep as far as we like to do, and simply by increasing the energy. Currently, majority of dermatologists, they are operating the laser in this range, 25 to 50 millijoules, but we usually go for the highest, since we want to treat the deeper papillary and reticular dermis with the fibers they are damaged, and that's why we are sharing this experience of treating with high intensity, focused or targeted CO2 laser. And this is again a schematic representation that unless you treat the base of these scars, like these ones, the results will not be sufficient ones. You have to have an optimum energy of 150 to 160 millijoules. That is quite a high energy, but in order to avoid these side effects, we decrease the density or the percentage of the body surface area that is being treated with this sort of laser. This study was conducted in a private setup, and after getting the informed consent, inactive, but and the individuals, they were off systemic therapy, but obviously they were applying topical retinoids as maintenance therapy. And individuals with any other concomitant medical illness or disease, they were excluded, and the tendency towards keloid formation and the immunosuppressant, that patients taking immunosuppressants, and they were also excluded. Immediately before the therapy, they were given oral antiviral, and antiviral, they were continued for 5 days. We did not use anti-systemic antibiotic, only was applied to the lesions, and they were instructed to avoid undue exposure to sun. Who started after 10 days topical hyperpigmentation, or they restarted their routine use of topical retinoids after 2 weeks. We mainly use topical anesthesia, and in some of the individuals, the chilled air cryogen was also employed during the procedure, and these were the parameters we utilized. The laser we used were of Fexis. It's a Korean brand, and it has a pixel size of 100 micron. Energy was tailored depending upon the thickness. In females, because of their thin skin, we usually remain on 130 to 140, but for male, for thick skin, 150 millijoules, and in some of the individuals with thick skin, especially the male patients, we have to have 2 passes, and the coverage was 20 to 25. It's a quite high energy. That's why we focused our laser beam or the scanner only to the area which are involved. This is the picture. You can see the scanner size is usually 3 to 4 millimeter. The individual acne scars, the individual lesions, not the whole area, but the individual lesions there were targeted, and you can see the immediate effacement. Unless you see 70 to 80% of the immediate effacement, like this one, the results, they are not going to be good after the treatment. So you have to tailor the energy depending upon the depth of the scars, and this is what we call it targeted high intensity, high influence, low intensity laser therapy. And the clinical endpoint was the significant scar effacement. By effacement, we means that this is the pre-treatment and this is immediately after treatment. Unless you get 80 to 90% of the filling of the scars immediately, the long-term result will not be good one. 2 sessions, 6 to 8 weeks apart, and follow-on evaluation was done after 3 months, although it's documented that continuous remodeling continues to occur even after 5 to 6 months of a single session of fractional CO2, but because of the limitation of the study, we kept the 3 months. And the evaluation was on-site clinical assessment on a visual grading scale of 1 to 10. 30 patients they were recruited. Majority of them were females, and but unluckily 40% they did not complete the whole trial, and we can evaluate only 18 patients, that is 60%. And then 3 months after the 2 sessions, on average, around about 65% of the improvement was seen. This was the immediate before the treatment. This yellowish or blanching is because of application of topical amla cream. And this is the picture immediately after this session. You can see there is a slight oozing, and this is because the intensity is very high, and that's why the capillaries in the papillodermis, they are also damaged, and you get some oozing, and these are the results after 3 months. Another patient, and this was a comparatively patient with darker skin, and that's why still after 3 months he's having some redness, and this redness is also because of topical use of retinoids, which we, as I said earlier, since majority of the patients, they are using topical retinoids before the treatment as a maintenance therapy for acne, and they restarted the treatment after 2 to 3 weeks. And this is because of that retinoids. But there is usually 50 to 60% improvement in the scar. Another patients, and again, a comparatively 10 patients, and again, the other side of the same patients immediately after the treatment after 3 months. The complication, it's a bit painful since we are using very high energy, 150 millijoules, and again, 2 passes in some of the male patients. So we have to take the help of topical. In addition to topical application of the amla cream, we have to sometime during the therapy use the chilled air to control the pain. Bleeding is the predictable immediate side effect, but the most difficult to educate the patients and to manage is the post-treatment pigmentation. Unless you educate the patient and you yourself understand that this pigmentation is part of the healing process, and it usually takes 4 to 6 weeks, it becomes difficult for the patients to accept this and to treat this. But you have to educate the patient before going for any treatment that their pigmentation will take some time, usually 4 to 6 weeks, and we usually start after the treatment a tailor-made cocktail of glycolic acid, hydroquinone, and we again start using retinoids after 2 weeks. But this pigmentation usually takes around about 5 to 6 weeks to settle down, but the results, they are good. In short, the targeted high fluence, low density, fractional CO2 laser is good option, but the patients and the treating physician should understand that post-operative pigmentation is a part of healing process and will usually take 4 to 6 weeks. Thank you. Thank you for your listening.
So now that we're done with today's talk, I would like to ask the audience if they have any questions for Dr. Shahid. Any questions so far? Okay.
Thank you, Dr. Shah. It was a very nice presentation, and fractional carbon dioxide is a long-standing, well-recognized treatment for acne scars. Do you have any comparative data comparing this fractional CO2 with PRP microneedling? Because I personally feel that sometimes in our patients, fractional CO2 does cause post-inflammatory hyperpigmentation, whereas PRP microneedling gives good results without any sort of this threatening post-inflammatory hyperpigmentation. And the third thing is that in some stubborn patients, we do combine fractional CO2 with microneedling, either with some kind of mesoserum or maybe PRP. So your experience on that?
As I said earlier, pigmentation, you should understand that it is a part of healing process. Just like bleeding and crusting is inevitable immediately after the therapy, the pigmentation will last for 4 to 6 weeks, and it should be considered as a part of healing process. It's bound to happen in our racially pigmented skin, and it usually settles down in 6 weeks' time. I have not done any comparative trial with the PRP and CO2 because I think the documents and the literature support this. There is no comparison of fractional CO2 with PRP. Fractional CO2 is far better than PRP. It physically ablates the whole of the epidermis, the damaged tissue in which there is texture change. It ablates the whole of the column of epidermis and the dermis. Yes, PRP does give you new collagen formation, but only in the dermis, and you are not removing the damaged textural epidermis and dermis. Unless you remove the damaged tissue, there is obviously microscopic evidence of new collagen formation with PRP, but clinically the effects not. Individuals who are doing PRP, they are familiar that clinically the effects not as rewarding as CO2. There is absolutely no comparison with PRP, absolutely. Yes, you can combine, but even with CO2 alone, there is new collagen formation even after 4 to 6 months of a single session. The new collagen continue to grow even after a single session after 4 to 6 months. It's comparatively easy, and downtime is minimum. But if you are going for low downtime, then you have to resort to non-ablative lasers. Non-ablative lasers, although they are not as effective as ablative CO2, but the downtime is less. In the literature, they usually say that if you do 4 to 5 non-ablative laser sessions, they are comparable to one session of fractional ablative CO2.
Assalamu alaikum. First of all, please be quiet. Sir, very nice presentation. And there is a new concept that even you have to combine for these types of deep scars. You can combine various treatment modalities like, as Jan Sahab said, PRP or microneedle, and even in newer studies they are combining microneedling with CO2 fractional lasers in deep scars. And in our skin type, there is a huge risk of post-inflammatory hyperpigmentation. And so it's better to use low fluence as well as low density to avoid the post-inflammatory erythema, scarring, and PIH. And another thing is to avoid the complications, especially and specifically PAH. There are new ideas that, as you know, that there are microtunnels immediately after these fractional lasers, especially these CO2 one. So they recommend that you should immediately apply tranexamic acids or vitamin C or HA serums to avoid post-inflammatory hyperpigmentation and to speed up the recovery post-operatively. So I think that most of us who are having fractional CO2 in our clinics and even in the government setups, so I think we should learn from you, and what we can do, that we can add post-operative things like PRP or new serums in form of vitamin C, niacinamide, as well as ferulic acid to enhance the healing and post-operative complications after. Thank you, sir.
Obviously, the combination therapy will be better than the single therapy. The main purpose of sharing this experience was majority of our colleagues, they are using low fluence and low density. And the results, they are not good ones. I have seen patients who have underwent 8 to 10 sessions of CO2 laser with minimum clinical outcome. We have never done more than 2 or 3 sessions. Majority of individuals, they underwent only 2 sessions. Hardly 1 or 2 patients, they needed third session. So the main purpose of sharing this experience was use high fluence, and unless you have an 80 to 90% immediate clinical effacement, your end result will not be going to good. And in order to avoid this side effect, you go for targeted therapy, that instead of treating the whole of the area, you target the individual acne lesion. That obviously will take a little bit more time, operative time, but you can avoid the undamaged skin. And you only keep your scanner to the individual acne scar, but please go for high fluence. I don't want to see any patients who say that I have went 8 to 10 sessions of CO2 laser and still my acne scars, they are not a good one. And majority of patients you have seen, they usually complain of this. Obviously, the post-inflammatory pigmentation is going to be there. And I said earlier at the start of my presentation that post-inflammatory pigmentation should be taken as a part of healing process, and this should be understood by the treating physician and by the patient also. Unless the patient do not understand this, you have to refuse. And as far as the other combination, a majority of the patients, they are using retinoids as a maintenance therapy, and we again start topical retinoids and hypopigmented agents who usually start after reepithelialization after a week, and obviously the still epidermis is thin one, the penetration is going to be high. And one comment about the commonly commercially available serums with vitamin C. May I caution my youngster that being a senior, I know from where they are manufactured and who are the original manufacturer of these. And majority of these, please be cautious. Majority of these, they contain low intensity of topical these steroids. So please keep watch on the skin of your patients to whom you are giving topical steroids. Whenever they come after a month or so, in majority of cases, though, will be able to see thinning of skin and telangiectasia. Especially this mushroom growth of topical vitamins, they are manufactured by only 2 factories based in Lahore and with different names. So be cautious.
is Dr. Abdul Majid Baledai. I belong to rural Sindh and flood affectee. Sir, my question regarding treatment of acne scar. Treatment of acne scar, as you mentioned that laser therapy is the one of the best one. So either even after laser therapy, either chances of recurrences are more or less. And what is the ratio between male and female regarding laser therapy?
So laser is going to do nothing with the acne itself. You have to maintain the maintenance with topical application. Now it's the standard recommendation that even when patients, they are in clinical remission, you continue with topical therapy. In majority of cases, it's a topical retinoids, or you can opt for benzyl peroxide. So laser have nothing to do with acne itself. It's only for treatment of acne scars, the sequelae of acne. And in our practice, if patients, they are not using maintenance therapy, we refuse any laser therapy. Since when you apply topical ointment like Polyfex after laser, there is rebound or relapse of acne. That is going to happen. So if the individual is not using topical any maintenance therapy, whatever you have applied, simply refuse any laser therapy. And please do not do unless there is clinical remission of acne. And the laser is for treatment of acne scar, not for acne.
Thanks a lot, sir. Sir, my question is
I'm so
regarding...
sorry. This is the last question we'll be taking because we're running late for the second session.
So my question is regarding the aftercare. You mentioned antivirals that they should be given before the treatment. That they should be given if the patient is giving history of herpes labialis, or it should be given in any case?
Initially, not as a part of study. Initially, we was reluctant to use antiviral, especially in individuals who were not having very extensive acne scar, and they did not need extensive treatment. But one of my patients developed herpes after that. So it's now part of the routine that we start before therapy. 6 hours before laser therapy, we advise them to take antiviral oral, and we continue throughout the healing process. That is usually for 5 to 7 days until their scars.
Topical only, sir? So it should be topical only?
It's oral, not the topical one.
Oral.
We go for topical Polyfex, the oral antivirals.
Okay. Thank you, sir.
Thank you. Thank you very much.
So now that we're done with today's talk, I would now request our Honorable Chairperson to please give... Now I would like to introduce our speaker, Brigadier Asher Ahmed, who is the head of dermatology of CMH Rawalpindi. He is supervisor and examiner with CPSP and is a very staunch promoter of academic activities. Sir, can we please have you on stage? And his topic of today is clinical training in OPD, comparison between direct and indirect observation. Thank you, sir.
Let's go on. You're on. Assalamu alaikum. My today's talk is regarding medical education. So you, all of us who are supervisors and teachers, they come across this issue, that is, they are sitting in a busy OPD
and they are short of time, and they want to train their trainees as well. So how this OPD setting is important as far as the training of trainees is concerned. So this talk has two parts. The first part is to understand the importance of OPD teaching and to highlight the ways and means to effectively conduct the OPD teaching both for the under and postgraduate students. And second part is a little survey, and this is a survey which I took from my trainees at MH and CMH, and this is the learner's perspective of seeing OPD while sitting in the consultant office with both its merits and the demerits. So clinical training and OPD. For teachers of medicine and allied, the outpatient clinic promise many unique educational opportunities that include a very comprehensive observation of chronic diseases, a closer relationship between teachers and the learners, and an appropriate forum for demonstrating medical interviewing and counseling skills, teaching psychosocial aspects of the disease, management, and the preventive strategies. Then it is also a way to show your attributes as a clinician. The teacher's perspective of OPD teaching. Teachers say that they have little control over the distribution and organization of this time as they are under pressure to finish their patients rather than wasting time in teaching. The clinicians must address the concern of each patient and have little or no time for more elaborative instructions, typically 1 to 2 minutes or less for a case which has come in the OPD. So many treatments are based on organic findings and are intervened with psychosocial issues. So the empiric treatment and personal experiences, many of which are non-bookish. So many of us are in OPD, they are giving treatments in a non-bookish manner. And most of the clinicians don't feel confident teaching the same to their students as well. Challenges of clinical training in OPD setting. The environment variables. The environment variables which affect the teaching at OPD include the time, the workload, and space for teaching, and the teacher's attitude. Effective teachers ask questions, show interest, define goals, demonstrate competence, and most importantly, spend time with the learners despite of the workload and time constraints. The learner's perspective. Medical students often rank their outpatient experience better than their inpatient experience, although formal testing reveals no difference. The postgraduate students have a mixed input, and which will be highlighted in the survey. Role modeling. Whatever the teacher does in his OPD is being closely monitored by the learners, and both positive and negative attributes of teachers are being discussed and influenced to the learner. They will definitely benefit if they have the opportunity to observe number of consultants in their OPD so that they are able to pick up good and avoid bad attributes. Then responsibility of clinical teachers in OPD. So their responsibility is to create an opportunity and space for meaningful dialogue with the learners and asking effective questions to conceptualize the general principles of patient care, and teaching one general rule per patient is more than sufficient. With learners who are inexperienced, like medical students, teachers will often use 2 other teaching strategies, and these teaching strategies are the priming and modeling. So priming in OPD. To prime a learners means to prepare the learners immediately before the patient encounter. Priming is especially important for medical students who lack the experience in recognizing the diagnostic issues. So there are two type of priming. One for the patient with new problems, and second is for patients with a follow-up visit. Priming for new problem. The teacher goal is to ascertain that the student's background knowledge and at the same time equip the students with the information necessary to recognize the clinical features and build up the diagnosis, such as recognizing a patient presenting with an erythematous scaly rash and making a final diagnosis among the possible differentials like psoriasis, eczema, and CTCL. So priming in follow-up patients consists of questions about the disease, drug complications, and managing of those complications. Priming for scheduled patients. If you know that such patient is going to come in the OPD, the consultant asks the students to read about a particular disease before that patient arrives in the OPD. Like a patient of lepromatous leprosy is scheduled at 10 a.m., I want you to read about this patient before he arrives. So this is, you can see how you can save time. Then modeling in OPD. When modeling, the teacher simply thinks out and shares the clinical hunches and insights, shares the general rules, and point out the controversial issues or provide a rationale for which to accomplish during the visit. This can either be done immediately after the patient visit or later when the OPD is not that busy. Modeling helps smooth the patient flow through a busy clinic effectively and provides opportunity for learning as well. The most important technique for modeling is for the teachers to identify which specific behavior he or she wants the learner to observe. For example, a patient with a recently diagnosed SCC arrives for a follow-up, and the teachers could say to the learners, before entering the room, the patient enters the room, I would like you to observe that how I share the bad news with the patient. Then feedback in OPD teaching. Effective feedback consists of specific statements about directly observed behavior of the students while they are seeing the patients, in a non-judgmental language, and balanced description of the learner's strength and the weaknesses. The group receiving feedback performs significantly better over the subsequent 6 months. On many occasions, the teacher can deliver the feedback to the learners in the patient's room, especially when teachers agrees with the learner's diagnosis. Yes, I agree that it's a benign intradermal nevus. Even when the teacher disagree, the feedback sometimes best delivered in the room. For example, you know, I think that it's actually a seborrheic keratosis and not a solar lentigo because it is slightly raised horn cyst and appears as if it could easily be picked off. So the feedback can be given at the same time the patient is being seen by the learner. Feedback can be given after the OPD. You can continue with your OPD and the feedback can be given at any time at the end of the clinic, reviewing the general rules encountered earlier during the day and organize a variety of other educational activity. Give a verbal account, use a written material or some digital information regarding the case through WhatsApp, and can ask the trainees to come next day after studying the interesting cases we saw in the OPD and get a PowerPoint presentation of those cases. So in conclusion, one of the strengths of OPD education is the opportunity for the learners to interact with the patients and teachers at the same time. When teachers ask questions, present general rules, and have a healthy interaction, this is a good opportunity for teaching in an otherwise hectic day. The trainees are able to fill up their knowledge gaps, improve their clinical and social skills, and develop confidence in managing the patients independently. Under the influence of good clinical teachers, the learners want to emulate the teacher's attributes towards the patient care. So this is a small survey which is based on the student's perspective on direct and indirect supervision in an OPD. This survey was conducted among the dermatology residents of MH and CMH Rawalpindi, who are exposed to the clinical teaching in OPD both by sitting with the consultants and sitting independently in the OPDs. The survey is comprising of open-ended comment in response to a single question. What, in your opinion, are the advantages in seeing a busy OPD with the clinical consultant or supervisor in the same room, that is direct supervision, and seeing an OPD independently and the consultant available in a different room for difficult patients, that I call as an indirect supervision. Merits of attending OPD in a consultant office direct supervision, the different responses. The trainees, these are the responses which I received from the trainees. So these are the qualitative responses. The trainees should be under direct supervision in their first few months of, that is the first year of training. 100% of the trainees who were given this survey, everyone agreed on this point, that all the trainees should be under direct supervision for the first few months of their training. Clinical supervision is a professional development activity where the trainees have a great opportunity to utilize the knowledge and skills of their seniors. Almost all of the trainees were of this opinion. 70% of the trainees thought that direct supervision filled their knowledge gaps. 55% of the trainees think that it improves the social and clinical skills and improve the skill gaps. 66% of the trainees think that it improves one's clinical acumen if they are directly observed. 35% think that it builds the personal confidence, the therapeutic knowledge, and critical thinking. And 40% thought that it improves their patient interaction, assessment, management, and quality of care. 10% think that identifying the non-bookish pattern of case variability and current treatment plan was helpful. 10% of the trainees think that they could borrow the tailor-made formulas of the supervisor's personal experiences. 50% think that chances of error in making wrong diagnosis is less if they are in the same room where the consultant is sitting. 50% think that it helps in identifying the mistakes and correcting them in the right way with necessary feedback and guidance for correction. 90% of those think that the trained learned methods and practice are applied throughout their career. So if they learned improperly, it will be reflected throughout their life that may lead to malpractice. As far as the role modeling is concerned, most of the trainees were of the opinion that witnessing the consultant's attributes towards examining, inquiring, investigating, and managing patients helped them. And almost all of them, they think that they increase the opportunity to observe the consultant procedural skill also helped them improve their procedural skills. 50% think that the personal experiences shared by the consultants about the atypical or rare presentations or even common diseases enhances their vision of dealing with those diseases. So these were the few demerits through the responses of attending the OPD in the consultant room. In third year of training, the registrar should be sitting independently in office next to his supervisor so that he or she can guide in case of any problem. And 40% of the trainees gave this response. These were mainly the senior trainees. Direct supervision may influence the trainees' own observational, analytical, and decision-making skills. the spoon feeding phenomena. 40% of the trainees gave this response. Again, 40% of the trainees, these were mainly the senior trainees, told that it will cause less development of one's own independent clinical and communication skill with the patient. And the same number of trainees said that it hinders their brainstorming process. 20% said that it is prone to dependence and low self-confidence while managing the patients alone. So there are 10% said that there are many occasions where the trainees have to act as yes man to the supervisor despite of having a conflicting view about the patient management. 10% said felt a little anxiety in seeing patients in front of the consultants. 40% of the trainees think that the indirect supervision allows for progressive autonomy needed to become confident in managing patients without compromising on the patient's safety. So on the basis of two conflicting views of the trainees, the conclusion is majority of the trainees, especially of first and second year of training, were in favor of direct supervision while attending their OPDs. They think it fills the knowledge gaps, improves the clinical acumen, and most of them were in favor of role modeling of their supervisors. While the majority of trainees of the last year of training wanted independence in making decisions in OPD and were happy if they are indirectly observed. This is my OPD, and thank you very much for the organizers of this workshop. If there are any questions, I am flood effect is.
Sir, regarding this session question, if you will allow me, that I should have to come in front of you and become a patient of melasma, and your client are patient. Within
Sir,
3 minutes.
We don't have the time for that, sir.
Within 3 minutes. Within 3 minutes, I want to see your behavior, attitude towards me. Within 3 minutes. Within 3 minutes. Yes. Sir, imagine I am patient of melasma and I am your patient. I have visited so many times and now again I have come to you. Sir, आपने डॉक्टर साहब अंकल आपने जो दवाइयाँ मुझे दी ना अंकल हाँ एक तो जलन हमें होती है कि हमें वो अंकल कहती हैं दादा कहती हैं उससे तो फिर और जलन बढ़ जाती है हमारी तो हम तो परेशान रहते हैं इसमें तो अंकल डॉक्टर ये जो आपने दवाइयाँ मुझे दी थी तो वो मेरा शोहर मुझे मार रहा था कि इतनी महंगी दवाइयाँ ली और आपको कुछ फायदा नहीं हुआ मेरे लिए कुछ करें मैं तो इतनी परेशान हूँ एक तो शोहर मुझे मारता है और मुझे फायदा नहीं हो रहा जितने भी आपने दवाइयाँ दी हैं उससे फायदा नहीं हुआ
पहली बात तो ये है कि आपके जो मुलाजमा है इसके आपके शौहर के मारने का कोई ताल्लुक नहीं है तो पहले तो शौहर से ताल्लुकात ठीक करें कि वो मारदार कम करे आपकी
बात अंकल जी आपकी सही है लेकिन पैसे तो वो ही देता है ना मैं कहाँ से लाऊं सारे पैसे तो मुझे वो दे रहा है और उसकी वजह से वो खुद भी परेशान रहता है मैं परेशान रहती हूँ क्योंकि मुझे तो शादी ब्याह पे जाना है उधर तो लोग मुझे वो जितनी भी मेरी सहेलियां हैं वो मुझे डांट कहती हैं इसका मुंह क्या है और फिर कोई मुझे लिफ्ट नहीं कराता मैं परेशान रहती हूँ डॉक्टर साहब मेरे लिए कुछ करें हेलो हाँ 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 मैं आ रही हूँ अभी डॉक्टर साहब के पास बैठी हूँ थैंक यू
Wow, that was very interesting. Now I would request our Honorable Chairperson to please give his concluding remarks. Professor Ijaz Hussain, can you please come here and give your concluding remarks?
Bismillahirrahmanirrahim. On behalf of all the panelists, I am presenting these remarks. All the presentation of this session were very informative, illuminating, and enlightening. As Professor Babar Rao Sahab discussed the new treatments of pigmentary disorders. Regarding melasma, there is a variant which is known as erythematotyl variant. Particularly, and these sessions are very interactive. A lot of questions were asked and they were answered. People shared their experience. Anything which induces inflammation in the skin, especially the skin of color, it will lead to worsening of the melasma, whether it is medical treatment, whether it is procedural treatment due to lasers, chemical peeling, etc. So we agree that there is an induction phase and there is a maintenance phase, and the disease is bound to recur. And regarding vitiligo, sir, my personal observation is that like psoriasis, melasma, vitiligo, perhaps these are heterogeneous groups which clinically present as pigmentation or depigmentation. They have a lot of different mechanisms. That is why no single agent is effective, and often we have to use more than one treatment. And the second presentation by Professor Abrar Sahab, that was also very elaborative. There is journey from broad spectrum immunosuppression to targeted immunosuppression. We are having new drugs. Obviously, they target different interleukins, different molecules. And thank you very much for sharing their experience with us. Many of the medicines which are not available in Pakistan, and we hope that they will gradually become available here. Few of them, they are in the market now, like tofacitinib and Actemra. And then the presentation by Professor Shahid Javed Akhtar, people present for acne scars, and we have to do something. Thank you very much for sharing your experience. Different people, they have their own experience. Perhaps the best treatment regimen is that which produces result in the patient. And the presentation by Professor Asher Mashood Sahab, it was based on medical education. Many of youngsters, they will become teachers, they will teach, they will supervise their trainers. Direct observation, they should work directly under the supervisor or indirectly. जैसे बच्चा छोटा होता है ना, तो he needs more care. जैसे आपने conclude किया कि first or second year के बच्चे, they feel more comfortable with supervisor, and as they become mature, they reach third year, they want to become independent. बच्चे बड़े हो जाएं तो they want independence. Thank you very much, all the presenters, all the organizers, Dr. Sadia Tabassum and her team, and our friends from states, Professor Babar Rao Sahab, Professor Abrar, and Professor Shahid Javed Akhtar, Professor Asher Mashood Sahab, for wonderful presentation. Thank you very much.
Professor Ijaz Hussain, I would request you to stay on the stage because now we'll proceed towards memento distribution. I would like to invite the first speaker of the day, Professor Babar Rao, to please come here and receive his shield. Professor Babar Rao. Professor Abrar Aleem Qureshi, do we have you here? Dr. Abrar is not here. Dr. Babar Rao is going to take it on his behalf. Professor Shahid Javed, can you please come on stage? Brigadier Ashur Ahmed, can you please join us on stage? Now I would request Dr. Irfan Sheikh, Chairman of 41st PADCON, to please come on stage and present the memento to our respectable chairperson. Thank you. Thank you, sir. Thank you. Now I would request Dr. Naeem Iqbal to please come on stage. He is going to distribute the mementos to our respectable and honorable panelists. Professor Khabar Khurshid, can you please come on stage? Professor Faria, can you please come on stage? Professor Jameel Shaheen, sir, can you please join us on stage? Professor Rahim Bangash, can you please come on stage? Last but not the least, a shield for myself. Thank you to all the lovely audience for sitting here patiently and listening to all the lectures. We'll be moving towards a second session right after this, so please remain seated. Thank you.
If everyone could please be seated so that we can move on to the next session. Please be seated, everyone. So everyone, please, I request you all to take their seats. Assalamu alaikum, everyone, and good afternoon. Welcome to the 41st PADCON. My name is Dr. Sana Siddiqui, and I will be the moderator for this session. I'm a senior registrar in dermatology at the Hamdard University Hospital, and I'm also practicing as a consultant dermatologist at the Maiman Medical Institute. I hope you're all enjoying the session so far. Thank you to the Pakistan Association of Dermatologists and the committee members for organizing such information-packed lectures for us all to gain from. We have again an amazing lineup for you in this session. The speakers are well-distinguished dermatologists. I'm sure you're quite familiar with all of them. But before I go on to introduce them to you, let me first invite and introduce our chair for the session, the most respected Major General Zafar Iqbal Sheikh. He has a number of accolades. Besides holding several qualifications, both national and international, he has served as a professor and supervisor in dermatology at the Army Medical College and Military Hospital in Rawalpindi, and is currently a visiting professor of dermatology at the Rawalpindi Medical University. He was the Dean of Faculty of Dermatology at the CPNSP and has the honor of being elected twice as the President of the Pakistan Association of Dermatologists. He was awarded the Hilal-e-Imtiaz Military in 2019 in recognition to his meritorious services in the field of healthcare. Major General Zafar Iqbal Sheikh, if you could please come on the stage, sir. A round of applause for Major General Zafar Iqbal Sheikh. Major General Zafar Iqbal, if you could please join us on the stage. Next, I would like to invite our esteemed panelists to the stage. Our first panelist is Dr. Tariq Mahmood Malik. He is the head of Department of Dermatology at the PNS Shifa Hospital and the Bahri University Medical and Dental College, where he actively conducts academic activities and has several research publications. He is an examiner and supervisor of FCPS and MCPS dermatology. Sir, if you could please have you on the stage. Our second panelist for the session is Professor Atif Kazmi. Professor Atif retired as the chairman and head of the Department of Dermatology at the Mayo Hospital, King Edward's Medical University, where he served in the position for more than a decade. He has been an examiner for FCPS and MCPS and has authored several books of dermatology. He is also the recipient of the Lifetime Achievement Award given to him by the Prime Minister of Pakistan in 2009. Please welcome Professor Atif Kazmi. Professor Atif Kazmi, do we have him here? Oh, sorry. Okay. Our next panelist is the ever so graceful Group Captain, Dr. Muniza Rizwan. She is the Associate Professor and the Head of Dermatology Department at the PF Hospital, Fazaya Medical College in Islamabad. She has a doctorate in medicine from the University of Manchester in the UK. She is the Vice President of the Pakistan Association of Dermatologists of the Federal Region. She is actively involved in academics, and she holds a special interest in photodermatology and biologics. Dr. Muniza Rizwan. Our last panelist is Professor Haroon Nabi. He is a professor and head of dermatology at the Lahore Medical and Dental College. He is an examiner of FCPS and MCPS dermatology program. Professor Haroon Nabi is a well-seasoned dermatologist and an aesthetic physician. He has conducted several aesthetic training workshops as part of the Pakistan Academy of Aesthetic Dermatology and Surgery. Professor Haroon Nabi. Professor Haroon Nabi, is he in the hall? So he will join us shortly. So let us move on to our very first speaker of the session. Our first speaker is Dr. Shahid Sheikh. He is the Associate Professor and Head of Dermatology at the Faisalabad Medical University. He is also the General Secretary of the Pakistan Association of Dermatologists. Dr. Shahid has the honor of currently being the only one in the country who is a supervisor both in the field of dermatology and the newly approved field of pediatric dermatology. His topic today is Pediatric Dermatology, a spectrum of diseases from Faisalabad. Please welcome Dr. Shahid Sheikh.
बिस्मिल्लाहिर्रहमानिर्रहीम। शुरू करता हूँ अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम करने वाला है। Respected chairman, co-chairman and respected panelists, dear audience, अस्सलाम वालेकुम। इस दुआ के साथ रब्बी ज़िदनी इल्मा, ऐ अल्लाह मेरे इल्म में इजाफ़ा फरमा, और इस दुआ के साथ कि अल्लाह पाक हम सबको मक्का पाक और मदीना पाक की हाज़री नसीब फरमाए। Today the topic of my presentation is pediatric dermatology. The topic basically is the different spectrum or pattern of dermatological disorders in pediatric patients of Faisalabad. Pediatric dermatology are need of the hour. There is increase in the number of pediatric There is increase in the number of pediatric dermatological disorders in pediatric patients, and which provoke an important public health problem. The pattern of skin diseases varies from country to country and even region to region. 30% of dermatological disorders examined by the dermatologist, 30% examined by the pediatricians, and 40% by the general practitioners. The objective of this study is to determine the pattern of various skin disorders in pediatric patients and to take preventive measures for skin problems in children. This study was conducted at Faisalabad Medical University, which is affiliated with the 3 hospitals, DHQ Hospital, Allied Hospital, and Children's Hospital, Faisalabad. This is an observational study of 1 year duration comprising of all patients who attended dermatology outpatient department. A detailed history and cutaneous examination were carried out in each patient. Skin biopsies and other related investigations were performed where indicated for the confirmation of the diagnosis. Luckily, this study was published recently in 2022 in JPAD, January, February, March issue. And the front picture, we call it title page, is decorated with the pics of patients of pediatrics. This is the sheets of the patients, data collection sheets of the patients. Total number of patients visited in outpatient department were 24,342. Why it is not working? And the female patients were 11,245, which is 46%, and 13,097 in male patients, which is about 54%. Mean age range was 0 to 14 years, and the mean age is 6.2 years. 2 months to 6 years, the number of patients were 16,322, which is about 67.05%. 6 years to 14 years, more than 6 years to 14 years, it is about 8,020, which is 32.95%. The total number of pediatric dermatoses was observed were 183, and in female it was 142, and in male 149. Mostly observed dermatoses were papular urticaria, which is 26.21%, scabies 18.28%, folliculitis 9.11%, impetigo contagiosa 7.55%, atopic dermatitis 6.07%, carbuncle 2.8%, chickenpox 2.7%, contact dermatitis 1.5%, tinea corporis 1.36%, miliaria 2.3%, and oral candidiasis is 0.83%. This is about 16 type of dermatosis which were observed in 21,725%. You can see which is 89.31%. Only 16 type of dermatosis mostly cover these patients. Miscellaneous dermatosis were psoriasis vulgaris, acute urticaria, neonatal allele, juvenile dermatomyositis, infantile hemangioma, salmon patch, port wine stain, alopecia areata, vitiligo, and infantile acne. And the rare dermatosis, Cocaine syndrome, Kindler, lamellar, Perry-Romberg, xeroderma pigmentosum, NHAM, anhydrotic ectodermal dysplasia, multiple myeloma, cutaneous aplasia cutis, lipoid proteinosis, incontinentia pigmenti. Collodion baby cutis laxa, bullous ichthyosiform erythroderma, Shabir syndrome, Peutz-Jeghers, neurofibromatosis, Ringo, cyst adenomatosis papilliformis, blueberry muffin syndrome, EDV, erythrodysplasia verruciformis, and hydrotic ectodermal dysplasia. These are the pics of these patients. You can see the insect contact dermatitis. You can see the bulla formation at the bite of the insect, and the infantile scabies, pyoscabies, this is the impetigo, ectodermal dysplasia, and marginal alopecia areata, we call it aplasia, we call it ophiasis. If we return the spelling of ophiasis and the alopecia areata is present at the vertex of the scalp, we call it sisafu. We just to reverse the spelling of ophiasis. And this is the misuse of steroids are leading on the primary dermatosis leading to stria formation and the genital perianal warts. You can appreciate the miliaria crystallina and the abuse use of steroids leading to Cushingite features like buffalo hump, hypertrichosis, moon face, napkin dermatitis, and epidermolysis bullosa, infantile hemangioma, CBDC, chronic bullous disease of childhood, atopic dermatitis. Tinea capitis and the scrofulloderma, epidermolysis bullosa, Perry-Romberg syndrome, port wine stain, and the tinea capitis again in the form of chorion. You can see the lupus profundus, and this is the same patient with ulcer on the hard palate. This is the abused use of steroids leading to tinea incognito or modified tinea. You can see the viral infection, herpes zoster. This is the acrodermatitis enteropathica, again in Pediatric, and abscess formation. You can see the face, hands, soles with keratoderma, palms and soles, laminar ichthyosis, infant acrodermatitis enteropathica, again juvenile xanthogranuloma, and the periorificial granulomatosis. You can see the morphia and post-inflammatory hyperpigmentation after a drug reaction, number of multiple bulla formation when they heal, leaving behind post-inflammatory hyperpigmentation. And this is the hypertrophic type of lichen planus, again alopecia areata, and you can see the multiple discharging sinuses, which we call it in different diseases. You can see the Herald patch in Petasis rosea. Juvenile dermatomyositis, you can see the you can see at the elbows the calcinosis cutis. This is the Mijoki granuloma. This is the multiple freckles and lentiginous will fall into the name Lamb and Dapert syndromes, and the photocontact dermatosis, neonatal LE. And this is the EDV, epidermodysplasia bruciformis. You can see the petaceous versicolor-like lesions and the plain warts. This is the, you can see the cluster of jewel are in chronic bullous CBTC, chronic bullous disease of childhood. Epidermolysis bullosa again. This is a cradle cap and the post-inflammatory, post-herpetic hyperpigmentation and slight atrophy with serpiginous margins. This is epidermolysis bullosa. We call it butterfly baby. We have guidelines for the genodermatosis. I will share in the group. If we treat the patients with with butterfly baby or epidermolysis bullosa, if we have good nursing care, we have a good training in caring these patients, how to feed, how to pick, how to lift, how to drink, and how to decorate the room of these patients. These patients can grow normally and they live normally. We want a guideline about these patients. We call it butterfly baby. This is ectodermal dysplasia, and Julie is the renowned model and treated with good nursing cares with different seasons, and these patients is the renowned model in the world. These are the guidelines I will share in the group, how to handle these babies. In discussion, you have seen the atopic dermatitis is 6.07%, napkin dermatitis 3.11%, seborrheic dermatitis 2.55%. Most of the patients were between ages of 2 months to 6 years. About it is the percentage of 67.05%. So the conclusion is most of the diseases were benign, about 89.08%, which is 21,000 patients around about, were benign and need special healthcare consideration. There is less provision of primary healthcare facilities, less number of pediatric dermatologists providing first contact care. Dermatological disorders of pediatric patients have been underestimated in Faisalabad, but even in all over the Pakistan, which is a major healthcare burden that affects the quality of pediatric patients and their parents' lives. This is the third most visited subspecialty in Children's Hospital, At the top, peds medicine, peds pulmonology, and then pediatric dermatology. So, the emerging challenge for the dermatologist to prevent and reduce these skin diseases. So, special considerations need to be given to extend the public health initiatives for the improvement of skin disorders in children. Why pediatric dermatology? How it's a need of the hour. You can see 24,342 patients were examined. Only 16 types of dermatosis were examined in 21,725 patients, which is 89.31%. 167 types of dermatosis were seen in 2,617 patients, which is 10.69%. Miscellaneous group 8.32%, and rare group is 2.73%. So the suggestions and comments are 30% were examined by the dermatologist and 70% by the pediatricians and general practitioners. There is shortage of pediatric dermatologists nationwide from the decades. There is a lack of pediatric dermatology training. There is countless publications and educational activities. So this study sought to provide insight into the pediatric dermatology workforce. So the recommendations about provision of awareness about skin diseases in children, improve their quality of life by early management, and producing qualified pediatric dermatologists and promoting this specialty. Boost them and say to them, Geo, and enjoy the life more than normal. Anyone can describe this picture? I will appreciate their contact. You can see a number of patients are more in the left side and there is less dermatologists. But on the right side, the number of dermatologists are more and the patients are less. So right is right and right is always on right. These are the references of this study. Presentation is dedicated to all contributors and those who understand the need of pediatric dermatology. This is a book of Dr. Yasmina Khan, who is about 70 to 80 years old with young enthusiasm and having a soft heart towards the care of pediatric patients. And these are the number of certificates awarded to her: appreciation certificates, attendance certificates. A big hand for the Dr. Yasmina Khan. These are the different certificates, national-wise and international conference she attended. Dr. T.S. Haroon Saab awarded him appreciation certificates. You can see the international award she is winning. International award presented to Dr. Yasmina Khan. Anyone, where is Dr. Yasmina Khan? Yes. In the second row, behind the Dr. T.S. Haroon Saab, and just obliquely. Here is father of Dr. Yasmina Khan. Father is proud of her baby. एज जितनी मर्जी हो फादर के लिए बच्चे बच्चे ही होते हैं. So I request my seniors, my higher ups, to the pediatric dermatology is now recognized by the CPSP. It is in the website. I request my higher ups, deans, faculty members to please recommend her in the start of pediatric dermatology as honorary FCPS dermatology to Dr. Yasmina Khan. Thank you very much. Is there any question? Thank you very much. Assalamu alaikum.
Thank you, Dr. Shahid, for sharing the very interesting observations in your lecture. Moving on to our next speaker, he is the brilliant Professor Sahabzada Noor. He is the Chairman and Department of Dermatology Head at the Lady Reading Hospital in Peshawar. Professor Noor holds special interest in pemphigus and psoriasis and has given several talks on the subject on various academic forums. Today, he's talking on the management of pemphigus, local challenges and solutions. Please welcome Professor Sahabzada Noor.
Bismillah ar-Rahman ar-Rahim. Worthy chairman and the panelist and the audience, Assalamu alaikum. I have been given 10 minutes, but I think they have been cut short from 15 or 20 minutes to 10 minutes, but I would try to do justice with my presentation. So let's start. The title of my talk is The Management of Pemphigus vulgaris, Local Challenges and Solutions. All of my talk will be scenario based, so I would have an interaction, so I need your attention, please. जो बातें कर रहे हैं वो please attentive हो जाएं. I would like to have your input because what do you think about this scenario? So the first scenario is a 13-year-old girl diagnosed case of pemphigus vulgaris was on steroids and azathioprine. She developed septicemia with raised fibrin degradation products and D-dimers were also raised. Consolidation was not achieved with the conventional treatment she was receiving. What should be the next step in the management? Those not from my unit, जी बताएं trainees जल्दी जल्दी बताएं 10 मिनट में हमने खत्म करना है. क्या करेंगे इसको? Pemphigus के पेशेंट को सेप्टिसीमिया भी हो सकता है, तो how would you treat? स्टीरॉइड ज्यादा करेंगे, क्या करेंगे? बायोलॉजिक्स देंगे? जी बावाज़ बुलंद. आपने कंसोलिडेशन भी अचीव कर ली है, डेफिनेटली एंटीबायोटिक्स तो देने हैं, लेकिन व्हाट मोडेलिटी वुड यू अडॉप्ट टू अचीव कंसोलिडेशन? उसकी पेम्फिगस को कैसे कंट्रोल करेंगे? आई थिंक वी नीड टू मूव ऑन. सो दीज आर द मोडेलिटीज. इसमें से कौन सी चीज आप करेंगे? पल्स स्टीरॉइड से इसकी इम्यूनिटी फर्दर जो है ना नीचे आ जाएगी, उसकी सेप्टिसीमिया एग्रेवेट हो जाएगा. यू नेवर गिव जी यस IV immunoglobulins. So IV immunoglobulins is the ideal choice or the treatment when you need to treat a patient of septicemia or whenever the pemphigus you want to achieve consolidation और वहां पे जो है ना उसको septicemia. No, whenever the cell lines are deranged, immunity has to be enhanced, favorable side effect profile with IV immunoglobulin, and it is the treatment of choice in patients who are at the risk of infection and where there is a chance of viral reactivation, right? So we move on to another modality scenario. A 46 years old obese male, 6-year history of pemphigus vulgaris, uncontrolled diabetes and hypertension, presently on prednisolone 2 milligram per kg per day, which according to the guidelines is the maximum dose, and as azathioprine for the past 2 months with uncontrolled pemphigus. He has recently developed aseptic necrosis of the femur head What will be the next step for disease control? He is from a poor background. He cannot arrange the biologics. Rituximab वो नहीं ले सकते. अब बताएं इसमें क्या करेंगे? पंद्रह सेकंड में सोच के बताना है क्योंकि I have to finish it off also. Anyone? IVIG बड़ी एक्सपेंसिव ट्रीटमेंट है. वन साइकिल कॉस्ट 6 लाख to 8 लाख रुपीस. किसने बताया? एक्सीलेंट, एक्सीलेंट, बिल्कुल. नाउ दिस इज द ब्यूटी. आपने जो है ना लोकल चैलेंजेस को जरूरी नहीं है कि बहुत ही कोई हाई फाई ड्रग से करना है. देयर यू नीड टू थिंक आउट ऑफ द बॉक्स ऑल्सो. सिर्फ गाइडलाइंस को नहीं फॉलो करना है. यू नीड टू लुक एट दी हाउ मच योर पेशेंट कैन अफोर्ड. सो out of these, cyclophosphamide pulse or the plasmapheresis, they are the appropriate choice. But if you consider the cost, the plasmapheresis is expensive as compared to the cyclophosphamide. आपका 1500 में जो है ना cyclophosphamide की pulse लग जाती है, whereas the plasmapheresis would cost you 40 to 50,000 rupees. So this was the patient with aseptic necrosis. उसको हम mobilize नहीं कर सकते थे, भेज नहीं सकते थे, तो we considered the cyclophosphamide pulse for this particular patient. Another scenario, a 55 years old male case of pemphigus undergoes screening for latent tuberculosis prior to receiving rituximab therapy. His quantiferon gold TB test is reported as indeterminate. आप करवाते हैं जी quantiferon gold TB test? How many of you have administered rituximab to patients? quantiferon gold TB test करवाते हैं? उससे पहले करवाते हैं. indeterminate आ जाता है तो क्या करते हैं? अभी तक नहीं आया. नहीं तो फिर करेंगे क्या? indeterminate आ गया. Yes, it is done for the latent TB, but what would you do then? जी, latent TB नहीं मैनेज करेंगे. If it is indeterminate, so you repeat the quantiferon gold TB test. लेकिन pulmonologists, they say that you need to go on and move with, you can administer the rituximab, because we live in an endemic areas where the tuberculosis is quite endemic. So indeterminate has got no specificity. Guidelines आप देखेंगे तो वो कहेगा कि repeat करें, लेकिन when you consult a pulmonologist, so they say that you can administer the rituximab. Sir, what do you do in US if it is indeterminate?
Repeat the test.
Yes.
If it's still positive, then you have to check for pulmonary disease. But the problem is they get extra pulmonary TB, which is watch the patient carefully.
Thank you very much. In Pakistan, you would look for the history of tuberculosis in the family. You would go for X-ray chest. If they are normal and it is indeterminate, you can administer rituximab. Another one, a 40 years old male case of pemphigus vulgaris undergoes screening. Now here the quantiferon gold TB test is positive. कौन सा जो है ना ऑप्शन आएगा? Four months therapy with rifampicin. Right? We move on. Scenario number 5, a 45 years old male, known case of pemphigus, is scheduled for rituximab therapy after a month. What will be your strategy? कब देंगे आप जो है ना उसको vaccination? जी. Yes. Now, yes, it is 4 weeks. Now, it's very important that if you look at the guidelines, they say that you need to administer pneumococcal and influenza vaccine to the patient if he is receiving rituximab. We did our audit of the patients who had received the rituximab, and we found out that we do not administer influenza and this flu vaccine. So it is important that if you are giving someone rituximab, you need to give them influenza and pneumococcal vaccine. Sir, what do you do in US? Yes. So you need to consider, because this is important for the patients who are, how many of you people give, when you are administering rituximab, you give them pneumococcal and influenza vaccine? Yes, good practice. So we were not doing it, now we have made it a protocol that we give them. We move on. Another scenario is scenario number 6, a 40 years old male with well-controlled pemphigus on prednisolone and azathioprine. Now this is a very common scenario. Raised ALT 4 times than normal, what would you do? Let's go on to the scenario also. आपको options भी बता देते हैं. कितने लोग कहते हैं कि स्टॉप करेंगे? कितने लोग कहते हैं कि स्विच टू माइकोफेनोलेट करेंगे? Right? With raised ALT, you need to stop the azathioprine first. Once the ALT comes to normal, the ideal choice is that you switch to mycophenolate mofetil. So what do you do in US? You switch. But remember one thing, when you are switching to mycophenolate mofetil, it is more expensive as compared to azathioprine. So normally what we do in our practice is that we wait for the azathioprine, we stop the azathioprine, wait for the liver function tests to come to normal. Once they are normal, we reintroduce the azathioprine because it is much cheaper as compared to mycophenolate mofetil. What we have observed is that the liver function tests do not alter once you reintroduce. But rarely, in rare cases, if you see again alteration in the liver function test, the ideal choice is that you switch to mycophenolate mofetil. Right? You need to consider, you need to take into account the cost of the treatment. Patient के पैसों को जो है ना देखना है. If it is he is a laborer and he is taking mycophenolate mofetil, 300-400 रुपए, अगर वो 700 की दिहाड़ी करता है और 300-400 की मेडिसिन लिख देंगे तो उसकी compliance नहीं रहेंगी. You need to take into account these things. Scenario number 7, a young female, married female, case of pemphigus is planned for rituximab. What advice will you give her regarding contraception? Females ko nahi diya, married females ko. 3 scenarios left. So the ideal is that effective contraception during treatment and for 12 months after the last dose of rituximab. It is for the married females, not for the males. Why? Because IgG antibody pass the placental barrier and cause transient B cell depletion and lymphocytopenia in the newborn. Right? Or रहते हैं ये 12 महीने तक. That's why you need to give a 12 months gap. A young male diagnosed with severe pemphigus vulgaris received the first cycle. Tapering कैसे करेंगे with the rituximab के बाद आप steroids कैसे taper करेंगे? Now this is the chart. If the pemphigus is mild, you need to taper 0.5 milligrams से आपने start करना है, and this is how you taper it. And if it is moderate to severe, you start with 1 milligram in the first month and then 0.75, and this is you move on. It is contrary to, this is with rituximab. The next slide I have incorporated is, now this is without rituximab. And I have presented this slide on so many forums, but I see that most of the people, they still do not taper the steroids properly. And one of our study, we found that the faulty steroid tapering is the commonest cause of the relapse in pemphigus patient. This is the another one, hepatitis B. If we look at on practice, लगता ये है कि tuberculosis is the most जो है ना challenging thing with rituximab. लेकिन what we have observed, I think I would also ask the panelists, sir, how many times you have seen the reactivation of tuberculosis in pemphigus patient? In our practice, I have not seen a single patient of pemphigus being treated and having a reactivation of tuberculosis. Hepatitis B and C is the most challenging part of it. So if you are administered someone with hepatitis B viral DNA raised levels, you need to start lamivudine 2 weeks prior to rituximab and continue for 2 to 3 months. And last scenario is this, because if we look at our practice, when we started the rituximab treatment in 2016, we considered it as the ultimate treatment. आप एक cycle लगा दो, probably patient ठीक हो जाएगा. But with the passage of time, we learned that no, it is not a single cycle game. You need to give them the rituximab after some period. What we have found it after 6 to 10 months, you need to give them another pulse. Initially, we based our treatment on the clinical condition. Relapse हो गया तो हम rituximab देते थे. Thanks to Professor Azim Jahangir, who is sitting here, that he has introduced the desmoglein levels. We have coordinated with him, and this is the protocol which needs to be followed. If you have given someone rituximab, आप उसको दोबारा कैसे देंगे? Poor specificity for desmoglein 3. Pemphigus vulgaris is a desmoglein 3 oriented antibodies आप develop करते हैं, लेकिन specificity for desmoglein 3 is poor if you are going for the levels. Desmoglein 1 की ज़्यादा specificity होती है, and you need to do it at the initiation of treatment, after 3 months of the rituximab therapy, and every 3 to 6 months based on evolution, and in case of relapse also. Thank you very much for patient listening, sir. Sir, questions end पे क्या भी? Later on, I think. Thank you, Ji. No questions?
Thank you, Dr. Noor, for that very important talk. And I'm sure all these scenarios will certainly help us in our own setups while dealing with cases of pemphigus. Moving on to the next speaker. The next speaker of the session is Dr. Aisha Riaz. She is the Assistant Professor of Dermatology at the Mayo Hospital in Lahore. She holds special interest in dermoscopy and is actively involved in teaching its usage. She has inspired many, including myself, to take interest in this valuable modality. Today, she will be talking on skin cancer diagnosis using dermoscopy as a helping tool. Please welcome Dr. Aisha Riaz.
Thank you so much. Assalamu alaikum. Honorable Chairman, Co-Chairman, my respected seniors, colleagues, a very warm Assalamu alaikum. So today, skin cancer is a word that none of us want to hear about. It's a scary word. Whenever it comes to our mind, there is a Pandora box of questions that opens up right away, and not every question is answerable. So this is me, Dr. Aisha Riaz, over here sitting in the front row, and this is my Department of Dermatology at King Edward Medical University, Mayo Hospital, Lahore. And I am supposed to discuss the features on dermoscopy of the common skin cancers that we see in our practice. How do we catch them early and how can we prevent them? In this era of aesthetics and supra-specialities and facial sculpturing and perfection, there is something in the core dermatology that we were taught in the undergrad as well as in the post-grad education was rare. But it's nothing rare. It's no more rare. I would say, your presentation after. So we are talking about some cancer precursors like Bowen's disease and the real cancers. Two classes of cancers that we really encounter in our practice. One is the keratinocyte cancer. This is basically a new term that has been introduced for the BCC and the SCC. Initially we called it as non-melanoma skin cancers. लेकिन आप खुद सोचें, क्या कभी हमने कहा है कि non-males, हम females अपने आप को females कहते हैं, males को हम males कहते हैं. So why not giving them a separate identity? This is the talk of the word right now. कि जो SCC और BCC हैं इनको आप केराटिनोसाइट कैंसर बोलो, और जो मेलानोसिटिक ट्यूमर है उसको आप मेलानोमा बोलो. So we are going to talk about these things. And if you are fortunate enough in catching and fixing the problem today that is going to become cancer in future, that is the real gist of your professional satisfaction. There are alarming figures that have been coming throughout the world regarding the incidence, prevalence and increasing ratio of the skin cancers. About 2 to 3 millions worldwide. What is the situation in Pakistan right now? Unfortunately, we don't know the situation in Pakistan because everywhere in the world there has to be a cancer registry which is bound to register and report the cases they encounter. But over here in Pakistan, we don't have a national cancer registry, but we do have some two small bodies. One is Punjab Cancer Registry and the other one is the Karachi Cancer Registry. Only these two bodies are registering some cases, and going through exhaustive research, I could only find out 7 to 10 research papers that have been written in Pakistan in favor of the skin cancers, their quality, their characteristics, histology. One paper was very interesting, quantitative analysis of skin cancer research in Pakistan, published in 2021. Apart from this paper, there is no such research, and even in this paper it was said that the alarming scarcity of the skin cancer research in Pakistan is an area of concern, and we should think about it. This is a glimpse of some of the research papers that have been published in Pakistan. So what do I suggest? I suggest if you people have a little index of suspicion in skin lesions in terms of duration, change in color, the appearance of symptoms or whatever, you think that the patient might have skin cancer either today or years to come, what do? You have an index of suspicion, you take out your scope. It's only possible only when you have the scope and you know how to interpret the image. Once you have a clinical index of suspicion, you go to dermoscopy, and lastly, obviously, you confirm it on histology. This is how we go about skin lesions that are concerning either pre-malignant or malignant. So why am I stressing on the use of dermoscopy? Pretty much evident, इसके ऊपर मैं बात नहीं करूँगी, मैंने लिख दिया. और इसको करना कैसे है? अब अगला क्वेश्चन. मोस्टली लोग मुझे पूछते हैं कि डॉक्टर आयशा करनी कैसे है? So अगर हम डर्मोस्कोप को 100 मार्क्स दे रहे हैं, तो जो करने वाला पार्ट है उसको मैं 1 out of 100 करूँगी. It is just like capturing an image, just like you do with your cell phones and the videos. Aim of the game is interpretation. Where we are weak is interpretation. हमें नहीं पता कि डर्मोस्कोपिक फीचर्स क्या हैं कैंसर्स के, जिनकी बेस पे हमने लेबल करना है कि ये चीज़ कैंसर है, ये चीज़ कैंसर नहीं है. This is the part which is lacking. करने में कोई मसला नहीं है. I've already submitted a video, 3 minutes video, जो ये कॉन्टेस्ट में थी, ऑर्गेनाइजर्स ने पुटअप किया हुआ था. सो उस पर हमने ऑलरेडी ये बताया कि डर्मोस्कोपी कैसे करनी है. तो यूज करना बहुत आसान है, असल चीज है कि आप उसे इंटरप्रेट कैसे करते हैं. अब अगले वाली जो स्लाइड्स आ रही हैं, इसमें वी आर गोइंग टू throw some light on the diagnostic features of keratinocyte cancers as well as on the melanoma. So this man comes to me. This is basically an inspiration for me, such cases to present on these forums. This was father of my colleague. He came back from America to Pakistan and said, Aisha, इनको देखो, अब्बू के मुंह पे एक निशान था जो थोड़ा सा बढ़ गया है. Now he thinks कि ये कभी-कभी itching भी करता है. So जब हमने अंकल को बुलाया in Mayo Hospital, we had the dermoscopy done. This is what I saw. So it was a pigmented, tricky thing on dermoscopy, and when we went forward, it was a full-fledged pigmented basal cell carcinoma on histology. So थोड़ा सा concern, क्योंकि उनका बेटा डॉक्टर था, उसको पता चल गया कि this is something concerning, लेकिन हमें नहीं पता चलेगा otherwise. Similar cases, BCC. Okay. क्लिनिकली आपको ऐसे नजर आते हैं, डर्मोस्कोपिकली ब्लू डॉट्स एंड ब्लू क्लॉट्स डायग्नोस्टिक हैं, ये याद रखें. बीसीसी के लिए ब्लू डॉट्स एंड ब्लू क्लॉट्स अगर आपको नजर आ जाते हैं तो दिस इज वन ऑफ द डायग्नोस्टिक फीचर, जैसे कि यहाँ पे नजर आ रहे हैं. दे कुड बी आइसोलेटेड, दे कुड बी इन कंजंक्शन मेकिंग ग्रुप्स, और इनकी जो लोकेशन है डर्मिस में वही आइडेंटिफाई करती है कि इनका कलर क्या होगा. थोड़ा सा ऊपर पड़े होंगे तो ग्रे होगा, थोड़ा सा नीचे पड़े होंगे तो ऑब्वियसली वो ब्लू कलर के नजर आएंगे. One more BCC. Okay, clinically left hand side, dermoscopically right hand side, gray to blue dots and clots और इकट्ठे भी पड़े में, a little bit of ulceration in the center जहाँ पे थोड़ा सा scab serum crust बना हुआ है, and another BCC. Okay, this is also a BCC. अब इसमें ये देखें कि brown pigmentation है, ulceration, and this is what I was calling blue dots and clots in the center. This is one of the diagnostic feature. थोड़ा रिवाइज कर लेते हैं कि BCC में क्या होता है, क्या पैटर्न होता है, क्या क्लू होता है. Pattern is a dermoscopically diagnosable figure that is there in more than 20% of the lesion which you are seeing. And if you see something which is in the less than 20% area of that image, it would be called as a clue. It won't be a pattern anymore. So pattern क्या होंगे? Blue and grey dots and clots and radial lines. अगर ये 20% लीजन से ज़्यादा में होंगी तो वो BCC होगा, लेकिन कुछ क्लूज भी हो सकते हैं, यानी 20% लीजन एरिया से कम के ऊपर चीज़ें अगर हों तो उनको हम क्लूज बोलेंगे. ये सारे क्लूज हैं जी. Brown grey dots, radial lines, ulceration, sticky fiber sign, white lines, serpentine blood vessels. तो ये सारे क्लूज हैं. सारे क्लूज का एक ही लीजन में पॉजिटिव होना जरूरी नहीं है. 1 to 2 clues are enough. 1 to 2 patterns are also enough. So this was about BCC. Let's look at SCC. Simple lesion, छोटा सा scab है, irritate कर रहा है, और ये 60 years के मेल थे. स्कोप रखी, आपको बहुत ज्यादा व्हाइट केराटिन नजर आई और ये व्हाइट सर्कल्स हैं जी. ये बिल्कुल आपको अच्छे नजर आ रहे होंगे. ये व्हाइट सर्कल्स हैं जो ब्लैक एरो पॉइंट कर रहा है. ये हमें बता रहे हैं कि जो स्क्वेमस सेल्स that are originating from the epidermis and they have gone malignant, they are coming down into the dermis, making up nests. तो ये हमें डर्मोस्कोपी पे व्हाइट सर्कल्स की तरह नजर आते हैं. दिस इज ऑल्सो अ डायग्नोस्टिक फीचर ऑफ SCC. सम मोर व्हाइट सर्कल्स, ये टिपिकल फीचर है, टिपिकल पिक्चर है SCC ऑन डर्मोस्कोपी. अच्छा, अब मैं आपको दो चीजें दिखाएंगे. आप लोग खुद से सोचें कि इनमें से कौन सा SCC लगता है, कौन सा BCC लगता है. खुद ही से सोचें. अभी हम डर्मोस्कोपी करने वाले हैं और देखने वाले हैं कि वाकई कौन सा SCC और कौन सा BCC है. तो वो निकला BCC A एंड B turned out to be SCC. दोबारा पीछे जाते हैं, देखते हैं कि वो क्लिनिकली फर्क थे, नहीं थे. क्लिनिकली ये कोई इतने ज्यादा डिफरेंट नहीं थे, बट व्हेन यू टुक योर स्कोप आउट और आपने देखा तो आपको पता चला कि ये डिफरेंट हैं. ओनली फ्यू मोर स्लाइड्स टू गो. तो SCC के फीचर्स जो हैं डायग्नोस्टिक वो ये होंगे. व्हाइट सर्कल्स ऑब्वियसली जो हैं इसके डायग्नोस्टिक हैं, और हिस्टोलॉजिकली वो किस चीज को डिनोट करते हैं ये बता दिया. दिस इज बोवेन्स डिजीज. ये जो आपको अभी नजर आ रहा है बोवेन्स डिजीज विच इज इंट्राएपिथेलियल कार्सिनोमा, और इसको हम प्रिवेंट कर सकते हैं फ्रॉम बिकमिंग ओवर्ट स्किन कैंसर. इसके डायग्नोस्टिक फीचर्स जो हैं तेजी से बता देते हैं. इसमें ग्लोमेरुलर वेसल्स, डॉट्स इन लाइन, ब्राउन डॉट्स और रेड डॉट्स प्रेजेंट इन लाइंस. दिस इज वन ऑफ द डायग्नोस्टिक फीचर ऑफ बोवेन्स डिजीज. तो प्रेजेंटेशन मुकम्मल नहीं हो सकती जब तक हम मेलानोमा की बात ना करें. दिस वाज अ केस referred from Gangaram Hospital a week ago. I think couple of weeks ago the case was referred from Gangaram and then we saw. मैंने इसको डर्मोस्कोपी वाले WhatsApp ग्रुप में भी पोस्ट किया था. So this man comes with this pigmented lesion on the sole of the foot along with this ulcerated lesion. We did the dermoscopy and what you see is the parallel ridge pattern of pigmentation which is diagnostic of acral melanoma. अब ये जो palms and soles पे melanoma होगा, it would show us like ridges and furrows, और इसके characteristic features different होंगे from that of the melanoma present on the skin otherwise. तो इसमें आपको नजर आ रहा है कि pigment is concentrated more in the ridges, while the furrows which are white lines they are practically devoid of any pigment. So this is parallel ridge pattern of acral melanoma. जैसे मैंने पहले कहा skin cancer इतना rare नहीं है. इट्स ओनली अ मैटर कि हम देखते हैं, उसको रिकग्नाइज करते हैं या नहीं. अदरवाइज मेलानोमा अगर बाकी स्किन के ऊपर आ जाए तो उसमें नेगेटिव नेटवर्क नजर आ सकता है व्हाइट कलर का, वेसल्स नज़र आ सकती हैं, वेरिएशन इन कलर होगी, बहुत कुछ और होगा। टोटल तकरीबन 10 मेलानोमा स्पेसिफिक स्ट्रक्चर्स हैं जो आपको मेलानोमा की डर्मोस्कोपी में नज़र आ सकती हैं। इनको याद करना थोड़ा सा मुश्किल है, बट आई हैव मेड निमोनिक्स फॉर माई सेल्फ, आप भी बना सकते हैं। इनको याद करेंगे, 1 by 1 देखेंगे तो ही पता चलेगा कि लीजन इन क्वेश्चन इज मेलानोमा और नॉट। So this is the end of my presentation approximately। अच्छा, आप डायग्नोस्टिक एक्यूरेसी डर्मोस्कोपी से कितनी बढ़ सकती है? 60% से 90%। लेकिन जो बंदा अनट्रेन्ड है डर्मोस्कोपी में, जिसकी कोई ट्रेनिंग ही नहीं है, अनफॉर्चुनेटली उसकी डायग्नोस्टिक एक्यूरेसी नहीं बढ़ेगी एंड इट वुड स्टे एट 60% डिस्पाइट यूजिंग डर्मोस्कोपी। ये बड़ी अलार्मिंग बात है। कुछ लोग समझते हैं वो डर्मोस्कोपी सही कर रहे हैं, बट दे आर एक्चुअली कैप्चरिंग द इमेजेस वेल। उसकी इंटरप्रिटेशन में दे आर वीक। इंटरप्रिटेशन इज द बेसिक थिंग। तो 60% से 90% तभी जाएगी अगर आप ट्रेन्ड डर्मोस्कोपिस्ट हैं। इसके बाद ये है जी नीड ऑफ द टाइम के ऊपर आप जरूर बात करूंगी। हमारे जो भी स्टेक होल्डर्स हैं, सीनियर्स हैं, आई वुड रिक्वेस्ट कि कुछ स्टेप्स लिए जाएं टुवर्ड्स मेकिंग अ नेशनल कैंसर रजिस्ट्री। केसेस को रिपोर्ट किया जाए, उनको रजिस्टर किया जाए, ताकि कुछ स्टैट्स हमारी भी जमा होना शुरू हो पाकिस्तान में कि कितना है। इट माइट बी इन कोलैबोरेशन विद सर्जन्स एंड प्लास्टिक सर्जन्स एंड व्हाटएवर, लेकिन ये किया जाना चाहिए। थैंक यू वेरी मच फॉर द पेशेंट लिसनिंग एंड इफ यू हैव एनी क्वेश्चंस आई एम हियर टू आंसर। Mnemonic is kind of very funny. It is based on a game of my baby. तो वो मैं नहीं अनफॉर्चुनेटली डिस्क्लोज कर सकती, आप वो मुझे कांटेक्ट कर लें पर्सनली, मैं आपको बता दूँगी। ये निमोनिक्स हम एक्चुअली वही चीज़ें बनाते हैं ना जो हमें याद रह जाए, तो मैंने एक फ़नी सा निमोनिक बनाया हुआ है, आई विल टेल यू। और कोई क्वेश्चन? लेकिन 10 मेलानोमा स्पेसिफिक फीचर्स हैं, 10 के 10 याद होने चाहिए जी।
From where we can get training on dermoscopy?
Very good question. In the last year's presentation in Lahore, I talked about areas from where we can get training. आज की presentation में ये included नहीं था। बहुत सारे forums हैं, online भी हैं, आप जाके भी training कर सकते हैं। पाकिस्तान में भी we are planning a few things. इंशाल्लाह in near future we are working on them कि हम training start करें dermoscopy की। अगर आपका माइंड है ट्रेन होने का, आप व्हाट्सएप ग्रुप में आ जाइए, वहाँ पे कुछ लिटरेचर हम शेयर करते रहते हैं जो आपको हेल्प आउट करेगा। देयर आर फ्यू बुक्स ऑन बेसिक्स ऑफ डर्मेटोस्कोपी, तो वो भी आपको हेल्प आउट करेंगे। यू कैन गेट इन टच। अब्रॉड से अगर आप बात करें, ऑस्ट्रेलिया इज द मेन सेंटर जहाँ से सबने सीखा, जो सारे मेंटर्स हैं वो वहीं से पढ़े हुए हैं और वहाँ पे काफ़ी सारे कोर्सेज इन लाइन हैं। What I did was a professional certificate, and then I did advanced certificate in dermoscopy, and I am working for the masters in dermoscopy. This would be the third step in dermoscopy qualification. Any other question?
Excuse me, if we want to buy a dermoscope, तो वो कहाँ से लें and what to look for to buy a good dermoscope?
Presentation में कोशिश करूँगी मैं पीछे चली जाऊँ। इसमें मैंने शुरू में बताया था कि डर्मोस्कोप के कुछ फीचर्स हैं जो होने बहुत ज़रूरी हैं। आप कोई भी डर्मेटोस्कोप ले लें, इसकी पोलराइज्ड होना बहुत ज़रूरी है। पोलराइज्ड एंड अनपोलराइज्ड मोड में टॉगल करना बहुत इंपॉर्टेंट है। जो मैंने 3 मिनट्स की वीडियो इनको भेजी थी ऑर्गेनाइजर्स ऑफ पैडकॉन को, उसमें हमने डिटेल से बताया कि कैसे पोलराइज्ड और अनपोलराइज्ड मोड में आप टॉगल कर सकते हैं, और वो इनफैक्ट बहुत इंपॉर्टेंट है। अगर आपके डर्मोस्कोप में वो नहीं है, ये देखें जी, नेसेसरी स्पेसिफिकेशंस शुड बी पोलराइज्ड मोड होना चाहिए, सेल फोन का अडेप्टर होना चाहिए, आप साथ अपना फोन लगा लें, उसी वक्त तस्वीर बना लें, नो वेस्ट ऑफ टाइम। कॉर्डलेस होनी चाहिए, मरीज आपका लेटा हुआ है, बैठा हुआ है, यू शुड बी फ्रीडम ऑफ मूवमेंट, एंड देन गुड बैटरी टाइम ऑब्वियसली। जो मेरे पास डर्मलाइट DL4 डर्मोस्कोप है, उसको मैं एक दफ़ा चार्ज करती हूँ और उसके बाद 3-4 हफ्ते के बाद मैं उसको चार्ज करती हूँ, एंड आई सी ऑलमोस्ट 2 to 3 केसेस एवरी डे। नाउ आई नो कि मैंने किस पेशेंट को डर्मोस्कोपी करनी है, किसकी नहीं करनी, लेकिन स्टार्ट में ऑब्वियसली आपके बहुत ज़्यादा पेशेंट्स होते हैं, यू ऑलमोस्ट पुट योर स्कोप ऑन एवरी अदर पेशेंट। So I hope this is the end of questions from the audience. Thank you very much.
Thank you, Dr. Aisha, for that very insightful talk. Before I announce the next speaker on stage, just a quick announcement that those wishing to attend the gala dinner tonight, transport will be available to them at the front and back gate. So the last speaker of our session today is Dr. Bilal Shams. He is an assistant professor at the Postgraduate Medical Institute in Quetta and an international fellow at the American Society of Laser Medicine and Surgery. Dr. Bilal holds special interest in lasers, and he kindly shares his knowledge on various dermatology forums. Today, his talk is on laser and energy-based devices in the dermatological practice. Please welcome Dr. Bilal Shams. Dr. Bilal Shams, if you could please come on the stage.
Honorable Chairman, respected panelists, dear seniors and dear colleagues. Today's topic is the need of time, laser and energy-based devices in dermatological practice. Lasers we see in our daily life from grocery store scanners to even this pointer, and similarly DVD players, CD players, etc., etc. So the uniqueness of this topic is that lasers, they are the supply lines of core dermatology as well as aesthetic dermatology. Suppose if someone is not interested even in aesthetic dermatology, he needs a laser as well. Yeah. किस तरफ? उस तरफ So, going back into the history of lasers, the first laser was invented by Theodore H. Mammon on 7th of July 1960. In 60s, the period of 60s is of prime importance in a sense that more than 10 lasers were invented in that time. And of course, we should remember the name of father of laser in medicine, that's Leon Goldman. So, which one is laser and what's normal light? Every normal light is not a laser. In order to give a specification to some light beam, the name of laser, it should have certain characteristics. Like it should have a single wavelength, a single color, the beams should be in phase, and then they should travel in one direction. So monochromatic, coherent and collimated. These three properties if a light has, it's called laser. How can we have a laser? Like definitely in order to, some basic things of physics are very important in order to have a minute idea about lasers. Like how can we have a laser is photons of energy needs to be generated if an atom goes from excited state into the ground state. So for that we need a medium, and then there are three types of media: solid, liquid and gaseous media. The topic is huge, so I need a quick review. Right. So when a laser falls on our skin, four of the things may happen. Either it gets reflected from the skin surface, especially the stratum corneum reflects it. 7% of the light, whatever light hits our skin, it gets reflected. It may get transmitted. After transmission, it may get scattered by the organelles, cellular organelles, the collagen, or it may get absorbed. So we are interested in absorption. When laser gets absorbed, there should be a certain chromophore, a certain specific target. And that target, what happens to that target? either photochemical or photothermal effects happen in that target, and it gets ablated. Already discussed chromophore. So there is a relationship between energy and frequency as well as wavelength. As we can see, going from ultraviolet range to the infrared range, as we go from higher frequency towards the lesser frequency, the energy decreases. As we go from higher wavelength, from lower wavelength towards higher wavelength, the energy decreases. This relationship is very important to know. Another important question most of the patients ask, they say, Dr. Saab, क्या लेज़र कैंसर करता है? ये बहुत अच्छा सवाल है. हर पेशेंट तकरीबन ये कहता है ये बहुत खतरनाक है, लेज़र कैंसर करता है. अब लेज़र कैसे कैंसर काज करता है, ये मैकेनिज्म भी अंडरस्टैंडेबल होना चाहिए. Like we are living in an era of multiple wavelengths around us. रेडियो वेव्स हैं, हमारे पास टावर्स लगे हुए हैं, ये सारे रेडिएशंस हैं. अब कौन से रेडिएशंस जो है ना वो कैंसर काज कर सकते हैं? सो एक रफ आइडिया ये है कि वो रेडिएशंस जिनकी जो वेवलेंथ पेनेट्रेट करे सेलुलर न्यूक्लियाई तक, एटॉमिक न्यूक्लियाई तक, वो कैंसर कर सकते हैं. इन अ सेंस they lead to a change in a stable atom. A change in an atom leads to a change in molecule. A change in molecule leads to a change in polypeptide chain and change in gene mutation. So this is the basis of. So the wavelengths that are having less than 100 nanometer wavelengths, those radiation, they can cause cancer. While the higher wavelengths we use in dermatological practice, they are safer ones. Selective photothermolysis, a very important, it might be a bit boring because these are the basics. Without basics we cannot go into the clinical ones. So selective photothermolysis is very important. Like you want to apply a laser to treat a condition. So you need a chromophore for that. And only that chromophore can absorb that particular wavelength. So that chromophore needs, we must know the thermal relaxation time of that chromophore. So the wavelength applied should have a pulse duration less than the thermal relaxation time. Coming to, apart from laser, again there is Jake of all trades but master of none, the IPL. Of course everybody is familiar with this. IPL is a bit different from ordinary light, like it's a harsh beam of radiation that is emitted from a flash lamp. It ranges from the range of ultraviolet to the far infrared light. Then we apply certain filters to get the wavelength of our choice. These are the lasers in common use in dermatology. The ultraviolet laser, the very famous one, excimer one. Then there are some lasers that are in visible range of light, the KTP, pulse dye, ruby, diode. And then there are infrared lasers that are, most of them are used in ablative and non-ablative treatment of the scars. So 4 to 5 important areas are lying in dermatology that has been thoroughly studied. The laser implication is studied in them. That is the vascular lesions, the pigmentary dermatosis, the epilation, as well as scars. So coming to the this port wine stain, 2% of the newborns get this one. Initially it may be pale red macule, but then with the passage of time it can become darker. So the lasers available for this are, there are different types of port wine stains. Even we may have some hypertrophic port wine stains that may have other components beyond these vascular components, like neural component, mesenchymal component. So we need to use multiple treatment modalities in Port Weinstein as well. So the most commonly used treatment modalities, the dye laser, the pulse dye laser, but when it comes to hypertrophic Port Weinstein and with nodules, we need to use other treatment modalities as well. So the Port Weinsteins, all the Port Weinsteins doesn't respond equally to all the treatment modalities. Like some Port Weinsteins on some areas of the body, they respond better, while the others respond less. Like the Port Weinsteins over the face and back respond better, and over the acral parts of the legs, they respond less better. Similarly, even in the face, the mid-face, and the distribution of the second trigeminal branch, they respond less as compared to the areas of the periorbital area and forehead and neck. They respond better. Smaller size lesions respond better as compared to larger size lesions. So then there are some Port Weinsteins that are resistant to pulse dye laser. Then we can use other treatment modalities like Alexandrite laser, long pulse YAG. Just a few slides. Hemangiomas. Another bothersome problem for the parents of the children who have hemangiomas. Pulse dye laser works excellent, but we need other treatment modalities as well. Can you play it, please? How to play it? So this is a hemangioma over the lower lip. We used long pulse Nd:YAG laser for this lesion, and a single treatment session was enough to treat this vascular lesion. You can see this treatment is coupled with epidermal cooling via a chilling device. Now you can look the lower lip of this patient. It's clear 100%. One treatment session. Telangiectasias, these are tiny dilated venules. Again, the vascular lesions, the lasers that work in vascular lesions, again, there are long pulse YAG, pulse dye, Alexandrite, and a very important laser that's neglected nowadays, 940 nanometer diode laser. It's more effective. Varicosities of great saphenous and small saphenous veins. Prior phlebology evaluation is must. Like before treating this, we must know that there are smaller lesions or larger ones. Like the ones up to 1 millimeter, they are treated best with pulse dye laser, while the ones who are larger, then Alexandrite laser or long pulse YAG can be tried. Other vascular lesions like venous lake, cherry angiomas, hereditary hemorrhagic telangiectasias, these all respond better to the vascular lasers. Like venous lake, it responds to multiple sessions of pulse dye laser, while a single session of long pulse YAG is enough. Now looking at this lesion over here, this venous lake, a single treatment session of long pulse YAG resulted in complete resolution of this problem, and you can see this patient over here. Benign tumors, xanthelasma, syringomas. Syringoma is a troublesome one. Like patient frequently presses the physician that please treat it. So any laser, ablative laser that treats syringoma leaves a scar. So the risk of scarring is there. So I better advise not to treat syringoma with any ablative laser. Better leave it as such. A digital mucus cyst can be easily opened, and then the debris can be cleared, and then the rest of the walls can be coagulated using a cautery or a laser even. Epidermal and organized nevi. There are epidermal nevi, there are soft papillomatous, there are some verrucous ones. You can have some shave-like effect through lasers, but that is temporary and the recurrence is common. If it is resectable, you better resect it surgically. lasers are not a good option in case of epidermal nevi. Warts. Warts can be treated anyway from, I think cautery is far better than a laser. While the problem is with mollusca contagiosa, especially the school-going children, that's a big issue. So pulse dye laser, if you have in your setup, it's painless. Okay. So it's painless, and it like children would be quite comfortable with this treatment. Lichen sclerosus atropicus, a rare variety, CO2 laser can ablate it and regress it. So sometimes recurrence is common at the borders and the healed areas. You can repeat the session, and it's a good treatment modality for lichen sclerosus atropicus, the carbon dioxide laser. Chondrodermatitis nodularis helicis, carbon dioxide laser in ablative mode is very effective in this problem. Psoriasis, some solitary plaques can be treated with pulse dye laser, while some stubborn plaques can be treated with excimer in the best possible way. Acne, different lasers have been used in acne. Pulse dye laser, the 1450 nanometer diode laser, that's approved by FDA, and certain light emitting diodes as well. Rosacea. Rosacea is another problem. There are multiple studies where pulse dye laser was used for rosacea that improved the pruritus, burning, flushing, dryness, as well as erythema and telangiectasias with varying percentage. This is one of my patients who had phymatous rosacea. You can see the disfigured nose. After 3 treatment sessions of ablative carbon dioxide laser, you can see the results. Okay. Vitiligo, everybody is familiar with the role of excimer laser and narrowband ultraviolet B, POA, and things. So this was a unique case. Like the vitiligo was widespread in this patient. So we removed the islands of the normal skin with a picosecond laser by the name of PicoWay, and you can see the difference. The face is fully cleared. Alopecia areata, excimer laser is the treatment of choice among lasers. Then there are hypertrophic scars. I won't recommend lasers for this, but nowadays lasers are used for drug delivery in hypertrophic scars as well as keloids. Stria distensi. There are so many indications of lasers in dermatology, so it's hard to cover all of them in a single lecture. And so, okay, I am summing it up. Can you play it, please? Can you play it? This patient had freckles over her nose, very stubborn freckles, and single treatment session of 532 nanometer picosecond laser worked for this. The dermal lesions of nevus apota was treated by 7 treatment session of picosecond Nd:YAG laser. So I better sum it up. And then there are tattoos. The stubborn one is the red one that we treat with 532 nanometer, while the rest of the tattoos everybody is familiar with to use Nd:YAG laser. Photoepilation, it's a big topic, and even a single day is not enough for this to cover it. There are certain lasers used for that. Ruby is not used nowadays because of its lesser penetration, while alexandrite and diode laser are better suited for fair colored skin and thin hairs, while YAG laser, that is for thicker hairs. So there is another problem arise that in photoepilation, that is paradoxical hypertrichosis. Paradoxical hypertrichosis, most oftenly we come across this problem when we use suboptimal fluences. Suboptimal fluences should not be used. So the treatment is again continuous treatment, continuous laser therapy, and ultimately the paradoxical hypertrichosis will be treated this way. Resurfacing lasers, some are ablative, some are non-ablative, and my respected seniors, they have told me to sum it up. So, skin tightening devices, radio frequency, nowadays Silfamex and so many devices are in market, HIFU. So, in a nutshell, the topic is so huge to cover it in a single 10 minutes, even 30 minutes talk, and that's it. Any question related to lasers? Yes, sir. Mic, sir, ko mic.
Bilal, excellent presentation.
Thank you, sir.
I was just asking for freckle and lentiginous, which one you will prefer, Q-switch or pico laser?
Picosecond laser is the best.
Which is more safer against melanocyte
Sir,
damage?
picosecond laser has less thermal effect in the surrounding tissue, so post-inflammatory hyperpigmentation is seen lesser in picosecond lasers as compared to Q-switch or nanosecond lasers.
Melanocyte को तो नहीं damage करेगा?
Yes, sir.
Melanocyte को तो नहीं damage करेगा?
किस चीज को सर?
Melanocyte.
Melanocyte को सर मेलानोसाइट इतने स्टबन सेल्स हैं कि आपको मल्टीपल सेशन इसके भी इवन करने पड़ते हैं.
Then how would you recommend the pico laser for treatment of vitiligo, for depigmentation of vitiligo?
Yeah.
In case of depigmentation, you need to destroy the melanocytes.
Sir, usually the cases, I have almost covered more than 10 cases in this way, like the patients with residual pigmentation. I used picosecond laser with a wavelength of 532 nanometer at picosecond range, not a nanosecond range. Sir, I tried 2 treatment sessions for each patient. Some patient responded very well, while the rest they required multiple treatment sessions.
Since
there are certain factors that cause the recurrence, like sun exposure. Some people even they keep applying steroids. There is another issue like
for recurrence.
The vitiligo never it attacks all of the melanocytes. Some areas are very stubborn, especially around the eyelids.
I'm only asking about the residual pigmentation treated by picosecond laser.
Yeah.
Since theoretically picosecond laser, the pulse duration is very short.
Yeah.
And theoretically the energy and the damage should remain confined to the melanosomes.
Yeah.
Not to the melanocytes.
Definitely.
And in case of vitiligo, you need to destroy melanocyte. Otherwise, there will be again repigmentation.
Yeah,
and
it happens.
It
does happen.
seems to be the magic of your magical hand that we get cure in residual pigmentation with single session of pico laser.
No, sir. Sometimes
we सिर्फ वो उसका gradual अपना ही process of depigmentation तो नहीं था that resulted in universal vitiligo.
Sir, I didn't get your question.
Vitiligo is going to have progression.
जी, जी.
The course is variable. Some patients spontaneously go into universal depigmentation. ये जो केस रिपोर्ट है क्या ये सिर्फ वही तो नहीं थे?
सर ये वाला पेशेंट ये मेरा रिसेंट पेशेंट है. जो मेरे प्रीवियस पेशेंट्स है वो उनमें से कुछ पेशेंट्स जो है ना उनमें रिकरेंस है. हम मेलानोसोम्स को डिस्ट्रॉय कर सकते हैं, मेलानोसाइट को नहीं कर सकते क्योंकि 532 नैनोमीटर की जो पेनिट्रेशन है इतनी है नहीं.
This is only meant to convey the idea to youngster that in case of residual pigmentation for in case of vitiligo, you need to destroy the melanocyte, and this still the recommended therapy is
monobenzone. Ultimately, you have to use it for follow-up.
Definitely, there are reported cases in the literature with PICO, with Q-switch laser, but probably that was the course of disease itself, and that was incidental finding only. One thing. Second, मैं पूछना चाह रहा था आपके parameters of hemangioma with long pulse therapy, ND-JAG.
Sir, the fluence I used was around about 150 joules, and the pulse width I used was 40 millisecond. 40 millisecond.
And single session.
Single session, yes.
Adult hemangioma.
Yes, long pulse YAG, 40 millisecond pulse width, and 150 joules of fluence.
Again, that is very high fluence, and unless you are experienced, like Dr. Bilal, never ever try this very high fluence, since it's may cause permanent scarring. Thank you, Bilal. Thank you for
sir,
excellent
there
presentation.
Are certain, welcome sir, there are certain problems like in hairy areas, it may cause scarring alopecia even. So trying these things without any experience would be troublesome. Because rather than satisfying your patient, you may go into trouble. Thank you so much.
Thank you, Dr. Bilal. Now, I would like to ask our Honorable Chair and an expert panelist if they could please share their thoughts and comments on the session.
Bismillah ar-Rahman ar-Rahim. I think all the presenters, their presentations and the way they had produced the research, original research work was very interesting, and ultimately the papers presented were of highest quality. My only observation is, generally I was discussing with General Zafar, that when we come to these forums, like national, international forums, the presenters generally, like as if you are presenting a paper in which statistics are there, fine. You are discussing it from the book and you are discussing the statistics, or like as Mahmood Noor, his presentation regarding for the PGs and 7-8 case scenarios. That is obviously something which is very beneficial. But then if we are just coming here and presenting papers, and those papers do not carry original research work, and it's only the bookish material that we are presenting here, then I think it can, now we all have the facility of the smartphones, the internet, the website, everything is there. So the scientific sessions, the scientific meeting basically is meant to show people coming here and presenting their original research work. That is very important. It's not the bookish material that you come and you just present it and go back. And ultimately, when you are here, so it is, these presentations are just not meant only for postgraduates or undergraduates. There are certain papers that are to be discussed with postgraduates or undergraduates, but then the majority of the papers, they are generally the original research work that has to be presented. Number two, one thing is which is more important is for our youngsters like Bilal and others, that beta, when you are given a specific period of time to come on the stage, you should know that your presentation should be limited to that period only. You should practice this at your place, because in international meetings, if you have been there, these youngsters I'm talking, they at times mute the mic after 10 minutes or 15 minutes of allocated time, and you cannot listen because that is the end of it. So if a person is consuming more time than beyond the limit of the time, it means that this presentation was not well prepared, and the presenter does not know that in that specific period of time, he has to produce or he has to present those specific research that he has carried out, rather than discussing the whole book, which can be read by anyone at any time. But still, I would like to appreciate all the presenters and speakers, and as I was discussing with Zafar, that it was a good session, and we really have learnt a lot, because even when we are sitting here, senior people, we learn with every presentation, and it is always an experience for us, and I wish them best of luck in the future as well, and not only in national meetings, but in international meetings as well. Thank you.
First of all, I would like to thank the organizers, the scientific committee, for arranging such a wonderful platform for all of us to be here and learn from the wonderful speakers we had this morning. There's just 2 points during the session we were just listening to. First is my comment regarding the freckle treatment, which Dr. Bilal mentioned with Q-switch and DIAG laser, 532 nanometers. And I'm sure all of us understand that freckles and lantogens can look alike. So before you decide to treat a freckle with 532 nanometers Q-switch and DIAG laser, make sure that you're not treating a lantogen, because lantogen can come back, the patient can come back with more pigmentation, a PIH kind of effect. So one has to be very careful in your clinical judgment. We know the differences, the clinical look at the edges and look deeply and keenly whether it's a freckle or it's a lantogen. My second, a small comment regarding wonderful statistics which was shared by General Secretary Dr. Shahid regarding the cases of pediatric dermatology, large number of patients. My only thing while looking at those patients was what is different when we talk about pediatric dermatologists and a general dermatologist looking at those cases. So if we add things like early detection of conditions like epidermolysis bullosa with electron microscopy, we are utilizing genetics studies, we are doing fetal skin biopsies, we are getting the chorionic villus sampling done, we are adding some value to the diagnostic and therapeutic outcomes of these patients. Otherwise, there is no difference between a dermatologist treating a pediatric case or a pediatric dermatologist treating or diagnosing a pediatric case. Thank you.
Thank you very much, all the speakers and the commentators. Right. Panel of experts. Right. It was a wonderful experience attending this 41st conference, and I must say that whatever Professor Atif Kazmi has said, it's an advice for the scientific committee of the 42nd PADCON that is coming up. I think we must follow these rules, because they are all followed by all the international organizations. We must present original articles, and we must care for the time allotted for individual speaker, so that we do everything in time. Now, for today's this session, first of all, Professor Shahid Sheikh has given a very comprehensive detail on the his observational study on the prevalence of different disorders in the pediatric population. I must appreciate the endeavors of Dr. Yasmina Khan in promoting pediatric dermatology in Pakistan, and I must let everybody know that this specialty has been now recognized by the College of Physicians and Surgeons as second FCPS Part 2, both for the qualified dermatologist as well as for the pediatricians. The second speaker, Professor Saibzada Noor, it was an excellent interactive talk, and we learned a lot many things, different scenarios in which we have patients with pemphigus vulgaris. And to summarize, I think he has given us a very good detail of effective, available, affordable, and safe modes of treatment in patients with pemphigus vulgaris, especially in different scenarios, you know. Dr. Aisha Gyas, I think she also gave a very comprehensive account of dermatoscopy, and I think her lecture was like, you know, making dermato-oncology made simple by using dermatoscopes. And I agree with her that we must have a registry for recording the prevalence of these skin cancers in our community, and of course there is a rising prevalence. Dr. Bilal Sham's topic on energy-based devices was certainly a very detailed account, and he tried to cover most of the things which obviously could not be covered in 10 minutes, but as Professor Atif Kazmi has said, that it's just a little bit of a rehearsal before coming, which can make you, know how much time do you need to cover the essential components of your presentation. So overall, it was a very good and very nice session, and we all learnt a lot, and thank you very much to all.
Thank you for the very valuable comments. Now it's time for the shield distribution, and I would like to ask our Honorable Chair, Major General Zafar, if you could please come on stage and present the shields to our speakers. Our first speaker, Dr. Shahid Sheikh, if you could please come on stage. Dr. Shahid Sheikh. Professor Sahabzada Noor. Dr. Aisha Riaz. Dr. Bilal Shams. Next to our esteemed panelist, Professor Atif Kazmi. Dr. Tariq Malik. Group Captain Dr. Muniza Rizwan. to the moderator, that will be me. Finally, I would please request Professor Ijaz Ahmed if he could please come on stage and present our honorable chair for the shield. Thank you, everyone. Thank you especially to the chair, the panelists, and the speakers who have traveled from their respective cities and especially have come here for this session. We really appreciate the gesture. Thank you, everyone. Just a few quick announcements. Lunch will be at the Xavier Hall at 1:45 p.m. The PGs, the postgraduate students who are enrolled for the quiz that is to be held right now, please stay in the hall and you will be served your lunch in a while too. Thank you, everyone.
May I have your attention, please? All the residents who have registered for the Kahoot quiz are requested to please remain here. We are about to start the Kahoot quiz. The residents are to stay here. Rest of the doctors can enjoy their lunch in Xavier Hall. The residents can come forward and sit at the front so that they can have a better view of the screens. All the residents, PG trainees who have registered for the quiz are requested to stay here in this hall. We are about to start the quiz now. We will start the quiz shortly.
lead me to my destiny. I have waited patiently. I have vision, oh I believe. I know I can count on me. So stand up for the champions, for the champions. Stand up, stand up, stand up.
Only those residents who have their registration for Kahoot are allowed to sit in the hall. Rest of you can leave the hall, please. No consultant is allowed to stay in the hall. If you have your mobile data which is working, then it's okay. Otherwise, you can join PC Banquet Wi-Fi. Join PC Banquet, click it, and then go to, don't join it as guest, just join it as public. Select the public one, and then you can log in with your mobile number. Is it clear? Ji. Everyone has joined the Wi-Fi? Okay. I'm calling out the names of those who have got their registration. Please say present, like your class. Oh, yes. Raise your hand. Dr. Ayman Hashmi, Dr. Wada Sheikh, Dr. Wada Sheikh, Dr. Mehwish Rafi, Dr. Mehwish Sultan, Dr. Ghazal Afzal, Dr. Rimsha Beg, Dr. Umme Ayman Khan, Dr. Asma Durani, Dr. Saif, Sayyida Salim, Dr. Maria Gul, Dr. Shafia Maiman, Dr. Azizur Rahman, Dr. Hafsa Junaid, Dr. Muhammad Umair, Dr. Fatma Hassan, Dr. Ravi Kumar, Dr. Muhammad Fahad, Dr. Muhammad Anjum, Dr. Tazeen, Dr. Fatma Zahoor, Dr. Kamal, Dr. Shabir Ahmed, Dr. Asma Ansari, Dr. Maruf Javed, Dr. Aliza Hamdani, Dr. Shafiq Ahmed, Dr. Muhammad Hussain, Dr. Khalid Iqbal, Dr. Bilawal Mubarak, Dr. Anam Khan, Dr. Adan Sardar, Dr. Afsana Tariq, Dr. Shazia, Dr. Abdul Wahid, Dr. Hifsa Mumtaz, Dr. Asif Mumtaz. No one is here. Okay, you are here. Dr. Sana Sheikh, Dr. Iram Kamran, Dr. Sarish Salim, Dr. Aksa Asgar, Dr. Suhail Shaheen, Dr. Faisal Ahmad, Dr. Maria Salim, Dr. Rahmat Ali, Dr. Sara Khan, Dr. Shayana Hashmi, Dr. Muhammad Anjum, Dr. Shafia Maiman, Dr. Rehana Batul, Dr. Najeed Khan, Dr. Aisha Salim, Dr. Sana Adil, Dr. Noman Azam, Dr. Zarak Shiraz, Dr. Iram Iqbal, Dr. Unaiza Hassan, Dr. Muhammad Umair, Dr. Hasib Ahmad, Dr. Hira Aslam, Dr. Muhammad Gil, Dr. Aman Amjad, Dr. Shahbano Jawad, Dr. Saira Moz, Dr. Aniza Tasawwur, Dr. Zainab Qadir, Dr. Aisha Chattha, Dr. Humaira Wazir, Dr. Rabia Ijaz, Dr. Shilpa Ramshi Lal, okay, Dr. Kamal Khan, Dr. Shamsa Kamal, Dr. Warda Sheikh, Dr. Ehsan Khan, Dr. Nabila Aurangzeb, Dr. Sania Iram, Dr. Shazia Wakar, Dr. Nayab Dugal, Dr. Ehsan Khan, Dr. Nabila Aurangzeb, Dr. Sania Iram, Dr. Shazia Wakar, Dr. Nayab Dugal, Dr. Arisha Arshad, Dr. Tuba Talha, Dr. Rizwana Hanif, Dr. Sania Kamar, Dr. Alina Abid, Dr. Mubashir Khan, Dr. Neha Rana, Dr. Reema Madhu, Dr. Humaira Kamran, Dr. Maryam Sohu, Dr. Safura Naveed. Huma Kamran. Yes. All of you have Wi-Fi in your mobiles now? Yes.
So everyone please be seated so that we can start. Assalamu alaikum and a very good afternoon to all my respected teachers, seniors and my dear friends. I am Dr. Tazeen Ambar, Chief Resident Dermatology from the Aga Khan University Hospital, and I would like to welcome you all to the 41st PADCON 2022 organized by Pakistan Association of Dermatologists. Moving forwards, now it's time for the highly anticipated talk on careers and evolution in dermatology by none other than Professor Abrar Aleem Qureshi. Professor Abrar is a proud alumnus of Aga Khan University and a diplomat American Board of Dermatology from the Harvard Medical School. He has also done Masters in Public Health from Harvard School of Public Health. He is a Warren Alpert Professor of Dermatology and Chair of Department of Dermatology at the Brown University, USA. He is also the Director of Hospital-Based Ambulatory Specialties at the Leisfeld Teaching Hospital and Chief of Dermatology at Veterans Administrative Hospital, Rhode Island. He has received numerous awards, which include Young Leadership Award from American Dermatological Association, the Outstanding Service Award, and Diversity Mentorship Award from the American Academy of Dermatology. Dr. Qureshi is a member of numerous professional organizations, including New England Dermatological Society, the Society for Investigative Dermatology, the Society for Epidemiology Research, the American Dermatoepidemiology Network, the American Association of Cancer Research, and the North American Rheumatic Dermatologists. His research interests include teledermatology, skin cancers, vector-borne illnesses, and psoriasis. Respected sir, please welcome on stage.
Assalamu alaikum, everyone. Assalamu alaikum. Great to see everybody after lunch. Hopefully it won't be a long qailula, inshallah. So can I get the first line? All right, so maybe 15-20 minutes we'll have a conversation. This is a very important hot topic, at least hamare yahan in the US, because of these reasons. So in general, when we recruit our dermatology residents, it's very interesting. They come from, they're typically very, very smart, very intelligent. They have, typically high board scores. They do very, very well in, in their exams. So this is such a hot topic right now, at least in the US. The question is, we recruit people who are extremely smart, really, really good. They're sort of top in their class in medical school. They've done very well throughout their lives. So they're really hungry to get into dermatology, and so we get them in. We're lucky to have them. And then what's really interesting is these people like to multitask. They want to do many things at the same time. And isn't that true if you think about yourselves, sitting in the room right here? How many specialties in medicine are there where you can see a patient with infectious disease, inflammatory disease, a disease you don't know, a tumor, a rash, and you can do doing a procedure in one room, you're writing for a biologic in the other room, a topical agent in the other room. So we're used to multitasking. It's very interesting. And so the two characteristics are the people are smart and you're all multitaskers. So how does one keep these types of people with these characteristics engaged in the long term? That's the question we're going to try and answer in the next 15-20 minutes. Right? How do we keep all of you engaged? And in the US right now, the biggest discussion in any hospital system is a term called burnout. Are you guys talking about burnout here at all, or not? Has that come up at all? Yeah? So burnout's a big discussion, and I'm not going to mention the word burnout, but I'm going to try and suggest strategies to avoid long-term burnout for people who have these two characteristics, people like you. So next slide. So the biggest hurdle we see in our experience is people are not planning for change. So as you go through, let's say you're doing clinical medicine, or you're doing research, or you're doing clinical trials, you like procedures, you're doing more aesthetic dermatology, whatever you're doing, we get stuck in that rut, and we're not thinking of planning for change. Next slide. So there are three observations I want to make to you that we have noticed about people who actually end up getting more burnt out. The first one is, we call them the people who are eternal fellowship recipients. They go from one fellowship to another fellowship, or they train in something else. They're always training, and the question is, when will they stop training and actually get into the real world? That's one. The second is, because these people are, remember, they're smart, and all of you like to multitask, you go for big goals. You want to achieve something big. But people forget, you know, getting something big requires small, focused success that then gets to bigger success. The third characteristic is, a lot of people, because they've seen so much success, remember I told you, these people have come into dermatology from they're top in their class in school, they're top, you know, and they're in college, they're very well in medical school, they do very well in the FCPS exams, so they're not ready to fail. And obviously in the real world, right, when they're in the real world, things don't always go as planned. So the key is, you got to be willing to do big things, you got to be willing to fail and then succeed. You got to get ready for that. So, what is, next slide, so this is the next slide really summarizes, how do you actually have a career that can evolve and adapt with you? For example, some of you might be starting a family, right? You have to plan a career around that. Some of you might be done with raising kids and want to think about, you know, how you can do more different things with your time. So the question is, how do you plan for that change, and how do you enact that change, right? So there are 5 important key ingredients to plan or think about that change as you think about your life. Whether you're someone who is training, just finishing training, mid-career, maybe a senior faculty member, this applies to every single person. So, question number 1, as you sit here for a second, I want you to think about this in your own heads. Try and answer the question to yourself, and be brutally honest with yourself. What is your brand? Who are you as a dermatologist? If someone says, you know, I'm thinking about, you know, Professor Lamis, for example, what brand comes to mind first? Professor Sajjad Noor, what brand comes to mind, right? The speakers you heard today, what do you think of them? Are they clinical excellence people? Are they aesthetic dermatologists? Are they, you know, proceduralists? Are they teachers? You know, are they more administrative? What is your brand? That's one question. The second question is, whatever you're planning for, is it feasible, right? You might have a big plan, but is it doable? And we'll talk about that in a moment. The third one is, whatever you're doing, is it impactful? Is it going to make a change? Is it going to, you know, does it meet what's called the wow test? You know, can you explain it to a family member who's not a physician, definitely not a dermatologist, and they say, shabash, ye badi baat kar rahe hain, this is big, right? Can you meet the wow test? Collaboration, that's a very tough one. Because to do big things, you need a team. You cannot do everything yourself. And people aren't used to working in teams. So you got to learn to collaborate and build a team. But if other people don't know how to work with you, you got to teach them to work with you too. You can set parameters. We'll talk about that in a second. And finally, you got to measure what your plans are. Measure what the career change you're doing. Is it effective or not? And you have to be ready and honest with yourself. Are you succeeding at that change, or is it failure? So let's talk about, well, let's talk about an example. I'm going to talk to you about an example that I'm going through right now on how I'm trying to plan for some change. So, but I'll talk to you. I'll give you an example of myself, maybe from about 7, 8 years ago. So, I was interested in medical dermatology. I'm doing research, writing grants, but I really wanted to learn how the health system works in the U.S. And that might be true for you. How does your hospital system work? If you work maybe in a national-based hospital system and you have a practice, you want to learn about how that system works. How do you get promoted? How does money flow in that system? But you also want to think about how a practice works. How does money flow in the practice? How do you advertise your practice? So you got to learn. So I was thinking about, well, I'm seeing patients, I'm running a lab, but I really want to learn about the workings of a practice. How is a hospital department run? What is an academic department all about? So I couldn't suddenly get to running a department, right? I have to start somewhere. So I start planning around that. I talked to some mentors. So next slide. So let's talk about the first one, niche or brand management. If I look at my brand, I was known as a clinical dermatologist. But no one knew me as an administrator. No one's going to come to me and ask me a question, hey, how can I get this problem solved? Because I was not known in that brand. So how do I begin to fix that brand? Well, I want to take a deep dive into that area. So I go to my chair and I say, you know, Tom, you've been very supportive. I think I can help you. My research interest, my clinical interest, I can help you lead a quality committee. So I get into quality, right? I get some advice from some friends. I become chair of the quality committee. So I'm managing all quality in the department. I take a deep dive in quality of healthcare. Patients come in, what's going on with their medicine, et cetera. Second, I develop an expertise in the area. I use my clinical experience, and then I start publishing in the area. So that gets me to the next level. They say, well, you know, you did a great job there. Now, would you mind running a small clinic for us? How do you recruit staff? How do you pay staff? How do you bill for services? And that's how you get going. So next slide. The second question is what I want to do, is it feasible and pragmatic? Well, it's feasible because I'm trying to run a service, but to run that service requires a lot of effort, right? I have to have the right staff trained. I have to have the right physicians and other providers taking care of patients. So, and there's a timeline. How fast am I going to do this? So when you're changing or thinking about a career change, you got to think about the timeline. Is it going to take you a year? Will it take you 2 years to plan? On average, what do you think? How often does it take someone to change, make a change in their career from being a clinical person to becoming a researcher, becoming an administrator? What do you think? How long does it take on average? Take a guess. 10 years? Yeah, Dr. Lemay saying, 10 years. Probably in the spectrum about 5 to 8 years, right? It takes about 2 years to develop the brand, or get to develop the brand, and another 2 or 3 years to learn the ropes. So it's a long-term effort. And so the 4 to 5 year, 6 to 8 year window is, we call it rediscovering yourself every 6 to 8 years. The next slide. Okay, I'm going to show you some pictures in a second so you still stay awake with me. Just give me a moment. So we're talking about, can you be impactful? Can you solve a problem? There's a famous saying, if you're useful to people, right, they will look up to you and actually get things done for you. So can you help fill a void? Can you be a useful person in terms of being impactful in your new role? The next slide. And then team effort. What do you think? Is it easy to work in a team? Yes? No? Maybe? Do you like working in teams? Right? So remember, to do big things, you need a team. Small teams don't achieve much. You need a big team. So here's the issue. You got to build a relationship with other people around you. So when I was running the quality committee, I needed someone to help me. I couldn't collect all the data. So I talked to the practice manager person. I collected data from patient care. I talked to billing services. I brought everybody together to say, listen, we're trying to do this together. I need your help getting the data. And that's how I did it. But the key with the team is everyone should win on that team. If everyone's not winning, they're not going to contribute to the team effort, right? They don't care. We call it, in English, we call it the WIFM, what's in it for me. If everybody in the team knows what's in it for them, they'll come together. The last slide, in this section, next slide. The last slide on this is measuring change. This is probably the hardest point in my talk today. You have to be honest, ask yourself the question, right? Brutally honest. Are you succeeding what you're getting to? Do you want to find another path? Do you need to talk to another mentor? Do you need some more advice? But be ready to measure failure or success, and then use data to inform your decision, not a whim. Don't do it based on what you think. Take data and digest it. So next slide. So I'll give you an example. This is the team I worked with about 12 years ago at my old hospital. That's a rheumatologist, Eleanor Modi, who's a colleague. We trained Joe. Joe did medicine, then he did rheumatology. Now he's doing an incredible job as a clinical trialist, doing rheumatology and dermatology together. This young woman actually is back in New York City. She's an incredible medical dermatologist. So as you train people and you see them evolve, you then become their mentors as they evolve. Next slide. So I'm going to change gears for a second. I'm going to give you an example of how I'm trying to develop a new brand for myself. So I want to use myself as an example so you can criticize, tell me if I'm doing a good job or not. How's that? Is that good? So the new brand I'm trying to develop is I'm trying to teach using a new technology. I'm not a social media person. But I figured I'm going to try and teach people clinical dermatology or clinical medicine using natural designs of nature. Okay? So I created a new Instagram page, and it's called Derm Tracker. You're welcome to follow me. But I'm trying to teach now a way to look at things a different way. So when we're taking care of patients, we are actually thinking more as we interact with our patients. So here, are you ready? Okay, everyone pay attention. When you look at this picture, I took this picture, okay? It was in Boston in January. It was snowing. But I noticed, as a dermatologist, my eyes picked up certain very important traits. I noticed that when the snow was falling, it fell on all flat surfaces. Okay? The vertical surfaces of the rocks, of the stones, didn't catch much snow. If there was any horizontal surface anywhere that the snow could fall, it got caught. See that? Look at the limbs of the branches. The bottom of the branch doesn't have snow. The top surface has snow. Yes? Everyone agrees with that so far? Right? But you're a dermatologist, you can see this. People not in dermatology may not notice these things. What else is interesting? Anything else you notice? You see the snow piled up here? That's just random snowfall. It fell on the ground, it's relatively flat, but why is it bumpy? Any thoughts? That's a hint right there. See that hint? There's small shrubs, small bushes, small plants. So when the snow fell, it didn't fall. If it fell on this stage here, it would fall flat. But because there are plants there, it's bumpy. Got it? So your eyes are now telling me something about the information on this. And when you see a patient, you're using the same tracking principle. That's why I'm trying to develop a new brand for Derm Tracker. Because I want to teach people a new way to look at things. Okay? Next slide. Okay. So bear with me. As I'm walking to the woods, I look around. Okay? What do you know? Does anyone want to say what they notice here? Say again? You have to be loud because I cannot hear you. You notice there's a burrow there. There's a hole in the ground. That's where a small mouse or vole lives. Okay? Now what do you think is going on? Why is there no snow here? What do you think? Because the creature is coming back and forth. आप कहाँ से हैं? किस school से? किस hospital से? Civil hospital. Okay, perfect. Excellent job, civil hospital. So the animal comes out, looks around, maybe eats, goes back in. तो जहाँ वो animal आ रहा है, वो snow पिघल रही है. Right? But isn't it amazing? If you're, as dermatologists, your eyes are seeing this, believe it or not. The width of the burrow is the same width as this. Because वो creature की जो body है वो उतनी बड़ी है ना, तो सारी बर्फ पिघल रही है, right? It's a warm-blooded creature. Everyone follow me so far? Okay, next slide. Then I look around some more. मैं देखना शुरू किया. So my eyes start picking up patterns. I see two burrows. और क्या नजर आ रहा है आपको? उन burrows के इर्द गिर्द बर्फ कम है, बाकी बर्फ पड़ी हुई है. Is that good? Yes? What else do you notice? Anything else? क्या कह रहे हैं? There's no plants. बिल्कुल plants नहीं है. क्यों नहीं है? क्योंकि when the animal dug this up, this is all dirt that the animal dug up. See the granules of dirt? It burrowed then and brought the stuff up. यहाँ granules नहीं है. ये देखें granules नजर आ रहे हैं आपको सारे granules? यहाँ नहीं है. तो animal ने उनको granules को push करके इस तरह push किया है. Yes? So when you're mapping skin disease, there's a story to tell. Even acne has a story. Right? There's an early lesion, there's a late lesion, there's scarring. So there's a story to tell. So now you're developing a visual vocabulary as I'm talking you through this. Okay. और कुछ चीज notice की आपने? I'll tell you what you should see, what I noticed. अगर आप बर्फ को देखें, बर्फ जमीन पे बहुत कम है. पत्तों पे है, जो weeds लगे हुए उन पत्तों पे है. क्यों? क्योंकि जमीन गर्म है, बर्फ पिघल गई है, पत्ते ठंडे हैं, बर्फ रह गई है. You see that? You guys notice that? Isn't that cool? Okay, watch. Next slide. So then you expand your scope. पहले आपको मैंने छोटा burrow दिखाया था, फिर मैंने दो दिखाया, फिर I start looking around more. So when you're seeing a patient, you're looking at certain things, then you expand your view, you can zoom in, you zoom out. Am I right or wrong? Yes? कोई सोच नहीं रहा यार, लोग सो रहे हैं. Are you guys awake? Okay. So you see things, right? So if you look around now, you see more burrows and you see the same pattern. So what you're doing is, आपने पहले patient देखा, उसका पहला lesion देखा ना, in the first 2 seconds you have a differential in your mind. Then you're looking to either refute the diagnosis or confirm it by looking at other clues. And as you look around, you यार हाँ आप कहते हैं यार ये भी है, यहाँ भी snow नहीं है, यहाँ भी snow नहीं है, इसका मतलब है कि वो creature बाहर आ रहा है. So now you're confirming your diagnosis. Got it? Next slide. What's going on here? So अब आपने वो तो आपने confirm कर लिया, ठीक है? You know कि creature बाहर आ रहा है, अंदर जा रहा है. You can use that knowledge in other cases also. There's no creature, there's no burrow here. But now that you know कि बर्फ पिघल रही है, नहीं पिघल रही, कहाँ रह रही है, क्या हो रहा है, you can now draw conclusions about something totally different. समझ आ रहा है आपको? So what's going on here? Anybody on that side of the room? ये साइड बड़ी quiet लग रही है मुझे. Anyone wants to tell me anything? क्या हो रहा है यहाँ? Footprints आप कहाँ से? Islam, कौन से? Are you a resident or faculty? Which hospital? Islam, okay. तो आप बताएं, तो footprints नजर आ रहे हैं आपको? किस तरफ जा रहे हैं? उधर जा रहे हैं, इधर आ रहे हैं? ऊपर जा रहे हैं, very good. और कौन जा रहा है? What can you tell me more about the person? है जी? बंदा है, बंदी है, उम्र क्या है, उनकी एज क्या है, वजन क्या है? Can you tell me? Yeah, actually, I'll tell you. जो शिकारी लोग होते हैं ना, उनके जो trackers जाते हैं, they can tell you more about the animal by looking at the footprints than you and I can do by looking at the animal. अच्छा ये बताएं, ये बंदा है, बंदी ये were they walking calmly, taking a stroll, or were they running away from something, afraid of getting hurt? भाग रहे? नहीं यार, चहलकदमी कर रहे हैं बड़े casually. When you run, I don't have time to show you. When you run, you don't put your whole foot down. You run on the balls of the feet. तो ये बंदा बंदी जो है ना बड़े casually walk कर रहे हैं. देखा आपने? So now you're applying principles in a different. Next slide. अच्छा ये isn't that a great picture? ये मैंने by mistake ले ली थी. It's an incredible picture. What's so cool about this picture? जो अब आपने visual vocabulary सीखी है, उस vocabulary के बाद apply those principles here. Let's come back to this side of the room. पीछे कहाँ हैं सब लोग? Anyone from the back? What do you see? आप किस hospital से? CMH, excellent. बताएं. Excellent. तो जो बर्फ है कहाँ पड़ी है? वो पत्तों पे पड़ी है, ठीक है? अच्छा एक बात बताएं, हर पत्ते पे पड़ी हुई है? किस पत्ते पे नहीं है? ब्रॉड पत्तों में पड़ी है, राइट? घास के जो पत्ते उन पे नहीं पड़ी, क्यों नहीं पड़ी उस पे? जगह नहीं है ना, वो छोटा सा पत्ता है, राइट? और उस पत्ते की शायद उस पत्ते का दर्जा हरारत कुछ और होगा, ओके? What else is so cool about this picture? Now, देखें, most people pick up the average stuff. But if you want to be special, you want the special brand, you got to take it to the next level. What's the next level observation on this picture? Now this needs, very good, pattern of the snow. आप कहाँ से हैं? कौन से hospital से? NESCOM. NESCOM is good. तो आपने observation किया का, फिर से बताएं क्या कहा आपने? Snow का pattern. Think back to like school days. बर्फ का microscopic pattern क्या होता है? Star-like crystals होते हैं. So it's interesting. This is a star-like weed, happens to be basically a star-like pattern, unrelated to the snow, but isn't that cool that it's a star-like pattern? So great job. Next slide. Okay. अब आपने, I have only a couple more slides left, don't worry. अब आपने काफी सीख लिया है इस पैराडाइम के बारे में. आपने psoriasis के बारे में सीख लिया है. तो psoriasis patient आएगा ना, next psoriasis patient, अगर उस psoriasis patient की variation है, they're doing something different to their skin, you will still make that diagnosis correctly. If you don't have the right diagnosis, what will you do? You'll think, यार ये क्या हो सकता है, right? So now, use the information I gave you and someone tell me what's going on this picture. क्या हो रहा है यहाँ? फिर से बोले, जोर से बोले. this is medical terminology here. There's a vast field. कहीं snow है, कहीं area of sparing है. Excellent job. आप कहाँ से? Penis Shifa, I knew it. MashaAllah. So anyway, so there's area of sparing. अब sparing क्यों है? Now you've made an observation. Now you have to have the hypothesis. भाई अगर बर्फ यहाँ है तो यहाँ क्यों नहीं है? यहाँ क्यों नहीं है? हैं जी? Whatever the reason is, कोई फर्क है या नहीं है? You agree? बर्फ तो एक ही पड़ी है, right? बर्फ इधर different तो नहीं पड़ी होगी, उधर different नहीं पड़ी होगी. But there's something different, and most likely it's that. तो what I found out was कि फसलें different लगी हुई हैं. ये जो है गेहूं लगा हुआ है, wheat लगा हुआ है, ये कुछ fodder लगा हुआ है for the animals. Okay, so it's different फसलें लगी हुई हैं. So that's causing the snow to be different. Isn't that cool? That's pretty cool, right? Next slide. Okay. Now we're going to do a test. Ready? I want everybody to look at these pictures. मैं आपसे सवाल पूछूंगा, and you have to just raise your hand. ठीक है जी? मैं आपको दे रहा हूँ 5 seconds to look at the picture, starting now. Everyone look at the picture. Okay. How many people see only 2 sheep? Raise your hand. 1, 2, 3. Okay. दो दुम्बे किसको नजर आ रहे हैं? 2. Okay. Thank you. Thank you for being honest. 4 दुम्बे किसको नजर आ रहे हैं? 4. 4. Everyone, keep your hands up, guys. 1, 2, 3, 4, 5. Okay. और 2 दुम्बे किसको नजर आ रहे हैं? 2. Sorry, 3. Okay. There are 3 sheep on this picture. Okay, guys. Actually, these are my sheep. I know that. So, देखिए ये जो हमारा जो lamb है ना, we raised her as a baby. She's a black sheep, the black sheep of the family. बाकी white है. ठीक है? तो if you weren't paying attention, you missed the black sheep. ठीक है? It's okay. You are doing your own assessment. That's fine. Now, are you ready? Next slide. How many goats are there? कितनी goats हैं? 2 goats, 3, 4? 3. There are 3 goats. But see how you, देखा आपने उस picture से कितनी जल्दी आपने decide किया, right? Decide किया. Didn't you make a diagnosis quickly? Yes? Okay. So what happened? What happened between the first picture and the second picture? हैं जी? आपने learn किया, experience किया. आप कहाँ से, किस hospital से? नहीं, आप किस hospital से हैं आप लोग? Pediatric Shifa. Wow, you guys are good. Pediatric Shifa is very good. Okay, so anyway, so you learned from the previous picture, you applied that principle in the second picture, yes? Yes? So that's, so मैं कोशिश कर रहा हूँ, I'm trying to develop a new brand to teach people clinical medicine through non-medical ways, to keep them awake. अब मैं आपको psoriasis picture दिखा रहा होता तो you've been asleep by now. मैं आपको दुम्बे दिखा रहा हूँ, ये सब जागे हुए हैं. रमीज पूछ रही है कि जिन्होंने 4 दुम्बे देखे थे वो कौन लोग हैं? उन्होंने काफी बिरयानी खाई थी लास्ट पे. All right, next slide. So anyway, just want to summarize the talk that when you're thinking about evolution, so you can judge me. Am I doing a good job trying to develop a new brand as a derm tracker teacher? ठीक है? Instagram join कर लें. You can see I post pictures all the time. मैं Kenya गया हुआ था last month, so I was teaching over there. So I took pictures of giraffe poop and I compared to gazelle, droppings to see कि क्या फर्क है. I was looking at different patterns कि giraffe का hoof कैसा. Anyway, so don't tell me, but be a judge for, am I beginning to make sense with these pictures I showed you, right? Am I like making, so find your passion and you'll have your brand before you know it. But you must think, aaj raat, kal subah, Monday when you get back to work, ye sawal puche, what is your brand? Do you like your brand? And do you want to change your brand? What do you want to evolve the brand to? And then remember, it's going to take you a couple of years to get there. ठीक है? दूसरा, start small. अब मेरे बेचारे followers हैं वो 150 होंगे Instagram पे. कुछ लोगों के 5000, आप लोगों के किसके 5000 followers हैं यहाँ? 10,000 20 देखें, right? But I'm starting small. It's okay. अभी शुरू किया है मैंने. Actually काफी अर्सा हो गया, but anyway. But you know, I'm slowly growing. It's okay. But I'm doing small successes. यार तस्वीर लेना बड़ा मुश्किल काम है. तो मैं तस्वीर ले रहा हूँ, आराम से brand बना रहा हूँ. But I'm patient. I'm going to take my time over it. Fair? And third one is, think about rediscovering yourself every few years because of the two reasons I showed you at the beginning. Number one, you're very smart people. Number two, you want to do many things together. To feed those two things, you got to keep rediscovering yourself. आजकल मैं clinically, I'm learning about scleroderma because I'm seeing more patients. तो मैं और पढ़ रहा हूँ, मैं और research कर रहा हूँ, मैं रात को papers पढ़ता हूँ, I look at research. I'm trying to learn about scleroderma because I'm fascinated by the disease. So I'm rediscovering my knowledge about scleroderma. I don't know too much. I want to learn more. All right, thank you for your attention. कोई सवाल है? सवाल तो नहीं है. Thank you. Professor Rao saw 4 sheep.
Thank you so much, Dr. Abrar, for interesting talk which kept everyone awake. So now I will invite Dr. Afza for the further proceeding of the sessions. Thank you.
Assalamu alaikum and good evening everyone. Welcome to the first PADCON last session. I am Dr. Afza Noreen Ghaus, working as a consultant dermatologist at Indus Hospital, Karachi. I will be the moderator of this session along with Dr. Iram Ashraf, who is consultant dermatologist at Institute of Skin Diseases, and Dr. Shakila Junaid, she is assistant professor at PNS Shifa Hospital. Now we are heading towards the last but the most important scientific session of the conference, the most demanded dermoscopy and skin pathology. We are honored to have with us Professor Dr. Babar Rao, who has traveled all the way from the US for this session. Before we move on, let me invite the chair of the session, Professor Azir Rashid. He is currently working as professor and head of dermatology department, Rahman Medical Institute, Peshawar. He retired from Khyber Medical University and Teaching Hospital as professor and head of department dermatology. He has over 38 years of experience in dermatology. Kindly, sir, come to the stage. Next, I would like to invite the co-chair, Dr. Arfan Bari. He is currently working as Associate Professor of Dermatology in CMH and Army Medical College, Rawalpindi. He has many publications and has authored around 200 articles and has also written chapters in various medical books. Dr. Arfan Bari, kindly come on the stage.
Now the speaker of the session, Professor Dr. Babar Rao. Though most of us have already met him as he gave a wonderful talk in the morning, but let me give a brief introduction again. Professor Dr. Babar Rao is currently serving as an acting chair and clinical professor of dermatology at Rutgers Robin Wood Johnson's Medical School. He is also an associate clinical professor of dermatology at Weill Cornell Medical College at Cornell University. He is the president and founder of Non-Invasive Diagnostic Innovations of Skin and the leading authority in non-invasive diagnostics, specifically reflectance confocal microscopy. The topic of his talk today is dermoscopy and skin pathology, so please give him a warm welcome.
Thank you. These two really have been working hard on many Zoom calls with me trying to organize this whole thing, and obviously Other is my very close buddy, friend, like family. And I was listening to Dr. Bari yesterday. It was a very, very wonderful talk by him on education and that. So, other, how much time do you have? I know there is a journal body meeting, so we have to, but I want to, you know, what we came for, but stop me whenever you want to. So, for dermoscopy, I was a fellow in dermoscopy many, many years ago when dermoscopy was starting. And at that time, or even now, when you have a clinical image and then you put a dermatoscope on it, usually there are many algorithms like ABCD, 7-point checklist, and extra, but usually when you are in the clinic and you have 2 seconds to look at a photo, you don't have time to apply all the formulas. So therefore, we started thinking how to make it simple for people who want to use it, and we came to our own formula. This I published, it's in my textbook everywhere, and I call it ASAP, which is a simple and practical approach to dermoscopy. Really, really simple. I think if you have 1 minute, I can finish this up. Basically, it is like there are common known patterns which are benign, and there are common known patterns which are not benign. And usually the discussion, melanoma, not melanoma, you can tell quickly. But usually there is a discussion, is it a pigmented basal cell or is it melanoma? But in this matter, it doesn't matter, as long as you biopsy. So if it come back a pigmented basal, big deal. If it's melanoma, obviously, either way you biopsy. So you just quickly look at these. These are, you all know, I'm not going to describe what is reticular, globular, reticoglobular, homogeneous, brown, patchy network, or any of these features. These are benign, no need to biopsy. Any of them you see, you biopsy. So simple. So in this one, absent pigment network, it's a brown lesion, and there is no network, so something is wrong. Then if it has arborizing vessels, then obviously that's a sign for basal, and you biopsy. Similarly, if you keep going, leaf-like areas, large blue, multiple gray lobules, spoke wheel area, this is all basal cell. And if you have a blue-white veil that we know it could be melanoma, so you cut it. Atypical pigment network, irregular pigmentation, multiple colors, regression, irregular streak, and parallel ridge. So this is it. So take a photo, or most of you know anyway, no biopsy, biopsy simple for dermoscopy as far as I'm concerned. We will also do some inflammations, hair, nail, which is a little different, but mostly for melanocytic, squamous cell, basal cell, this formula works all the time. I have published it. If you use this and patient have 220 moles, it still takes me not more than 7 minutes to look at every single mole if I have to. So very simple. We call it ASAP. You can look in the literature. It's published many places. So now here are the lesions, like 1 and 2. So which one should do biopsy? How do you decide? This happens whole day to us, whoever in the clinic. And then, so what if I tell you this is the lesion? So how many people want to biopsy this or just leave it alone? Leave it alone. Most of the people leave it alone. Now the next question is, this is how I'm going to do all of them. So we will have a picture. You will decide to biopsy or not. Then we'll see what was the feature which convinced us to biopsy or not. So why? Because it's a reticular pigment network and nothing else to it, and absence of any atypical features. So first we look, पहले देखें कि ये benign features हैं. Next you want to see if there is anything else to it. This has nothing to it. I call it beautifully benign, no need to biopsy, and we go to the next case. How about this one? Biopsy or not biopsy? जो मर्जी कह दें, it's not a test. Biopsy. Okay, so according to the formula, if you just look at it, it has many features that it should be biopsy, but let's look what features I'm talking about. So, asymmetric pigmentation, meaning pigment is different, hair is different hair. To my formula, it's already should be biopsy. But on top of that, we add multiple colors. So once you have multiple colors, forget any story. If you have light brown, dark brown, gray, blue, you should biopsy it. So based on simple formula, it has asymmetrical pigmentation, multiple colors, we biopsy. No question. By the way, you'll see some of this name. This is my fellow from Ukraine. Some of the photos she was preparing for me. Okay, so how about this one? Biopsy or not biopsy? Biopsy, I heard. So biopsy, why? Because if you go on same formula, it has many colors, at least that does it, but let's, what feature I highlighted here. So it will be biopsy, yes, because the pigment obviously is irregular from there to there to there. And then in the center, it has like scar-like areas, and one of my features is multiple colors. So in this one, we biopsy. We're going to biopsy. And by the way, if anybody thinks I'm wrong on any of these lesions, then raise your hand, talk to me, and we discuss why. How about this one? Biopsy or not biopsy? Good. So we are already like, at a point like you're learning that why this doesn't need to be. And when you say no, I'm going to ask you, give me why. So because just a globular pattern and there is nothing abnormal about it. So again, we saw a reticular network pattern, globular pattern, and then a couple of atypical patterns. How about, well, this is not dermoscopy, so clinically it looks like this. And dermoscopy will look like this. So no question, I think everybody would want to biopsy, yes? Yeah. So the trouble is, जब किताबों में आप दिखाते हैं ना, जब पढ़ा रहे होते हैं, so usually they give you thick nodular melanoma, which are easy to diagnose without dermoscopy. But what you need to learn is flat lesion, जो के are difficult. This is no question, has to be biopsied. It has everything you need for a bad feature. So multiple colors again, asymmetric pigmentation, and blue-white veil. This blue-white veil usually is part of melanocytes or melanoma in the dermis, with inflammation, melanophages, and fibrosis that gives you this color. So there's no question this is melanoma. Clinical and this one. How about this? Biopsy ke chhod dein. Okay. So biopsy, no biopsy. No biopsy. You guys know as much as you should know. But usually what happens is when you initially start learning dermoscopy, जब पहला कोर्स करते हैं उसके बाद जाके बायोप्सियां ज़्यादा होती हैं क्योंकि वो फीचर आपने पहले नहीं पढ़े होते. But slowly you get to a point where you know. So this obviously we said no biopsy, should be no biopsy. So basically congenital nevus with just globular pattern. I think they didn't put my features there. Sorry. How about this one? Let me show you the clinical first. Somewhere on the heel. We go on dermoscopy, which is this. So, photo is not great, but biopsy or not biopsy? Okay, so this is a little trick question, because what happened is you cannot see well, but this is like a homogeneous purplish color, and this happened to be, I think, trauma, but it will, maybe the photo was not good. Yeah, so no, because this is all hemorrhage. If you go on my original formula, it has irregular pigmentation, but this photo is not clear, but this is just a homogeneous purplish color, which is because of blood, so maybe a difficult lesion. How about this one, biopsy or not biopsy? Okay, iski mein dermoscopy, here it is the dirt. So this one, obviously, everybody will biopsy, and why? Good. So it has multiple colors, asymmetrical network, and milky white area. So everything you need for a bad lesion, it has it. As I said, agar in worst case scenario, let's say you say it's melanoma, you biopsy and it comes by some acral carcinoma, it's fine as long as we decide to biopsy it. So no need to fight about ke ye kaun sa nikal aaya. How about this one? Oh, the answer I already gave you, sorry. So this is the hemangioma or angioma. How about this one? Biopsy or not biopsy? Biopsy, and what are the features just to review? Arborizing vessel, is some globules, that's already plenty, so it may be a basal cell, maybe a melanoma, but that's already plenty to biopsy. Iski battery mu gayi lagta hai. Oh, sorry. So here then arborizing vessels, pigmented globules. So this translucent, this color obviously we classify basal, but let's say if you just had this, It may be difficult कि melanoma है कि basal है, but according to my formula, just biopsy it, whichever it is, as long as you biopsy, you'll be fine. So this is, I think, anyway, just on this biopsy or not biopsy. So it has those telangiectatic vessels. If you go on dermoscopy, biopsy or not biopsy? Okay. Anybody knows what are these little white streaks or white color other than the telangiectasia part? Okay, so these are arborizing vessel and white area. These are common in this one called something pincus tumor or basal type of a basal cell. White streaks we call them. हाँ जी, biopsy or not? So this is that one. Yeah, biopsy or not biopsy? So there are a lot of these branching vessels and then scar-like areas. It has more than, if it was just hemangioma, you wouldn't have these vessels running. So these vessels with the scar-like areas, according to our formula, it's already funky looking, so we should biopsy. What it is most likely, here we go. So then we have vascularization and these white structures. And this is actually, I'm pretty sure, was a fibroepithelium of pincus that won't have, because the basal cell is little, it's hyperplasia of the epidermis, basal cell usually in the end, small pockets. In between, usually there is fibrosis and telangiectasia. So anyway, biopsy. How about this one, biopsy or not biopsy? So look at what are these things, these little dots. There is a scale, but these little dots. Probably but blood vessels. So only two things have blood vessels if you're doing dermoscopy, like this dotted one. Either it's psoriasis or is it, let's say if it's a tumor, then it'll be AK or SCC. So psoriasis would have it or SCC, so if in a tumor you will know. So this happened to be, I think, AK or SCC because there is this scale. Psoriasis vessels are a little bit tinier than this. Sorry, I went backward. So basically this dotted blood vessel other than scale will give you a, if clinically it was a single lesion and I'm ruling out AK-SCC, this will be AK-SCC. But agar multiple lesion and somebody asking psoriasis, this could be differential, but psoriasis ki vessel I'll show later. They are dotted, but they are much more tinier and more circumscribed, well-defined. Okay, sorry, this jumped. Biopsy or not biopsy? Biopsy again. So features are atypical pigment and then multiple colors. That's already enough to biopsy. Irregular chaotic pattern, but that's we discussed already. How about this one, biopsy or not biopsy? I don't know what it is. We have mostly now one yes, so let's check it out according to our formula. So this is seborrheic keratosis, comedonal-like structure. There could be white-looking area or black-looking areas. It's a papule, it's raised. Rarely it could be a congenital nevus, but generally if you have comedonal-like openings, so it's a SK. Biopsy or not biopsy? So this is classic textbook melanoma on dermoscopy. So if you start counting, number one is multiple colors. Number two is irregular pigmentation. Number three is this blue-white veil. Number four is irregular, those streaks. So everything is bad. So just to review, what are the melanoma features are atypical pigment network, multiple colors, blue-white veil, streaks, scar like it has all of those. How about this one? This tricked me. 2-3 साल पहले ये मेरा केस था, but biopsy or not biopsy? Yeah, so this is, and in this case, agar sirf if we just have this one, and network is not clear, so is it basal cell, is it lichen planus like keratosis, is it lentigo malignal, will be difficult, but you have network here, so you can guess it is probably melanocytic, it has multiple colors, formula works, and it is a melanoma. How about this one, biopsy or not biopsy? Yeah, again, scar-like area, or they call it a veil, and this multiple colors, so again we're going to biopsy it. So we discussed that. Biopsy or not biopsy? So it could be melanoma, could be hemangioma, I don't know, let's see. So multiple colors, white lines, blue-gray wheal, everything, so we will biopsy it. How about this one, biopsy or not biopsy? No, it has multiple, at least one color, two color, three color, and then irregular pigment. Even if it comes back benign, it's fine, but we have to biopsy. Yeah. How about this one? Biopsy, so it has scale and it has some vessels. So it could be basal, could be squamous. There are only two choices, but we have to biopsy it. And features-wise, I'm calling these leaf-like areas, which is in which condition? Leaf-like in basal cell carcinoma. Basal cell has many patterns. One of them is this maple leaf or leaf-like areas in the periphery. But this clinically looks more SCC than basal cell. Okay, this is a common issue a lot in our patients in Pakistan, where they have a big brown patch on the face. What do? So differential diagnosis based on just, would be like lentigo pigmented actinic keratosis or lentigo melanoma. So then how do you decide? Still the formula works, multiple colors, number 1, 1, 2, 3, 4, 5 colors, good. But then there are additional feature, we call it a hole in a hole, okay, where you have adnexal structure and then in between you see little white area, but this is based on multiple colors is going off. This is a irregular thick pseudopigment network and multiple colors out, so lentigo maligna. Biopsy or not biopsy? Okay. So vessels we know, basal cell ki. How about this one? This is palm or sole. So you know those, even in United States, जैसे ही कोई lesion palm sole पे आते, everybody get worried कि palm पे है तो जरूरी कोई melanoma होगा. No, moles happen on palm and soles also and melanoma also. So if you have clinically lesion like this, let's see if I have a bigger photo. So this is called the parallel furrow pattern, where these lines are thin. And बोर्ड के लिए जो हम अपने स्टूडेंट रेजिडेंट्स को बता रहे होते हैं, furrows are friendly, F with friendly, and then just remember that. So but thin lines, which can have network, but thin lines, nothing to worry. And then at other point, how about this one, biopsy or not biopsy? Anybody wants to guess what it can be if they are guessing? G? So it could be basal or could be melanoma. It looks like some of those basal cell-like features. But either way, you have to biopsy, no choice. Ovoid globules, maple leaf-like areas, streaks, so basal. How about this one? This little the area. Biopsy or not biopsy? Nail pe hai. Maybe you cannot see, it's little reddish color, not really much otherwise. So it's trauma, this is blood. क्योंकि melanoma नहीं ऐसा हो सकता कि इतना sharply circumscribed और पूरा homogeneous area. So this is trauma. If you want to confirm, take a little blade, needle, scrape a little bit, you'll see blood coming off. Again, how about this lesion? Let's see if you have a dermoscopy. So biopsy or not biopsy? Okay, no biopsy, definitely no biopsy. Okay, so that was tumors. We're going to, well, we have inflammation, few of them, then here, and then something else. But in reference to melanocytic, keratinocytic, really that formula works all the time. You look at common benign patterns, which are reticular network, globules, and so on, and then you look, there was nothing abnormal, and then move on. You can diagnose in few seconds once you know it. Okay, going back to inflammations. So what is the diagnosis? There are only few possibilities. Let's say eczema versus psoriasis, which one do you pick? Eczema, very good. Eczema क्योंकि इसमें वो psoriasis की वो darted vessels है नहीं है. It has few areas here. Let's highlight it for you. So few darted blood vessel and punctate hemorrhages. So जो है ना, these are hemorrhages, so that is usually common in eczema. Eczema, as in histology and clinically, had types. You can have lichen simplex chronicus, you can have contact dermatitis with a vesicle, or you can have a subacute type. So this, if it's a subacute type, this is where you see those few hemorrhages and darted vessels. Agar thoda sa, if it go, how about this one? Psoriasis. So remember we saw a SCC or AK, that also had darted vessel like this, but they were much bigger, but they could look very alike. ये आपको clinical पे जाना पड़ेगा कि आप क्या ढूंढ रहे थे. So again, so these are a darted and a silvery scale, obviously, and darted vessels. How about this one? So again, this has scale, some serum, and not many darted vessels. There are a few vessels there. So what the eczema versus psoriasis? Eczema. So it's clinically eczema, it is eczema. How about this one? So these are some white streaks. So what is the clinical name for that? Lichen planus, yes? Lichen planus, okay. Why? Because those streaks are common. Then similar condition, but looks a little different. Oh, sorry, I already gave you the diagnosis. What about this one? It's a magnification of this white scar-like area. Anybody wants to guess? LSA, lichen sclerosis, yes. So I think most of the melanocytic, keratinocytic, and many of the inflammation, really you can guess as good as biopsy. Obviously lupus, those are difficult, but most of them you can tell. This is lichen sclerosis because this, they call it structure area, and milky, like milky pink color, little bit pinkish and then white mixed in it. The clinical image uski. Clinical, will move on. How about this one? So we did eczema, we did psoriasis, we did lichen planus, we did lichen sclerosis. Anybody wants to guess this one? So the color is a little more like, little different than, these are not darted vessels, this is not eczema ki jo thi wo serum crust. So anybody, this is a little bit more golden color. So this will be into one of the purpuras, lichen aureus, jo ke Schamberg purpura, all those can have that picture. So, sorry, let me go back. Copper red background pigmentation and these linear punctate vessels. So, but this color, clinical मैंने जान के नहीं लगाई क्योंकि आपको clinical का तो पता है. So I'm just showing dermoscopy, but this one has this copper red background pigmentation, जो could be pigmented purpura, lichen aureus, all purpuric eruptions. How about this? You all know this one. This redness around the nail fold, telangiectasia. So something to do with the systemic sclerosis as connective tissue diseases. Anybody wants to guess this? You see, like, wo kidhar gaye, jo Chamda hospital wale the, you see tons of this a whole day. But, scabies, okay. About ye chote structure hain ye wale, round, oval, like comedo-like areas. You see this whole day, and it's molluscum. So molluscum, you don't need to do dermoscopy, but for fun's sake, there are times when you have a single lesion, it doesn't really look like molluscum, you put dermatoscope on, you'll see these molluscum bodies ke jo groups hain. Okay, anybody wants to guess? पीछे से कोई आवाज आ रही? Yes? Okay, so there is a scale at the periphery. P. rosea, okay. All right, let's see. Anything else before I get the answer? Yes. Yeah, so porokeratosis, yes. because there are too many P. rosea की lesion इतनी साथ ऐसे नहीं होती, so too many round oval and you see the scale clearly. But poro के लिए you don't need dermatoscope. How about this one? Anybody wants to guess? Another type, basically scale at this point, which poro, but you see this scale going all around, porokeratosis ki. So that I just showed some example, the inflammations ki, so that you have some idea. Now hair and scalp, we have to do it. I'm jumping. So how about this one? Is it psoriasis or seborrheic dermatitis or what? Look at these vessels. These are not dotted vessels. Maybe they are, but they are not. And there is scale. So if that's the case, then psoriasis versus seborrheic dermatitis, what do you want to pick? Seborrheic dermatitis. And there I may have the markings, yes. A greasy yellow scale and arborizing vessel. Jaise BCC ki nahi vessels hoti, you will see arborizing vessels and then scale in comparison to this one, which has these different vessels and scale. So that will be twisted capillary groove with silvery scale. So they look like a little bit SEC AK type vessels maybe than the arborizing vessel of seborrheic dermatitis. So this is psoriasis. How about this one? Anybody wants to guess? So this scale which is going all along the hair follicle. Anybody? Okay. I think some of you got it. So lichen planoparous virus, empty, this empty area and then peripheral scale. If you see peripheral scale, it's pretty diagnostic for lichen planoparous. Anybody? I think this is just clinical. All right. How about this one? There is this erythema around the hair follicles, redness. Anybody wants to guess? So it's not seborrheic, not psoriasis, not lichen planoparous. Most likely lupus, some kind of lupus. So follicular opening surrounded by dilated blood vessels. So this redness is from blood vessels, and this you can actually clinically see very quickly. So Ellie was right. This is easy. The explanation here is alopecia areata. Okay. So I'm going to skip the dermoscopy. Anybody have a question? Obviously I killed it because general body hai, so I moved fast. I'm going to go to skin pathology. Anybody have a question related to what I said in dermoscopy? How many people use dermoscopy in the clinic? So our tragedy is if we teach resident dermoscopy very well, then we lose business-wise because then they don't do biopsies. So wahan pe we have different kind of issues. Okay, you teach them so well that they're not doing biopsies, so you lose on the business a little bit. But really, jaise idhar situation hai, itni biopsy nahi hoti, dermoscopy obviously you should learn as much as you can. And most of the situations you can solve very quickly with the dermoscopy. So do we go this to, can you go to the next topic? Yeah. So I'm going to do, jaise meri hai na, a simple and practical approach to dermoscopy. I also have a very simple approach to skin inflammation in histology, which I do every day before I go to next topic. So every day I sign about 250 cases of skin pathology. Sign outs are live digital on my computer. So if any of you are interested, please shoot me an email. I can put you in the list. Or jo Pindi people, some of the Pindi people are here, or other cities, they are logged on to just look at fresh cases as I'm signing. That you get a Zoom link and you can look at it. So for me, skin pathology or for the reason whole medicine, usually you can easily divide them into two, tumors or inflammation. And inflammation means there could be inflammation, infestation, all kind, but tumor or inflammation, and we're going to talk about inflammation mostly in skin pathology. So first of all, before I even go to inflammation, some of you may be very young in dermatology. We'll go to some definitions. So when the epidermis is thick from there to there, what do we call it? Hyperkeratosis. So when it is thick from there to there, what do we call it? Acanthosis. And when you see nuclei stuck in the stratum corneum, we call it parakeratosis. So koi bhi pathology ki report dekh lein, they will discuss that, like hyperkeratosis, parakeratosis, acanthosis. So we should know what does that even mean. I'm sure you all know. What do we call this? Obviously I have written on the top. This is called spongiosis. And what does spongiosis mean? Okay, so there is fluid and it can even make a blister. But initially it may not be this much. It may be just increased spaces between the keratinocytes. So just white areas. Thoda se bhi nazar aa jaye, we call it spongiosis. Then this could be, let me just keep, how about, well, this is written on it. So this is another common term we use, acantholysis. Acantholysis means that keratinocytes have lost their connection with surrounding keratinocyte and they're just floating. So acantholysis, and this is called dyskeratosis. Dyskeratosis means that keratin is supposed to be in stratum corneum. If you see it here, that means something is wrong, so we call it dyskeratosis. So as we move into this discussion, if you have acantholysis alone, then differential is pemphigus and pemphigus family. If you have dyskeratosis with it, then we have different differential. So we'll go into that in a minute. So just acantholysis. And then this is another term we're using whole day, basal cell degeneration. You see these little vacuoles, and we should know that term. And then if we go into blister, the blister can be in the epidermis, as you know, or it could be under the epidermis, subepidermal. So now I have introduced few terminology, and I'll use it in my approach, and we'll go step by step. It's a huge topic. Obviously try to compose it in 30 minutes or so. We will try to do it. But what I have usually done is I divide them into epidermal, dermal, and subcutaneous to simplify it. And then the epidermal one, I further divide them into like 3 main categories: subcorneal, intraepidermal, subepidermal, and interface. So we'll go through them one by one. And if you want this lecture, obviously PAD has it. You can get it for you. So subcorneal. And if you go in subcorneal, then what are subcorneal? You know, impetigo, candidiasis, superficial pemphigus, and pustular psoriasis. So those are, there could be other like AJAP and other choices, but mainly if you think inflammation stuck in the stratum corneum or under the stratum corneum, these are the 4 choices, nothing more than that. And if you do that, here we go. So collection of neutrophils, some scale crust within the stratum corneum. And then if you want to see is it candida versus impetigo, you will do a gram stain and you can quickly determine that. If obviously you do other fungal stain, you see candida. And if you see acantholysis superficial, then it will be superficial pemphigus. So just focus. Subcorneal inflammation or in the epidermis, only 3 or 4 choices: impetigo, candida, maybe pustular psoriasis, or superficial pemphigus. So here is the pustular psoriasis. Now what if we go to my next category, still in the epidermis, we say acantholytic, my most favorite topic. Acantholytic we already discussed. Acantholysis means keratinocytes have broken their connection, and this one is when all the keratinocytes are breaking apart, we call it a delapillated brick wall, that all bricks are breaking, and this is classic for Haley-Haley. If it is focal with acantholysis, then it could be Grover's. And if it is like widespread like that, it could be pemphigus. If we're staying in the epidermis right now. Now, how do we decide then? Again, I was saying, number one, you have to find acantholysis, which is this. And you have to find dyskeratosis, which is this. And if you have these two, is this picture, the only two choices really, Grovers or Darriers. Then you go on clinical, Grovers, Darriers, that you can tell. And there are some keratin markers you can do, but usually it's all clinical. If anybody have a question why I'm calling it Darriers here? Because we have acantholysis and we have dyskeratosis. Dyskeratosis, one more time, abnormal keratinization lower here, and classic for in this situation. Going into next category, so we have done subcorneal, we're doing intraepidermal, we have done acantholysis, we're going to spongiotic. Those are easy, all the eczemas. So again, we did spongiotic, there is a vesicle, there is all that. And then going further, it could be atopic dermatitis, could be chronic, and then an acute episode with blisters. Again, and then it could be seborrheic dermatitis. Only way you can tell something is seborrheic dermatitis, other than being in the locations, that it will have little bit neutrophilic abscesses like psoriasis, but around hair follicles. So going to my papillosquamous. Well, it's written on there, so this is PR, pityriasis rosea. How do you diagnose PR? Is number one low power sign is hemorrhage. If you see hemorrhage can be in the dermis because of your trauma or whatever, but if you see hemorrhage going into the epidermis like here, then there are really only three diagnoses. Is it PR, plava, or maybe some kind of vasculitis? There is no third diagnosis. So for PR, why it is PR? Because you have hemorrhage going up, and then you have mount of focal parakeratosis. Classic. Otherwise, it's subacute otherwise, but it has hemorrhage and have focal parakeratosis. Psoriasis, classic, everybody should know psoriasis, obviously you all know. Classic is based on number one diagnosis you made from neutrophilic abscesses. If you see them, you are done, but with that you should have hyperplasia, dilated blood vessel, parakeratosis, hyperkeratosis, and usually you have hypogranulosis in psoriasis. This is boring. Parapsoriasis diagnosis clinically mean you're thinking MF, but it's not MF. Histologically, it's the same thing. Okay, it has some fibrosis, something, but no atypical cells, so usually not diagnostic. This one, obviously, it diagnostic. So remember, first of all, this is an inflammation which is a little wedge shape, and then have some epidermal necrosis. I think some of my slide went upside down. Will come back. Now the reticular degeneration, usually it could be herpetic and non-herpetic. In reticular degeneration, the number one thing really is you see this network-like breakdown of epidermis, the thready networky, and then what are these cells called? You all know, yes, no? Zank positive cells or giant cells in herpes. They could be in any herpetic infection we'll have is zoster, shingles, simplex, chickenpox, monkeypox. Actually, this is a case, my fellow is not, we published in JAD. This was maybe the first clinically and histologically and lab-wide diagnosed of monkeypox in Manhattan. Patient walked into our clinic and we were brave enough to do biopsy and the test. He had monkeypox. So again, giant cells in the epidermis with reticular degeneration. Let me go to, so we are in this reticular degeneration, which could be with giant cell, without giant cell. This is the case of ORF, but main thing is reticular degeneration. Case of Milker's nodule. So I know you're getting a little bit lost in this. So just keep in mind subcorneal, intraepidermal, epidermis. In the epidermal we have few choices, and then subepidermal is inflammatory, non-inflammatory blisters mostly. So when you have a subepidermal blister, what you want to see is what is the type of cells. If you have eosinophil, it's pemphigoid or HG. If it is With neutrophil, this is classic dermatitis herpetiformis, papillary myproexa, meaning subepidermal blister with neutrophil. So if it's with eosinophil, it's pemphigoid or HG. If it's neutrophil, it's DH or linear IgA. This also will have neutrophils. Now, what if it's a boring, dead-looking blister? Then it could be either EBA or it could be porphyria, where you also see this festooning. So, very simple, subepidermal blister with EOS, pemphigoid or HG, with neutrophils, DH or linear IgA, no inflammation, or maybe few lymphocyte, EBA or porphyria. So, there are only just 4 choices. So, going into the last category of epidermis is lichenoid, non-lichenoid, and this usually it's going backwards. So, usually when you get, this is the most serious thing in dermatology. Is it EM? Is it Steven Johnson? Is it graft versus host? Is it like lichenoid drug? And so it's good that if you spend few minutes focusing on that, how do you solve that mystery? So most, what we call interface mean that there is inflammation in the epidermis which is attacking the basal layer, and there may be vascular change. Once you determine that it has interface change, then next thing is to think lichenoid or non-lichenoid. Once you think lichenoid, then only really 2 or 3 choices. So this is, in this case, is lichenoid, it's lichen planus. I mean, you know features of lichen planus like hypergranulosis, sawtooth, acanthosis, but basically lichenoid. If in lichenoid you see other types of cells such as eosinophils here, then it probably could be lichenoid drug reaction. If you see a lot of plasma cell, then it will be syphilis or maybe syphilis. So you have lichenoid. In that with EOS, it will be drug, lymphocyte lichen planus, plasma cells obviously syphilis. Now, what if we go to non-lichenoid? That's where the trouble starts. Non-lichenoid, again, non-lichenoid mean that it's perivascular, but there is interface change, but in that then you find eosinophil is most likely will be a fixed drug. Now, but I'm basing this interface based on lichenoid and non-lichenoid and then type of inflammation again, EOS versus others. Now in this case, again, it's a high power view of similar change. How about this one? So remember erythema multiforme, I have half cut off there. Erythema multiforme falls in this understanding as perivascular, but with interface, no EOS. So easy to diagnose. Differential diagnosis in this could be graft versus host can do that in a given case if the history is right. And then what about if it is still perivascular with interface derm, but there is follicular hyperkeratosis, so diagnosis will be what? There was some lupus person sitting here, so DLE most likely. I'm going to skip this one. So this is, we just finished the epidermis. Are we bored, tired? Should I stop or do the other 2 parts? Okay, continues. Okay, so anyway, this is a lot to absorb in 20 minutes, but just my whole wish is that you have a concept in ko approach kaise karna hai. And my approach for whole skin inflammation is you divide them into epidermal, and epidermal you divide into these 4 parts, very simple location wise, and then you go into these categories, and I think you can try to make sense of the report. So now if we go to dermal, again dermal inflammation, Dr. Ackerman wrote a whole book on it, but if you want to simplify, I usually do it superficial and deep. That's the first part. And then we have granulomatous, vascular and others. So if we go to first part, which is superficial. In superficial again, I divide them just into which type of cell, like one type of cell or many type of cell. If you have many type of cells, like this one, there is some lymphocytes and there are some eosinophils. So most likely it could be a drug reaction because it has it's superficial, it has EO and perivascular, so most likely drug. Then if you see perivascular neutrophils, then it could be most likely a allergic urticarial eruption. If you have then sometime pemphigoid wouldn't make a blister, but it will have eosinophils lining along the basal cell layer like this. So what if it is just monomorphous? That's the most boring histology. It will be perivascular, lymphocytic, nothing else to it, most likely viral exanthan, or they can do that, but say difficult to diagnose that way. But if it is eosinophils, obviously you'll think drug. Now, at this term I don't use my dermal contact. I think, what if it's superficial and deep? So again, in superficial and deep, again you're going on the cell type. Is it single cell type or multiple cell type? If it's superficial and deep and it has many eos, then you're thinking insect bite. If it is, again, differential will be scabies. And what if it is monomorphous and it is superficial and deep? Then the differentials are gyrate erythema, Jesner's, and all those. What if it has just lymphocyte and edema there, then it could be PMLE. So, if you go to the next group, so I divided them into, again, superficial and deep, and superficial polymorphous, monomorphous, superficial and deep into polymorphous, monomorphous. And then we go to granulomas. And granuloma, again, we have certain types called palisading granulomas, which is, palisading means you have histiocytes surrounding an area of central collagen degeneration. So these are histiocytes making this palisade. If you see that, classic is granuloma annulari. If you see many layers of that, then it's usually NLD. And if you see it's palisading and it's a fibrinoid necrosis there, then it could be rheumatoid nodule. Or if you see this empty white crystal, it could be gout. So palisading granuloma, classic type GA, next type NLD, and then if you see fibrinoid, then it's rheumatoid nodule. If you see this crystal, it's gout. But all of them have this palisading granuloma. What if it's sarcoidal? Sarcoidal means you have these epithelioid macrophages, granulomas, without much inflammation around them. So, but if it is then necrotizing, that classic necrotizing is TB or tuberculoid granuloma, where you have central necrosis, then neutrophil, then lymphocyte, different than sarcoidal, different than palisading. Differential is huge, TB to leprosy to rosacea to everything else. This is a necrotizing granuloma, which obviously mycobacteria. Rosacea can do that, but then you will know it clinically, which could have necrotizing granuloma. So these one really easy. Palisading at granuloma annulari, NLD, rheumatoid nodule, and gout. Sarcoidal, mostly sarcoids and other foreign body, and necrotizing TB and leprosy, and sometime in rosacea you can see that one. Vasculitis is a big, vast topic, but if you have to just make it simple, it's small vessel versus medium vessel or large vessel. So if it's small vessel, it could be just lymphocytic. If it's medium vessels, like in polyarteritis nodosa, but main change is the damage to the blood vessel with some leukocytoclasia. If it's large vessel, it could be giant cell arteritis, temporal arteritis, and so on. But the main change is, like, you have to see there is damage to the vessel wall with neutrophils and lymphocytes around there. Then the last one is like sclerosing, fibrosing. In that I have morphia and dermatofibroma and couple of those. I'll just go to morphia, others are not relevant. In morphia, number one thing, you have lot of collagen. Number two, you will see the adenosine structure pushed way down or maybe missing sometime, and just a lot of collagen and sometime inflammation. This one is, one of them is lichen sclerosis atrophicus, which is basically papillodermal fibrosis, and otherwise nothing much. A keloid, you know, they can look like that, obviously. So the last one is deposition, when things come from somewhere else. Amyloid, sometime you'll miss it quickly if you're not focusing. If you do PS stain, Congo red stain, you'll see it better, but homogeneous pinkish bodies in the papillodermis. You can have deposition because of hydroquinone we were talking, or achronosis. Obviously, you can have tattoos, and you can have lipoid proteinosis, which is lipoid proteinosis and amyloid look very clinically, histologically very similar. So you have to go to clinical. So I think next part is ending with the subcutaneous part, and then usually we divide them into septal and lobular. So this is very temporary classification, but in the books this is how they talk, this is how we talk. So primarily in the septal you will have erythema nodosum, and septal means these are fat lobules and inflammation is just in the septa here. This always spills over a little bit, but and you can have joint cells, so this is erythema nodosum, septal. And if you go into the lobules, there are many types of lobular, but it could be sarcoid, and it could be traumatic fat necrosis, which is attacking primarily these lobules. And it could be then lupus profundus, which is again primarily lobules. It could be pancreatic fat necrosis, primarily lobules. And even when I took board, me and others took our exam in London, even at that time they were asking, and this is still a very popular question in every single exam. So panniculitis, different types, erythema nodosum, pancreatic fat, traumatic fat, all of them you have to really, each one of them you may forget where you are, but they have buzzword like ghost cells and crystals, so you have to memorize that, otherwise you can't diagnose them. This is nodosum leprosum here with the granuloma. So I will stop here for a minute, and then I just have like 10 cases for you guys which you will diagnose. But I know it's a lot to cover, like my approach to skin pathology just, in this time. But I welcome all of you to join sign-outs, which I do every day live, and you can learn more. Before I show the next 10, 15 cases, anybody have any questions? Okay, we go to the cases then. Can तीसरी वाली, if I have it. Whoever did hold this job, by the way, it's beautiful. The organizers जो हैं इसकी PAD के. So I don't know how many cases do I have. Just let's see if I can do it myself. Okay. What is the diagnosis? Anybody wants to guess? So there is a blister, there is some inflammation. So what are the possibilities? It's in the epidermis. Somebody said pemphigus, I guess it could be, but you have to find some acantholysis. क्या था? Sorry, मुझे नहीं आवाज दी. Some kind of spongiatic, okay. So acute contact, good. So let's go back. This is important. So obviously you can, acantholysis you have to find. If you don't find acantholytic cell, then it can be pemphigus and that family. So this is an acute contact dermatitis with big blister, but if you don't find acantholysis, you don't find acantholysis. Let's see if there is a histology somewhere. How about this one? PR. So we discussed that. There is amount of parakeratosis and some red blood cells going up. Otherwise, PR is subacute spongiatic dermatitis. What makes it PR is hemorrhage and then this amount of parakeratosis, which is focal. So you don't need the clinical, you don't need the histology. some board, relevant things. How about this one? This was my case. So now let's go back what I was trying to teach. So this looks lichenoid. There is some perivascular too, but yahan pe this is lichenoid. And if it is lichenoid, then remember we were thinking we have to look for cell types. So if you find lymphocytes only, then it's some kind of lichen planus. If you find eosinophils, then it's lichenoid drug. And if you find something else, then it's some, let's see if I have a high power. I don't know I have a high power. Here I have. So if you can focus here, a lot of these cells are ampered like a peripheral cytoplasm. So let's say these are plasma cells. Then it is syphilis. And so going back, here, if you send me this slide, I will not call it syphilis. I say some kind of lichenoid inflammation. Give me some clinical, but if I'm lucky and I find plasma cell, then I'm going to say, okay, maybe this is syphilis. That's what exactly I did. I saw this histology, and then they basically send me the clinical. The clinician jisne bheji thi. Then we did blood tests, they were positive, then we treated, but basically lichenoid inflammation with plasma cell, now you will remember. I'll see if I have another case. All right. Who wants to guess this? This one I did not show you, but let's struggle. So it's perivascular, and there is some inflammation. There are some bigger cells here. Anybody wants to guess? This one here, this one, there are many small cells. And these are not neutrophils, most likely lymphocytes. Any guess? Okay, so eczematous, some kind of, because I have hyperkeratosis, parakeratosis. Lymphocytic mostly, no eosinophils and other things. These are some red blood cells. Then these cells are moving into the epidermis. Let's see, I have a high power. Handy? MF. This is MF. Like I may have another photo here. So obviously this is big, large cell, but these are those collections we call Portrait abscesses. And remember, Portrait abscess mean neutrophil, but in MF those are not neutrophil, those are abnormal lymphocytes. So there is a little Portrait abscess. This is a very abnormal lymphocyte. There are many now, but it could look like spongiatic dermatitis, but you have to focus and see if there are no abnormal cells. I'll see if I have another relevant case. This was the clinical. All right. So again, I showed one of these cases. So anybody, so this is perivascular. So we remember we did, this has interface, and interface means inflammation along the basal cell layer which obscuring the dermoepidermal junction. At this power you cannot tell, but maybe there is vacuolar change. So this is interface dermatitis. Now if it's in DLE, perfect. So, but the way I was approach is it's interface, it's not lichenoid, so lichen planus is out and lichen planus family is out. Then it is perivascular interface, first type you should think lupus, but perivascular interface obviously could be other things as we were talking earlier. So follicular hyperkeratosis, and this has vacuolar degeneration, so this is lupus or DLE, lot of vacuolar degeneration. This I do a board case for dermpath boards every year. These cases are from there. Okay, now, and this case we already went through. Anybody wants to guess what is going on here? So there is something happening here. So it is something in the epidermis, okay? It's not subepidermal, something in the epidermis. Next question is it just like a vesicle, or we see some acantholysis? Maybe I have a high power view, I'm not sure, but let's check. Yeah, so there is, now we have it. So these are acantholytic cells, pemphigus, but there is look like, this could be just a scale crest, but look like there is sub-abnormal keratin or abnormal. So it could be Darier's, or it could be Grover's, but it looks too inflamed for that. But basically, either it's pemphigus or Darier's because it has dyskeratosis. As long as you have those two, then clinically at least you can give them a differential. This is Grover's, by the way. So I put this chart intentionally. Once you are in blistering disease, how do you move forward? This you all learned in your FCPS, MCF, house job or daily life. But basically you can, use this chart to your benefit. How do you go further once you have the, a blistering disease in the epidermis? I'm seeing if I had a high power or not. I don't, so I'll skip the case. Okay, what does it look like? Somebody said DLE? Morphia. So the only choice really is either it's a scar, fibrosis, or it's morphia, because there is nothing in the epidermis, no interface, koi deposition nahi hai, kuch nahi hai. So either it's something we don't know, or you can guess it's morphia scleroderma. So what happens is sometime in morphia, jo initial cases hote hain, even clinically, they look very red and very juicy. So initial stages of morphia can be very inflammatory. So similarly, histology may not have this much fibrosis. Initially, you'll see a lot of perivascular inflammation and early fibrosis. But this is morphia scleroderma. So I'm skipping those questions. Okay. So I did not show this case today, but we are in the dermis. So it is not an intradermal problem. We start looking at it, we see many giant cells or something like giant cells. Then there are some foamy looking cells. So anybody, it's a tumor, anybody wants to guess? Ji? Mujhe nahi samjh aayi. So it could be the really true differential, either is the xanthogranuloma or there is another one called reticulohistiocytoma. But there's only two differential, but they look like are like two-ton-like cells. So juvenile xanthogranuloma. Let me go back. Multinucleated cells and then foamy cell, and there are a lot of them. So iske teen hi differential honge. Either it's JXJ, juvenile xanthogranuloma, reticulohistiocytoma, or sometimes AFX, atypical fibroxanthoma. But that one usually do not have these kind of two-ton giant cells. So how are we doing with time? Okay. I'll stop in 2 minutes. Yeah. I know there is an important conference waiting. This, let's see if I have high power or not. I was wanted to show that reticulohistiocytoma, but high power hai nahi iski. Koi last photo and then we'll stop. If I have a photo. These are mostly non-photo cases. I think we'll update, I did a file update, it didn't get it to you guys. So I think we can stop here and just take the questions, it's okay. Ji. Mike, is, maybe they want, yeah. So obviously, I was trying to cover a lot of stuff in 1 hour, but it takes 3 years residency to do all those.
Hello, can you? Babar, I'll start with the first question myself. I mean, Babar I've known since 1984. So, I mean, how do you feel since 84, 38 years? How has dermatopathology evolved, and what changes have you seen, and really what's your opinion? I mean, from those days of Edward Wilson Jones till now.
Yes.
Well, how would you really sort of,
So the way it is changing is not like eczemas are still eczemas, but like new things obviously are, one is in at least United States and many other companies who have, countries who have resources, we are slowly going into non-invasive diagnostic. One example is dermoscopy, but uske baad then we have now confocal microscopy, which you put it on the skin and you can see the cells as good as histology, but just in black and white. So for most melanocytic, most keratinocytic, most like diseases, I can use confocal, which we have a lot of them, and we don't do the biopsies. Then, नई अभी चीज आई है ex vivo confocal microscopy and similar tools like that, especially for cancer. You cut the tissue, जैसे fine needle aspiration करते हैं ना, you cut the tissue, you don't need to freeze it like frozen section. You put it on the machine and you see it right then and there, and gives you an H&E right there. Pseudo color होते हैं digitally, but you put it on the machine and you see colors right and then, and you can go finish. So जो Mohs की technique है कि freeze करो, ये करो, वो करो. So ex vivo diagnostic and then non-invasive diagnostic is changing pathology in a way that there will be less biopsy and more non-invasive things before you cut. Histology itself, really not a major change. Only thing is, I think in few years' time, most of us, I already do for last 3 years, all my histology is all digital. I don't touch a glass slide anymore. They scan it for me wherever the lab is, and then I see, I have a link here in my phone, we can check now, and basically you go click, click, and sign it digitally, which is really, it look like if you do it digitally, you may lose some detail, but actually not. Because whatever is in front of you, already focus, aapne usko adjust nahi karna. So digital pathology, non-invasive diagnostics, I think, is coming in pathology. Yeah. Dr. Badr. Ji.
First of all, I must appreciate that it was a very enlightening marathon presentation. But I think you made it very simple for all of us to understand the dermoscopy and the histopathology. Unfortunately, in Pakistan, this dermoscopy is still in infantile phase. I mean, I remember that when I saw the literature, in 2009, there was a first editorial written by Professor Ijaz in JPAD on dermoscopy. Mm-hmm. And I think after that, in whole decade, there was nothing written on dermoscopy. Mm-hmm. No published data. There was extreme dearth of published data on this dermoscopy. Although it's a very important, non-invasive, relatively cheap diagnostic tool that should be included in our armamentarium, diagnostic armamentarium. And this should be regarded, this should be taken as a stethoscope of dermatologist. Because we can avoid so many invasive things if we are using it regularly. So here I was glad to see the correct responses from the audience.
No, they were good.
That happened to be my students in PNS Shifa, because here I would like to share my experience. How did we started it incorporating dermoscopy in our routine training and routine clinical practice. So I think we were having a dermoscope in our department. It was for many years and it was not being used. So one fine morning, we conceived an idea, why not to use it? So who will be using it, how it is going to be used? So ये सारी चीजें जो थी वो nobody was knowing. So what we did, so I chose few of my trainees, 3 or 4. I think they were pioneer in that was the pioneer team, and we thought that we distributed something basics about the one was distributed about the basics, and one was allotted that he or she must know all the details of dermoscope, and then the use in melanocytic lesion and the non-melanocytic lesion, infective lesion. So we spared 1 week. We called it a dermoscopy week. उसमें हमने daily 1 hour का एक tutorial, एक lecture इस पे रखा. So we covered almost the basic concepts of dermoscopy. Then we started using it. And after using a couple of months, then we had a 1-day workshop, hands-on workshop. उसमें फिर हमने invite किया अपने सारे trainees, PGs from the surrounding institutions. So that was a very wonderful experience, और उसमें सबका बड़ा enthusiasm था, और सबने उसमें खुद hands-on करके learn भी किया how to use it. Then there was so much pressure on it कि जी इस तरह की और workshop करें. So after 6 months we had another workshop. So then we started giving this projects to our trainees. जो उनकी dissertation के topics, the articles, research articles, उनमें जो comparative studies जो हैं, histopathology versus dermoscopy, infective lesion, inflammatory lesions, benign lesion और malignant lesion. तो इसमें I was glad to see कि वो जो हमने एक पौधा लगाया था उसका after a couple of years, तो we have started getting response कि हमें अभी जो है ना I have seen few of the articles that have come up in the literature recently. तो हमारे इसमें और दूसरा ये कि few I think many of the articles they are still in pipeline. So I would like I would take this opportunity कि यहाँ हमारे जो head of institution हमारे senior लोग बैठे हैं तो they should also take this initiative to start this dermoscopy in their institution in routine clinical practice as well as in it should be a part of curriculum also.
जी just to जो दुनिया में जो number 1 expert है ना dermoscopy का me and him were fellow together same time. I went into more pathology. Ashfaq Margoob, he's from Pakistan, his father is from Pakistan, so he's the number 1 specialist in the world, and then I'm the number 20th specialist, but still both are from Pakistan.
Let me add something about Baba Rao. He's been very humble. We were together at St. John's in '84, and at that time we've heard about Lever and Ackerman, and they used to be a godfather of our guru of dermatopathology, Edward Wilson Jones. And at times Baba used to make him rethink about the slides.
Yes.
So a person like Edward Wilson Jones would have a second look at the slides after Babar's opinion.
Yeah.
So this is sort of something which is not mentioned.
But thank you everybody. Like as I said, students, residents, whoever, if you want to learn, join the learning, just shoot an email. Sadia and this team has the emails. And if seriously more than that, if I know Badr was talking yesterday also, like, so you know more clinical than America, end of story. ठीक है, clinical आपका बहुत अच्छा है. Where we're lacking is, and most of you have done actually more treatments than I have done, but lacking is the publication part. So I seriously encourage छोटे-छोटे project करें, publish. अगर आपने 500 case देखे हैं, publish, and that's how then younger generation will write more. So, and if anybody is interested, I actually have virtual fellows. Right now I have 11 of them from different part of the world. Some of them come with me, other are virtual, but the only way they get accepted is if they first prove that they are hardworking people. So anybody is welcome if they want to join, contact through this research or education. Thank you. Thank you. Thank you.
Any questions? Thank you very much, Babar. Excellent presentation and a very sort of informative one.
Thank you.
It is a very informative session for all of us, and we have learned a lot, and thank you so much. So we are ending with the Baba Rao's presentation, so thank you so much.